Ladies and gentlemen, dear speakers, dear excellencies, dear friends, dear GCCCF community, I'm very happy to welcome you to our Global Clinical and Care Coordination Forum, the GCCCF conference, CARE 2025. In these times, one word is very important. This word is solidarity. This is what we are representing today around the world in our conference, solidarity. In Corona times, it is very important to coordinate medical care, but even more, one aspect is also very, very crucial: prevention. The crisis shows that our mindset was not focused on prevention. Now, we are focusing on prevention. Prevention to realize healthy active aging, prevention to make sure that healthcare system worldwide do not collapse, prevention to avoid economic burden, prevention to avoid tragedies in our families. Chronic diseases like diabetes, cancer, respiratory diseases, and cardiovascular diseases, which may lead to stroke, are the biggest cost drivers and the biggest tragedies. Here I'd like to emphasize that prevention needs to be coordinated as well. So, how can digitalization and e-health support this? Here I would like to quote my dear friend Chai Chua, the former Director General of Health, Chief Executive of Ministry of Health New Zealand. He said, "World-class cool technology should always be in warm hands of a person with a caring heart." How can industry, universities, doctors, nurses, medical technicians, IT specialists, investors, and governmental bodies play a role here in the context of innovation and policies? In my more than 30 years of leading healthcare transformations worldwide with multinational corporations like Siemens, IBM, Ascom, Preventicus, and others, I'm very thankful to be always supported by a great community of thought leaders, professors, physicians, ministers, and policymakers. For all who do not know me so far, I'm Ljubislav Matejevic, the president and founder of the Global Clinical and Care Coordination Forum, the GCCCF. I graduated as an electrical engineer in Berlin and did my MBA at the University of Warwick. The GCCCF is the platform for interdisciplinary collaboration between care providers and payers, academic, politics, and industry. As part of our work, we run an international program of thought leadership roundtables globally. In the last year, we performed our GCCCF roundtables in London, Paris, Dubai, Warsaw, Moscow, Belgrade, Copenhagen, Hamburg, Bucharest, and Krakow, as well as our annual conference CARE 2025. Our GCCCF LinkedIn group consists of more than 5,500 healthcare stakeholders worldwide. In these times, it's even more evident that the survival of human being is dependent on a vital healthcare system. In the on-site roundtable a few weeks ago in Dubai, one speaker emphasized that in these times we get an overstimulation and attention flood with all the web meetings and online calls. From one side, we need to avoid the white noise. From the other side, this is for us the only one opportunity to be together currently. The GCCCF community never stops working on the necessary transformation of healthcare delivery. Even though I know we are not alone, I sometimes feel alone. I miss our in-person meetings. Nevertheless, I'm glad that you all joined now. Ladies and gentlemen, as the president of the Global Clinical and Care Coordination Forum, the GCCCF CARE 2025, I declare for open and I will lead you through the conference program today. Please enjoy. I'm looking forward for a very active cooperation, comments, questions in our Today YouTube channel, as well as on our LinkedIn event page. My team, which is here around me, will monitor your comments, postings, questions, and will bring them to our digital stage. Our day will be structured in 3 parts. Part 1 is from 9:30 to 12:30. Then we will have a 1-hour lunch break from 12:30 to 1:30. We will come back at 1:30 sharp. Part 2 will be from 1:30 till 3 o'clock, followed by a 30 minutes coffee break. Part 3, we will start 15:30 sharp and will end at 5 o'clock in the afternoon. I visited Dubai first time in 1999, and since now in 2020, Dubai and the entire United Emirates went through an amazing development. His Excellency, Dr. Amin Al-Amiri, the Undersecretary of Public Health Policy and Licensing of the Ministry of Health and Prevention of the United Arab Emirates, will speak about the future of healthcare in the United Arab Emirates and the advancing health innovations. Your Excellency, dear Amin, thank you to be with us here today. It's your stage. Okay. Das würde funktionieren. Chai, you're ready. His Excellency is not ready. Okay, das würde funktionieren. Okay. Ladies and gentlemen, I just hear from the regie that His Excellency is not there. He will come a little bit later. So let's go forward with Chai Chua. So that's another impressive country which has done an impressive healthcare transformation in New Zealand. I'm still remembering a very well tight cooperation with my dear friend Chai Chua. He will touch and envision the future of healthcare post-COVID-19. He is the former Director General of Health, Chief Executive Officer of Ministry of Health of New Zealand. And he is the founder of Healthcare System Transformation Limited. Dear Chai, thank you for your time and your support today. I know it's very late at the other end of the world. Even it is very, very late, you're with us here. Please share with us your view. Chai, thank you very much. It's your stage.
Can you hear me?
Yes, I can hear you.
Yeah. First, I just want to thank you as the president of GCCCF and your organizing committee for inviting me to deliver this keynote address to your forum. It's been very interesting for me to prepare for the forum, and I'm now going to share with you a number of slides, which is really an memoir for me as I sort of talk you through this particular theme around, so what does the future of healthcare look like in a post-COVID world? So I'm going to share the screen with you now. Okay. Can you all see the screen?
Yes.
Okay.
Yes.
Right. So I'm going to start off with some opening remarks. When we think about the future of healthcare, it's not a destination. It's more like a journey. So if we look at healthcare in the last 200 years, we cannot help but to think about the tremendous progress it has made. But those of us who have been in healthcare, particularly in the last 20, 30 years, there is a sense that the momentum has slowed. And in many jurisdictions, COVID-19 has exposed the flaws in many of our health systems, and as more and more health systems come under pressure. And one of the fundamental reasons why COVID has exposed those flaws is because the changes that is affecting our health system is exponential and is becoming more complex. But the way that policymakers and decision makers have chosen to respond to those exponential change and complex change has been linear and simplistic. So we have to make the transition. So a transition to the future of healthcare that we want is going to be hard, but is necessary and is achievable. And in the talk I'm going to give you is I'm going to suggest that the transition requires a dual transformation approach where we have to shift from an emphasis on rescue and acute treatment to well-being and prevention and actually addressing the broader determinants of health. And I will finish my presentation by just looking specifically at a number of significant chronic conditions like stroke, dementia, cancer, and then lastly, I will address the very present issue of COVID-19. So if you look at the 21st century in terms of context and environment, these factors that I put up have been accumulating for some time now. So we have rapid technology advances, and some would say it's almost like godlike technology. The economic models that the free world is built on has created so much uncertainty. And with demographic changes and the issue of climate and physical environmental impact that is giving rise to extreme weather and natural disasters. And some would argue that the pandemic, hence COVID-19, and wars and conflict is because of the way that context environment has chosen to actually run the world. So as a result of all these things, 21st century life is under significant pressure. So in general, you can get a sense that there is a developing distrust of mainstream institution. There is stress, anxiety, and loneliness among quite a lot of people, both young and old. There is increasing evidence everywhere we go, no matter how rich the country, of homelessness and poverty. And the issue of the health gap is part of the driver, but it's not the only driver. We see evidence of substance abuse and violence and crime. And the fundamental reason for that pressure is because the changes that we are facing is exponential, as this graph is showing, but the response that all policymakers and decision makers, whether they are in public sector, private sector, politicians, professionals, unions, et cetera, is linear. So we can see that as a result of these two quite different trajectory, there is a gap opening. But mainstream institutions have chosen what I call a patchwork of responses. So if you look at this particular diagram I put up, the usual responses of hinges around, we need more resources. We need to work on accountability and perhaps better levers. We need better structures. We need to focus on quality. Perhaps better integration would help. Or let's focus on productivity, efficiency, or reducing waste. Now, none of them are particularly wrong. It's just that it is still a linear response and is insufficient to actually meet the gap that's opening up because of the exponential change. Now, I put up some examples of reports from New Zealand, from Canada, from Australia, of the kind of reports that prepared for government of how they should actually address this issue facing our society, particularly in the health system. So if you were to look at all those reports and then ask the question, but why is it not making progress? What's getting in the way? What I'm putting up here is some of the things that I've observed. What's getting in the way is the tyranny of the urgent. So a lot of our colleagues are dealing with the here and now, right? They're looking for the silver bullet. They're generally quite risk averse. The mindset is quite closed. And generally, when they don't get the progress they want, they will look for someone to blame. And a lot of our leaders are not looking up. They're not looking around, and they're certainly not looking far ahead. And it is also my observation that too many of the people who we rely on to lead us have actually stopped learning a long time ago, right? And they run obsolete institutions. They are practicing obsolete leadership model. And generally, the value is more about self rather than about teams. And there's lack of courage, and there's more about fear, and big egos dominate our landscape. And the very important issue around addressing this culture of fear is we pay lip service to those cultures. And it is not difficult to find wrong values that drives our system. So those are some of things that sort of explain why, despite all those reports that are prepared by multiple governments, we don't make progress. So as a result, in most healthcare systems that you look, these three elements signify widening gaps. And every one of those three elements, affordability, access, and equity, with each passing week, month, and year, it becomes bigger, and the gap is even bigger. But then, of course, COVID-19 arrived, right? So it is characterized initially as a health crisis, but we now know it has got broad social and economic impact. The interesting thing about COVID is there is a little bit of a silver lining on this, in that it has actually opened the door and accelerated some what I call stall technology. So if you look at some of the examples I put in here, some of this stall technology, they have been trying to actually get a foothold and make more substantial progress in our health system, like digital telehealth, COVID tracing, and developing of apps, and the use of artificial intelligence, robotics, and other autonomous platforms. The genome sequencing of the various variations of virus, it's a great boost for genetic medicine. So what we're doing in terms of virtual workshops and conferences, telecommuting instead of people coming to work. But COVID-19 has also crippled, if you're really honest, the broader health service. Even in New Zealand, virtually all other health services are taking a back seat and have been deprioritized to respond to COVID. And in that regard, I think it has exposed and exacerbated the flaws that we're seeing in all health systems. So I want to turn to the future of healthcare. And I thought I'd put the graphics up here around what the future might look like. So this is a drawing that I did, Mr. President, about 2 years ago when I was sitting on the beach somewhere. So I thought I'd share it with you. So when we look at the future of healthcare, there is a giant iceberg. And this particular slide shows that it is very tempting when we talk about future of healthcare to focus just on health services. But what sits underneath, and I've deliberately put the words upside down just to make it harder for people to look at, is because what sits underneath is probably more important for us to address as we look at addressing health services. So the issues around culture, social issues, environmental and economic determinants. If we address health services without addressing all this that sits underneath the sea level at the bottom of the iceberg, then the future of healthcare would have failed. The second thing about future healthcare is that we are facing a very common term that's been used, is what it's called the silver tsunami. So when you look at any developed health jurisdiction, and I'm using New Zealand and a few other developed countries as an example, 15% of New Zealand's population is age 65 and above, but we consume over 50% of the total health expenditure, and not all the way by any means actually is good use of the funding. The 2017 OECD report, I would recommend for those of you who are listening in to read that, because it, amongst other things, it explains about when we look at the metrics of the silver tsunami, it's not just about the percentage of people over 65, but it also reminds us to actually look at the velocity of aging, how fast a population is aging. It reminds us to actually look at the old age dependency ratio. And it reminds us that, addressing the silver tsunami, right, is so important because it is not just going to impact on health. It has got broad social, cultural, economic impact. And the little arrow I put underneath is a very helpful categorization that's commonly used among the community that talks about an aging population. If your population has got 7% of people who are 65 above, you're called an aging population. If it's in 14%, it's an age population. 21 is super age. At 28%, it's called ultra super age. Now, actually, the established definition kind of ends there. And I've added on the last one, and it's a creation of mine. It's because by 2050, there are half a dozen countries, right, where more than 35% of their population will be over 65. So I've coined the word mega, ultra, super age population. So I think it just emphasized that, we are starting to see the effect. So even in New Zealand, where we have 15% of population over 65, we're starting to see the impact of it, not just in healthcare, but in government policies around superannuation, the retirement age, and so forth. So if we're going to address the iceberg and going to address the silver tsunami, we have to accept that in the future of healthcare environment will be characterized by these things. The pace of change will be fast. The change environment will be ambiguous, right? And the environment will also be very fragile and volatile, and it will be constantly shifting and changing, and there will be great uncertainty, and all those issues, when you combine them all, are complex. So the situation doesn't lend itself for us to continue to try and run future healthcare in the same old way. So let me come to what I think the key themes of what future healthcare will need to have. First of all, the first theme is that future healthcare will need to be personalized to individual, and it needs to be precise. So people use the word personalized healthcare and precision medicine. The second theme is future healthcare will also be earlier, it will be closer, and it'll be smaller. Right. And the reason for that is if you kind of look at where genomics science is going, we will need to actually look at the issues of intervening much earlier, going right back to molecular level, much closer because it will be personalized, and much smaller because we actually have to intervene not when a tumor grows, but actually addressing the cells is actually grows to that. The other theme that kind of fits in with this particular forum is the big emphasis on prevention and well-being. And we need to look at the term prevention and well-being in the broader context, well beyond just health services. We have to look at that underneath the iceberg to look at the social, the cultural, the economic, and the environmental determinants. And last but not least, and I think that this is a lesson from other economies, other sectors, healthcare, future healthcare will need to be consumer driven. So a good place to start would actually be the new generation of of the elderly, which are the baby boomers. People like myself, I'm 62 this year. So people like me coming along, we will demand more. We will expect more. And we won't be like the silent generation of our parents, where we sit back and we accept whatever is given to us. So we want to have greater ownership, greater say in the choices that's available to us. So these are the four big themes of future healthcare. But future of healthcare has also got to solve these four issues. If the future of healthcare doesn't solve these four issues, then it runs the risk of being stalled. The issue of security, the issues of privacy, the issue of equity of access, and the issue of affordability. Increasingly, all these issues become more and more important if we want to actually look at a more rapid movement towards future of healthcare that's sustainable. Right? Because if we don't address the issue of security, privacy, we won't get trust. If we don't address the issues of equity of access and affordability, we're going to leave a lot of people behind. Right? And the future of healthcare, we can't actually do that. So the way we make the transition to the future of healthcare from where we are is to embark on what I call a transformation journey, where you actually have to do two things concurrently. You have to improve the existing, and you have to create the new. And the momentum of doing both those things together is you initially start by a big emphasis on improving the existing, but you also have to start by creating the new, small as it may be. But as you move on that transformation journey, you start to see that shift where the two parts become more equal. And as you mature in the transformation journey, the new part becomes more dominant than the existing. But to embark on the new transformation journey, it has to be anchored on a very clear statement and understanding of purpose, of vision and mission. And those are just not fuzzy words, because those words need to be meaningful enough so that you can develop a coherent strategy with an accompanying implementation plan. Then the strategy and implementation plan can only be executed if you have developed an appropriate target operating model, right? So, and I'm going to dwell on the operating model because this is probably one of the hardest thing about executing the transition, because most jurisdictions will be very tempted to just pick some of those 12 elements and work on it. You cannot do that. To execute the coherent strategy and the implementation plan, you have to execute all 12 elements of the operating model. And all the 12 elements have got to be interrelated. Now, I've highlighted culture and leadership and technology because I want to spend the rest of my time just talking about why those three things are really important. Culture is like a foundational thing, right? If the culture is wrong, everything that you built on it is built on shaky grounds. So for future of healthcare, one of the aspects of culture, it needs to be values-based. And
أنا تأخرت عند الوالد والوالدة وجيت وقت المؤتمر.
Above self.
سامحوني أنا موجود بس.
I'm getting some feedback here. The second aspect, I think, is the culture needs to value teamwork above individual health, self. The culture needs to emphasize on diversity of thoughts and talent. And the culture also needs to be about making decisions and not just, so in New Zealand, there's a saying, we spend far too much time talking and not enough doing. So the culture needs to be about delivering and about executing. And we need a culture of learning. And the reason for a culture of learning is important is because that environment I talked about is constantly moving and changing. So we have to keep up with that. And the only way to keep up is to continue learning. An important aspect of the culture also is about learning to own the challenges, the success, and the failures. We have to abandon this culture where we always blame somebody else when something goes wrong. Right? And it's about being open to new ideas, open to criticism, opening to other perspectives and viewpoints. And last but not least, it needs a culture where we are comfortable with an environment which is volatile, uncertain, complex, and ambiguous. And I like to emphasize leadership because there's another saying that I like, which says that you can have the best strategy in the world, you can have all the funding in the world, and you can have the best tools in the world. But if you don't have the right leaders, none of the other three matters. And in the future of healthcare, we need leaders who will live and support and develop the culture, because this is like building the foundation. And we need leaders who are fearless and who are courageous enough to step outside the comfort zone and be courageous enough to accept responsibility when things don't work. And we need leaders who are comfortable to lead from the front, but also comfortable to lead in the middle and comfortable to lead from behind, right? And the reason for that is because at times we need other people to lead from the front and we need to step back. And this is kind of important because the leaders in future of healthcare need to know how to arrive in their role, how to stay in their role, and when is the time for them to leave. Most leaders today do not know how to leave. They like to arrive, they know how to stay, maybe, but they know how to leave. In the future of healthcare, leaders need to know when to leave. The other aspect of leadership is to learn to have a strategic conversation and an excellent communicator. The strategic conversation, I don't know whether you have been in meetings and conversation before where you realize there's a lot of words being spoken, but actually it doesn't mean anything and it doesn't lend itself to advancing the agenda. And the reason is because the conversation is not strategic. The other aspect of leadership, the kind of leaders we need, is also leaders who are very disciplined and who are very focused on what's asked of them. And the ego management is very important because, if you are a successful leader in the future healthcare, you will have an ego. And so will the rest of your team. The challenge of the leadership is to learn how to manage those egos and not let that get in the way. Resilience is important, and because of the uncertain environment, the constant changes, the potential that some things we do might not work, and potential that, we might have to accept, things may take time. It requires us to be patient. It requires us to be resilient. Number 9 is very important because especially when we are in an age where we are having godlike technology, learning how to be compassionate, learning to be more human and to be humane is a prerequisite for leadership in the future of healthcare. And finally, we need to be respecting that we need a team of leaders, not one charismatic leader. And I'll put down that if you're looking for a team of leaders, you want in the composition people who are good strategists, who are good visionaries, who are good networkers, but also people who can implement. And you need all 4 of them. And in technology, and this is my last of the element of the operating model, is this particular book I like because this is the second book by Klaus, where he has refined and clustered the 21st century technology into these 4 headings. Now, I won't actually go through that because you can read that. But the point I put underneath there is quite important. As we develop more godlike technology, we need to become more human and humane. So, Mr. President, the quote that you quoted from me earlier is consistent with this theme. So I'm now going to now look at some case study quickly for you. So if you look at the journey ahead, where do we start in future of healthcare? Well, a very good place to start is to look at the issues of the silver tsunami, in other words, the aging population. And if you look at the typical things that an aging population face, which we are very familiar with, is stroke, dementia, and cancer. But of course, with COVID-19, it also disproportionately affects the elderly. But what is very interesting, though, it has actually almost sidelined all these 3 things. And, the emphasis on COVID and all these other things have almost been pushed aside. But if you look at why we need to look at all these elements and not just focus on COVID, is because, Mr. President, some of your organizations are focusing on stroke. There are 15 million people who are diagnosed every year with stroke, 5 million die, 5 million are disabled, right? If you look in Europe in 2019, this is costing Europe 60 billion euros. And when you kind of look at what are the risk factors, sitting at the very top is hypertension and AFs. But in terms of how we address this massive problem, is the point that was made in the opening address is to shift the emphasis from looking at acute intervention and treatment towards prevention and towards well-being. Now, my last point there, if you kind of look at the things that will make an impact on the prevention and well-being, are things like genomics, the early and continuous and inexpensive 24/7 monitoring, and early intervention on the broader determinants like lifestyle. If you look at dementia has even got a scarier number. Dementia, there are currently 50 million people around the world with dementia. It will rise to 75 million by 2030. And in the US alone, it's costing them 818 billion. In 2030, it will be 2 trillion. And some of the major risk factors is effective aging, but it's also genetics, it's also lifestyle. But the current focus on dementia is largely looking at dementia as a disability and is focusing on the medical model of dementia. It needs to shift towards much more around prevention and well-being, just like stroke. And the future of healthcare for dementia has got to emphasize on connections and meaning for the individual and the family supporting the people with dementia. There will be opportunity to look at issues of genomics, the monitoring and screening, but also the use of smart technology. Cancer is another big chronic disease. There are 10 new cases a year, it will rise to 20 million in 17 years. In 2017, it costing the US 400 billion, right? And the major risk factors, again, is age, genetic, and lifestyle. So there is consistency with a lot of those previous two conditions. But the future healthcare, like the other two, need to move away from the focusing on acute treatment towards prevention and well-being. And again, technology will help in terms of cancer, just like the others. And I want to finish off by just talking about COVID-19. So if you were to look at the stats, it's not very encouraging. And in fact, some of us are so numb to the numbers, right? So there are 46 million cases and 1.2 million deaths of 2nd November. 8 out of 10 people in the US who are dying are 65 and above, in other words, the elderly. So COVID-19 currently is characterized by waves. So the Northern Hemisphere is now getting subsequent waves. So people are looking at lockdowns and what's beyond the lockdown. And 2021, I can almost guarantee you, will be dominated by the discussion around vaccination and better treatment. Right? But it's also impacting on people's lifestyle, on social interaction, economic activities, and cultural changes. Just look at our conference today. That's, we're doing it for the first time for many of us. Right? But the current COVID-19 response in the context of the future is we have to move from being responsive to recovery and planning for the next pandemic. Because there are already thought leaders, they are saying we need to look at the lessons and the linkages of COVID-19 as a dress rehearsal of what is coming, which is the global impact of climate change. If you look at how disruptive and how linear our approach to managing COVID-19 and how it's disrupted almost everything we know globally, well, I think that the global impact of climate change will be more significant, it will be even greater. So I think that the faster we look at the lessons learned from COVID-19, it may give us put into a better position to actually address the issue of climate change. 2 more slides, then I'm finished. So I like this particular statement from Klaus. He is the founder of World Economic Forum. This is in his first book. So he says the changes are so profound that from the perspective of human history, there's never been a time of greater promise or potential peril. My concern is that decision makers, and I put bracket leaders, are often too caught in traditional, linear, non-disruptive thinking, or too absorbed by immediate concerns to think strategically about the forces of disruption and innovation shaping our future. And I'll finish by giving you this quote that I love from this book by Dr. Atul Gawande, who for some of you will be very familiar in his book, Immortal. In the epilogue, he writes, "We have been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that. It is to enable well-being, and well-being is the reason that one wishes to be alive." So thank you very much for the opportunity. I'll hand it over back to you, Ms. President.
Thank you, Chai. Thank you very much. I still remember our working together in New Zealand, my visits there, and I was very impressed how, from this leadership perspective, what you showed up to be open, to generate trust, to not too much show, not too much ego. And when you showed these 10 points, I really saw you there. So it's really a pity that you're not anymore there, but you're still active in this area. And one important aspect, and you know me, we had a lot of discussions about that, is the word trust. So I think one aspect is to generate trust. And what would be your advice to the new leaders, to the leaders today, how to gain trust? And trust in the definition is the acceptance of vulnerability. So how we can make people to accept their vulnerability, to trust in healthcare systems, to trust in leaders. What you will be your advice, how to start to do that? Because I think this is the biggest, let me say, the biggest challenging aspect here.
So I will answer that question, Lupo, by giving you a story of something that happened to me in real life, right? So when I was a chief executive running an area health board, my chairman said to me, the community doesn't trust you. And the reason why they don't trust you is because you always hold your meeting on your terms. In other words, I always get them to come to the hospital or to the offices, this sort of stuff. So he said to me, if you want to gain trust of the community, you have to go to the community. That's one. Secondly, when you go to the community, you are not there to make statements and ask them to do things. You're not there to explain about what your organization does. You're there to ask them questions about what matters to them and what are the things that keep them awake at night. And then the next step is they would like to know what you're going to do when they tell you these things. And they will want to expect from you that you would not just listen, but you want to demonstrate that you are courageous enough to at least do one thing that they have spoken to you. If you go to them, you listen to them, but you do not do anything, then it is not possible to have trust. So I think it was a very sobering experience. I think we can extrapolate a number of principles from that, but I think I'll just leave that for your audience to just think that through.
Thank you very much. And I need to emphasize here that, and you already said it, this is the first time that I only see the speakers. I don't see my complete auditorium. We are now around 700 people online. I don't see them. It's a little bit strange for me, but still we need to be able to generate the trust to do our presentation and to go forward. And thank you very much, Shai. Please stay in the line. And I see here a question. What is the biggest gap in healthcare systems, by your opinion, especially now during the pandemic? The biggest gap in healthcare systems, especially now during the pandemic? That's the question from the internet.
Yeah, so I think that the biggest step I see is, which for me felt very, very strange, is everywhere I look, even in New Zealand, right, we seem to have abandoned all the other services and put all the emphasis on COVID-19. It is as if mental health, cancer, stroke, dementia have all disappeared overnight. And I think what we are going to face very shortly is when we are getting to a position where we feel that we've got COVID-19 under control, we're going to have a massive problem with the failure of health system in not being able to handle all these other issues, which were significant issues before COVID-19 arrived. But for some strange reason, without exception, based on the countries that I've looked at, seems to have been relegated not just to a second place, but to a third, fourth, and fifth place. And I think, I just don't understand that.
Yeah. So there's another question. Do leaders need to regularly gather themselves to change the healthcare systems like COP21 today, or the environment? Or have you or other examples to suggest helping the healthcare systems?
So can you repeat that?
So do leaders need to regularly gather themselves to change the healthcare system? This is one question. So do leaders need to regularly gather themselves to change the healthcare system? That's the question.
Yeah. So I think that what leaders need to do is, one thing for sure, is that if they are just managing status quo and not changing enough, I think it's a signal that they're not doing enough. Mm-hmm. So, you come back to the point I was making around the dual transformation. Every leader in healthcare who wants to make an impact, right, needs to do both. In other words, they need to be looking at the existing thing that they do and think about how to make it better. Now, make it better can also mean that you actually stop doing some stuff, right? Mm-hmm. But actually that is not enough. You actually have to actually do something new. And that something new is completely different from improving your existing service. So the short answer to the question is yes, but the yes is in two parts. You have to do both.
Mm-hmm. So the last question for you now: how can we build a sustainable data-driven healthcare ecosystem? So my team is bringing me the questions. So this is, I think.
Okay. So the question is, how can we build a sustainable data-driven healthcare system, right?
Right.
Yeah. So I think that part of the operating model I talked about is the focus on the management of information and big data, right? So for those of the audience who are very involved in the sphere of information technology and data management and big data analytics, et cetera, so the thing I would say about it is it's going to be a very important part of the future of healthcare, but it can only play its usefulness if it is connected with all the other things. So a lot of the time that I see when I talk to people who are passionate about this agenda around data is they almost pushed the whole issue of data ahead of everything else. Just as people who are passionate about workforce, just people who are passionate about quality or safety, they push those individual silos. So for data to play a bigger role and be more sustainable, the champions of the data part of the sector, if you like, need to think about how to connect with the other aspects in the operating model.
So, and I think I'm also very convinced about that, is, so we have a lot of technology around us, a lot of new innovations, which is good and will be always, again, more innovations. But it's about the people who control this, who define the strategies. So it's all about people. So it was like that in the past, and it's still like that now, and it will be still like that in the future. That I think every best technology can only work if the human beings have control about that and have the right strategies for that. Is it, so in summary, how we can look at that, Chai?
Yeah, look, I think that, and that's why I put the statement underneath one of my slides, right? So I think there is no question that technology will become much more advanced. As part of technology, the whole issue around the use of data, the significance of that. But I think that as we accept and learn how to incorporate those things into a future healthcare system. Right. One of the things we need to think quite hard about is to not forget the issue of the human touch and about being more humane. And the basic example I can give you in the practical terms today is I just cannot understand, like right now with COVID-19, that we have actually lost our humanity by actually locking up and locking away our elderly, either in their homes, on facility, and denying them of, being supported by their loved ones and their families. Right? And there is to me, it is so very wrong. So in that regard, I think that what has happened, in terms of future healthcare is right now, COVID-19 have shown us that we are faced with an existential challenge like COVID-19. We have somehow forgotten humanity and excuse that by saying, oh, but we're trying to keep the elderly safe.
Yeah.
I think that's wrong.
Jai, thank you very much. Thank you, and stay with us. And I will need you also for some more question. I know it's late in New Zealand. It's 10 hours ahead. So thank you very much.
Welcome.
And also you will get also the questions also later on, so we cannot touch every question.
Sure. Just send me the questions.
Okay. Thank you very much.
Okay. Thank you. Welcome.
So, ladies and gentlemen, I visited Dubai first time in 1999. And since now, in 2020, Dubai and the entire United Emirates went through an amazing development. His Excellency, Dr. Amin Al-Amiri, the Undersecretary of Public Health, Policy and Licensing of the Ministry of Health and Prevention of the United Arab Emirates, will now speak about the future of healthcare in the United Arab Emirates and the advancing health innovations. Your Excellency, dear Amin, thank you to be with us here today. It's your stage.
Thank you very much, Mr. Chairman. It's good afternoon from here. I'm quite sure there are people which I have to tell them good morning, good evening, ladies and gentlemen. It's my profound honor to be here with you and to share with you the experience of United Arab Emirates in health transformation. Allow me to share with you, first of all, my presentation. Is my presentation clear in front of everyone?
Yes, now it's
excellent. Let me start to say something that the year 2020, it's a unique year. It's a year that's proven to the whole universe that health has an important role, and health is the most important and precious and valuable thing that we have. Think of it and invest on it and take care of it. The only sector which was running during the COVID-19 pandemic situation was the health and the health sector. And the only sector which the people tried to use for survival of their community was health. And therefore, here comes the importance of how we should learn and gain lessons from this pandemic situation, and to make sure that we will be able to implement and enroll systems, policies, regulations to help us in facing any unexpected pandemic situations at the future. There are two very important things here we have to understand. One has been clearly said by Dr. Chai, but let me raise it again on a bigger scale. The first thing is the human's minds, innovations, ideas, and how I will be able to get their trust, bring them together, let them live in peace in my country and benefit from their innovative ideas, their brains, their suggestions, and have a proper integration of such good, valuable things together for the improvements of our health services. Today, the technologies are many. Every day and another, there are new technologies being implemented worldwide. But you need the people who could innovate those technologies, and you need the people to implement them properly. And I can say, I emphasize in one word, ethically. Dr. Shao said, we lose humanity during this pandemic situation. And therefore, I'm emphasizing on how to use the most health technologies ethically and to be parallel with the humanity. Secondly, the leaders. You need leaderships on healthcare services, that's right. But on the top of it, you need another leaders. You need higher leaders to support your leaders at the health sector. And those leaders are such as mine, what we have here. Today, this is a statement from on the left side, the photo of His Highness Sheikh Mohammed bin Rashid Al Maktoum, Vice President, Prime Minister, and ruler of Dubai. As I said earlier, humans being, they have many good ideas, innovative ideas, their dreams, their connections. We have close to 200 nationalities living in our beautiful country, the United Arab Emirates. Wherever they go, good things happen at that place tomorrow or after tomorrow. And this is why we are trying to get back the good brains from different countries of the world and to convince them to come and join us. UAE established in December the 2nd, 1971. Today we are talking about reaching Mars. We had a mission to Mars. This is the United Arab Emirates, but we alone were not able to do so. We had people living with us from 200 different nationalities. Mr. Chairman, yourself, you visited my country and you found how we are connected with the people who lives with us. And therefore, people are the main focus of development in our country, as the statement of His Highness Sheikh Mohammed bin Zayed Al Nahyan. The photo on the right side is the Crown Prince of Abu Dhabi. And therefore, here comes the importance of joining the people together, living in peace, getting them involved in the development of our country. This led that healthcare sector in our country has a swift rise, and there were many reasons behind. One of them, which I was talking about, expectation of the government, the wishes of the government that to have the best class of healthcare services. On the other hand, expectation of the people, that the people, how do they expect that I should provide them with the highest quality, highest standard of healthcare services. Growing population, this is a major issue worldwide, and therefore the life expectancy is increasing. The economical burden from the non-communicable diseases like an NCDs, hypertension, diabetes, so and so, so and so, so and so, and therefore, and also the emerging epidemics which we are facing now here in each single country. Expanding medical tourism, we are very much open to the rest of the countries that we would like everyone to come and have their healthcare services and healthcare programs with us. We have good examples, by the way. We have Cleveland, Abu Dhabi. We have Seoul National University Hospital running Sheikh Khalifa and Ras Al Khaimah from South Korea. We have Global Health from Sweden running 4 hospitals. We have Mayo Clinic. They have an affiliation with the American Hospital in Dubai. Those are some of the examples that it supports the health medical tourism, but also it gives you an evidence that how the infrastructure and the policies and the systems are very much transparent and open that those international hospitals, they are coming and joining us. This led for healthcare investment to be increased rapidly in our country. In 2019, we're talking about 56.2 billion UAE dirhams, and we are expecting to reach above 80 billion US dirham by the near future, 89 by 2024. And this is one of a good example. Despite that, the health technology, health information system, it's being used very strongly in our country. Those are in a front view in a very busy slide are some of the examples. Probably you can read, you can log in through your mobile application, and you can connect and find out what we are providing to our community. But let me share with you two examples. At the bottom, the middle, the left side, the third says UAE Radar. UAE Radar is the new application which was launched 3 years back. It's for the adverse reaction of the medicines. This has been developed as a smart application on your mobile phone. In 2-3 steps, you can report about any adverse reaction of the medicines. This has been developed with MHRA in UK, connected to our ministry and to Uppsala in Belgium, which that means that we are able to give an alert to close to 167 countries worldwide, which that the member with the World Health Organization. We give them the alert about any adverse reaction of the medicines. Next to it, called Hayat. Hayat, it's a new technology which has been developed. I think we are unique worldwide that we developed a smart application for the organ donors voluntarily, if they are willing to donate their organs after death. In 3 steps, in just 2 minutes, they can be an organ donor and they can log in and donate their organs and register with us. Those are examples of 2 top examples we have in our country, but we have many, and therefore this what has to be used worldwide, because the number of the mobile phones subscriptions represents in UAE almost 208%, and worldwide it's almost 98%. They are using the internet, and therefore the interneting of things using these smart applications with the smart mobile phones is very important to reach the people and provide them with the fastest, best, highest quality of care services. This is one of the health technology which is being used in our country, robotic system and doing surgeries, the tele-ICU which we have is connected with the overseas big hospitals and some of the hospitals inside UAE, although the telemedicine is being implemented in UAE since 1993 between Al Mafraq Hospital in Abu Dhabi and Mayo Clinic in United States of America. This is one of the other beautiful example of using the technologies called smart nebulization room. Now the nebulizers is being fixed with the children if they have asthma in different hospitals worldwide. But in my country, this is one of the examples from Al-Qasimi Hospital. Al-Qasimi Women's and Children's Hospital belongs to the Ministry of Health and Prevention, that whenever we would like to provide the nebulizer for our children, we provide them in this room with the 3D projection mapping, that we educate them and we give them a sort of education about the asthmatic disorder. And we are trying also to give them a sort of health education and to make the young generation to be aware of different type of diseases, how to prevent it, how to have a healthy lifestyle. Professor Chai was emphasizing on the lifestyle of the human being. If you will start to educate the young generation, your youth, that's the future of your country, because those are the new generation of your country. Another example, the robotic pharmacy on the left side is the existing pharmacies still in the majority of the countries worldwide. The right side, the photos, examples in my beautiful country are an example of robotic pharmacies that we can use it to avoid human errors, and we will expedite the dispensing of the medicines to our patients. We avoid any sort of mistakes, even from the doctors who prescribe the medicine, because the IT, the artificial intelligence, the AI will control the dispensing. And also we allow our pharmacists to focus on patients' care and other valuable added tasks that has to be provided to our patients. I said at the beginning of my presentation, the COVID-19 pandemic situation has become a shock to different societies and governments, and it brought a huge burden, economical burden. A lot of, I can say, thousands of countries has been broken, has been closed, and really has been brought a huge burden economically, socially, health-wise to different countries in the world. But we have to use the transformation of the healthcare sector strongly, and to make sure that how we will be able to transform the new technologies and to be provided to our community, to our society, that to provide them with the healthcare services while they are at home, at their offices, implement the new technologies like in small wearable devices that they can check their vital signs, how to provide them with their medication, especially with the patients with the chronic disease, and provide them with the medication door to door, from the door of the pharmacy or a hospital to the door of their house, how to control their health, how to send them the doctors to their houses, to their offices, how to support them while they are at home, and we don't want them to come to the hospitals and not to expose them to the risk of the COVID-19 virus. Another example that how we started to use the new innovations and new technologies to fight against the COVID-19 virus. We were the first in having in fact, the first genome sequencing of the virus. That was done in Hamad bin Rashid University for Medicine and Health Sciences in Dubai. We use the stem cells of the, we call it an autologous, the stem cells of the same patient who's positive for COVID-19, that we separate the stem cells and give them back by the nebulizers, and also using of the antibodies of the recovered positive COVID-19 positive patients, and recover one, then we use their plasma to be re-injected to the other patients to boost and support their immune system. And I'm quite sure you know that we started the clinical phase trial, phase 3, clinical trial phase 3 for COVID-19 virus with Sinopharm in UAE. It's a Chinese company, and we accomplished about 40,000 healthy voluntary donors. And we started also with the frontline people. And at the bottom right side, this is my photo, which I'm getting the vaccine as a frontline people. At the backside, my minister and other undersecretaries are standing with me. Usage with Huawei, we use the smart vehicles to go and provide the PPEs, the sanitizers, to the villas, to the houses of the people. And during the during the beginning of the pandemic situation, really we did a great job in terms of how to protect our community and use of the new technologies in supporting our communities. I was talking about the AI, those one of the examples. I was talking about the wearable items and the sensors, which it supports the patients, using of the nanotechnology, using of the robotics, 3D printing, virtual images, to put the people in reality, especially the health professionals. Those are among the next 50 years plan, which we are working on it, that from today until 2071, which the UAE will be accomplishing and completing 100 years since the date of independence in 1971 until 2021, we are putting our plans on those sectors, on those fields, which is AI, robotic, 3D printing, nanotechnology, virtual seeing, genome sequencing. Those are the new technologies, new transformation of those technologies to be in our healthcare system. And this has led that almost 87, or I can say 88% of our hospitals to be accredited by the JCI Jones Commission International. We are number one worldwide after United States of America. On the right side, this is the report from Joint Commission International. Those are an outcome or an achievement of how the new technologies were implemented, how we raised our standards, how the focal point was on the patients and the patient safety, which the patient safety comes first. We were able to reach this successful level of hospital accreditation. I was talking about on the right side an example of the international hospitals which they are based here in our country, and we are happy that we are working with them to provide the highest quality of care to our patients. Having said that, let me tell you one thing, that you cannot achieve any sort of success in the healthcare services even if you have a strong infrastructure of logistic hubs, airports, higher tech, and the technologies and the most advanced hospitals and the, I can say AI, but you need a legislation to support you. You need a legislation will allow the new technologies to be enrolled, to be implemented in your country. You need the legislation, health legislation, to allow the R&D to be implemented in your country, and also to interneting of things, and also to use the benefit of the high data or which is being available at your hospitals. And therefore, for last 4 years, since 2017 until 2020, we were able to, in fact, release almost close to 36 number of the new laws or legislations at the health for the health system, either released by His Highness the President of the country or His Highness by the Prime Minister of the country. Therefore, updating and having new healthcare legislation is a must to support your healthcare services. I will conclude my presentation with a statement of His Highness Sheikh Mohammed bin Rashid Al Maktoum, which he said, innovation is what defines our status among nations and the value we add to the world around us. Therefore, I will go back to my first slide. I will say that new ideas, new innovative ideas, new brains, new suggestions, new recommendations of the people integrating, joining together, and allowing them to be shared with your community and with your government, with your ministry, you will be able to reach the highest, and you will be able to have your mission to Mars, like what the United Arab Emirates did a month back. Ladies and gentlemen, I had a pleasure, a great pleasure to be with you at this conference. And really, as Mr. Chairman, His Excellency said, that we look forward by the next conference to see you face to face. This is a new challenge for us, that we are seeing each other virtually, but hopefully and consistently, we look forward to see you face to face at the near future. Thank you very much. God bless you all. And we wish all of you to live peacefully in your beautiful country. Thank you and have a nice day.
Thank you very much, Your Excellency. Do you have some few minutes to stay with us for some questions?
With pleasure, my brother.
So I think, Chai, do you have a question for His Excellency from your side? Can you hear me?
No, I can hear you. No, I think what I enjoyed most about the presentation actually is the emphasis on inviting a diversity of people to participate in the UAE, to continue to grow what I think is an emphasis on innovation. And I think that that's kind of a key part of the future. If we stop innovating, we don't have a future in healthcare. So I really like that aspect of the presentation.
Thank you, Chai. I can emphasize one thing, and this is also due my long work. I worked long time for IBM, and I mean, you also know Lina Shadid also worked for IBM. I was a lot in different situation, and what I really appreciated how the people, the local people, and also the cooperation with people from abroad was so. First of all, it was very pragmatic but warm-hearted, and it was not that what I liked a lot. And this is something what always I have in the Nordic countries, but in this combination, warm-hearted by heart plus plus the encourage, the how brave they go forward, how fast they deliver things, how generous they react if something don't go well, the re-innovation. So it was something, and this is only a comment from me, not a question. I would be happy if United Arab Emirates stay with that also in the future. That will be a big win, and I go conform with your president, and it's the right way.
Thank you very much.
I have a question here. Yes, from the internet. What are the preventive strategies of UAE considering the increasing population aging?
Once again, the question was not clear to me.
What are the preventive strategies of the UAE considering the increasing population aging?
Our plan is to keep them healthy. Our plan is to provide them with the proper healthcare services. And our plan is to enroll in our healthcare services the strategies and the technologies will protect their health and provide them with highest standards. And therefore, now we have a lot of new designed hospitals, which we provide like a home care. We thought of something new for the elderly people, that instead of taking them to the hospitals, we provide them with the quality of care constantly while they are close to their family. And we wanted those, I can say, aging people to be close to their family and to have a social support and to have the proper mental health management. Today, mental health is one of the very important discipline that we have to concentrate on. And it has been now provided with different type of our healthcare services, not even the hospitals, but also the health centers. Mental health is something that to be very much emphasized, supported to especially the aging population, and especially during this pandemic situation, which really the mental health support were very much needed. And therefore, we have a lot of new programs to cover this category, which they are the minority, because the majority of the percentage of our population are a young generation from age of 15 to 40. And therefore, that's the majority aged in UAE. We are still not facing an aging population, maybe 20 or 30 years later, but we are very much prepared for it.
Thank you very much. Here's one more question. How do you tackle the culture-related challenges to accelerate the digital transformation in the UAE? So how do you tackle the culture-related challenges to accelerate the digital?
I think always those things like a culture issue, you can take it and convert it to the way that positively will be having an impact to your community and your country. Once I said we have close to 200 nationalities from different countries in the world. By the way, they come with their attitude, they come with their culture, they come with their behavior, they come with their entire culture from their own country to you. And therefore, we succeeded that how to accommodate them, how to benefit from their culture on a positive way, and to convert it to the tools that it could be used positively to support the the transformation or the health technologies. I will give you an example that we started 10 years back that to announce that we are hosting the most different cultures, from people from different cultures to come and join us, especially the highly educated people, and to accommodate them in a way that we will be able to benefit from what they do have positively, and we could adopt their culture with us in a way that not to reflect negatively in our community or in our own, in our own culture itself. And therefore, we are always having a sort of proper management to adopt those things on a positive way and to convert it for the benefit of the government and the country.
Thank you very much, Your Excellency. One more question, if you allow.
Go ahead, please.
How do you rate in percent the prevention, education, and medical practice in this pandemic times? How much percent should be dedicated to each sector?
How much percent? The last sentences, how much percent what?
Percent should be dedicated to each sector.
Okay, he means the sector of different health disciplines, probably he means that?
Yes.
Okay, I think what we did is that we dedicated the volunteers from the health professionals to have a base in some of the centers in different emirates in the UAE to concentrate on educating the population on a different way, even the health professionals, that how to educate them during this pandemic situation, that how to prevent the transmission of the virus, how to protect themselves, how to sanitize the things before using it, how the usage of the PPEs properly, how to protect the older age among different families, and how to make sure that we will be able to educate the youth and the children's in preventing behaviors that it will expose them to the virus. I think he was meaning during the COVID-19 pandemic situation. Therefore, the public awareness and the health education was strongly used, not only from our, I can say, permanent health professionals, but we used the volunteers because the private sector was under the lockdown for almost 2 months. We had a huge number of the volunteers from the health professionals that they joined us, and they have been exposed to the guidelines of the prevention and the precaution and also the public awareness, which has been adopted from the WHO in our country, this gone very smoothly, and therefore the number of the cases were declining in my country, starting from as per the statistics of the prevalence number of the cases from February until I can say end of September. The number was declining almost in number of the cases, and also the number of the new cases was very much declining. Now the number probably is a little bit going up due to the, unfortunately, the people are not sticking to the guidelines, but still we are going back to the strengthening and enforcing the public awareness and proper education to make sure that we will be able to protect them and to protect their family members also.
Thank you very much. Okay, so that's from my side. Your Excellency, dear Amin, thank you very much to be with us today. You're invited to say also to hear the next presentations. We will go forward. And also to be involved in the discussions, because it's that's the only thing where I have really a face-to-face opportunity for a discussion. The other discussion you see, I get from the internet. So I would be happy if you stay with us, and we will come to the next presentation. Thank you very much.
It will be my pleasure. I will stay with you, but today's Friday. We have enough praying time after a couple of minutes. Probably if I will excuse you from now, allow me to quit once the praying time will be there.
Yes.
Thank you.
Thank you very much. Thank you very much. So now we touch something what usually happens suddenly and is the biggest tragedy for families and one of the biggest economic burden worldwide. This is stroke. 9 of 10 strokes are avoidable. The main risk factors include undetected cardiac rhythm disorders, primarily atrial fibrillation, AF. Early AF detection and intervention is the core aspect to avoid this tragedy. Professor Paulus Kirchhoff today will speak about technology-enhanced, remotely guided screening for atrial fibrillation, what we know and what we need to find out. Professor Paulus Kirchhoff is living and working in my lovely hometown, Hamburg. Paulus, it's your stage.
Thank you very much. Thank you for the opportunity to speak to you about atrial fibrillation. And as you said, it is an important part of the cardiovascular disease continuum and an important part of public health prevention. But I also think that atrial fibrillation is almost an exemplar that can illustrate how technology can, on one hand, enhance and improve diagnosis and care of patients, but on the other hand, how important it is to carefully evaluate every new tool, whether it is technologically enhanced or not. So I'll spend the next 30 to 35 minutes speaking to you about technologically enhanced, remotely guided screening for atrial fibrillation, what we know and what we need to find out. My experience, my talk is based on my current position at the University Heart and Vascular Center, UKE Hamburg. Also on the work that I did at the University of Birmingham and in Birmingham over about a decade, and on the experience that I had at the University Hospital Münster, where I trained beforehand. These are my financial disclosures, as is now common for academic speakers. None of them influence what I'm going to tell you. I want to talk about 5 aspects. I want to briefly show you how beautiful our atria, a small part of the heart, but an important part of the heart are, and how much they get damaged when they suffer from atrial arrhythmias. I will then briefly cover how we can prevent strokes with anticoagulation, and will spend a few minutes on a recent study that we've just reported that shows that rhythm control therapy, so the actual prevention of atrial fibrillation, can further add to stroke prevention once we have diagnosed atrial fibrillation. And then I'll tell you about screening for atrial fibrillation and why it can actually help to improve stroke prevention. And then I'll talk about technologically enhanced screening, learning from device experience, so experience that heart specialists have with implanted devices, and then talk about the emerging area of consumer electronics. This is a picture of the two atria. When you shine a light through them, you can appreciate how beautiful they are. They are an amazing structure because they work continuously throughout our lives. When the heart stops beating, life stops. And even though we are amazing engineers and scientists, we have yet to devise an engine that works for 80 to 100 years without ever stopping. Now, this beautiful, highly organized, very complex structure turns into something much different. And these are biopsies taken from patients with atrial fibrillation when atrial fibrillation develops. And you can even with the bare eye see that the red color that identifies the heart muscle is exchanged for something that's yellow or whitish, typically fat or fibrous tissue that does not function anymore. How can we prevent atrial fibrillation? Now, there are a few things that we already knew for many years, actually many centuries. Sufficient physical activity, a balanced diet, which in our times means don't eat too much, sufficient sleep, moderate alcohol consumption, potentially actually abstinence, avoid or compensating for abnormal stress. There's a sixth factor that helps to prevent heart disease, stroke, and atrial fibrillation, and that is not smoking. We only know about this in Europe for the last 100 to 200 years because we didn't have wide-ranging access to tobacco before that. We, of course, have many medical interventions that can help us to protect the heart against atrial fibrillation and to protect the heart against atrial fibrillation-induced damage once it develops atrial fibrillation. These include not only blood thinners or anticoagulants, but also antiarrhythmic drugs, AF ablation, treatments for heart failure, treatments for diabetes, treatments for hypertension, where we as cardiologists currently learn that these medical treatments have interacting factors. So for example, that anti-diabetic substances can prevent heart failure, that atrial fibrillation treatment can prevent heart failure, or that heart failure treatments or antihypertensive treatments can prevent atrial fibrillation. For this to implement and to become fruitful for patients, we have to diagnose atrial fibrillation first. What are the key treatments that we can and should use to prevent strokes in patients with atrial fibrillation? They are anticoagulation and rhythm control therapy. The former is well established, and I will not say too much about it, but I think it's important to cover this. These are summarized data from the 1990s. Only 25 years ago, we didn't know that anticoagulation prevents strokes and atrial fibrillation. But now we know that at least 2/3 of all strokes in patients with atrial fibrillation can be prevented with anticoagulants. This was initially studied with warfarin and vitamin K antagonists, but we now have other easier to use and safer substances. The yearly stroke rate without anticoagulation is really high, up to 1 in 10 people per year. And it drops dramatically to 1.5, maybe 1% of patients per year in those who take anticoagulants. And the risk of anticoagulants is, of course, the risk of bleeding, and particularly the risk of bleeding in the brain, intracranial bleeding. But that is much lower, and that is actually one of the reasons why the newer substances called NOACs appear safer than warfarin and are now the standard of care. And this is a picture from the European Society of Cardiology guidelines on atrial fibrillation management that summarizes this nicely. It is called the ABC scheme, and it says anticoagulation is the cornerstone of management of patients with atrial fibrillation. It should be combined with B, which stands for better symptoms, and we'll come to that in a minute, to assess quality of life and improve quality of life, and C, to treat concomitant cardiovascular conditions and comorbidities. Now, we have just published a paper that I think will change the value of this column B. And this is the title page. It's called Early Rhythm Control Therapy in Patients with Atrial Fibrillation. It was the primary outcome of the early treatment of atrial fibrillation for stroke prevention trial, where we answered the question, does early rhythm control therapy improve outcomes compared to usual care in patients with early, recently diagnosed atrial fibrillation at risk of stroke? We randomized patients with recently diagnosed atrial fibrillation, so within the first year of the first detection of atrial fibrillation and stroke risk factors, to either usual care, that's anticoagulation, rate control, treatment of concomitant conditions, and rhythm control therapy only in those who remain symptomatic on these initial treatments, or in blue, to early rhythm control therapy, which is the same background therapy plus an antiarrhythmic drug or AF ablation in all patients at the start. And the hypothesis was that early rhythm control therapy may improve outcomes compared to usual care. 2,789 patients were randomized across Europe in 11 European countries, half to early rhythm control, half to usual care. All of the patients were analyzed in the primary analysis. That's an important technical aspect. The mean age was 70 years. A third of the patients were asymptomatic. That is, I think, of particular importance for our topic, because they would have never come to a healthcare professional to say, I have a problem, because they didn't even know and notice that they had atrial fibrillation. Almost all of the patients received anticoagulation. That's an important part for this therapy to work. The patients randomized to early rhythm control received antiarrhythmic drugs in the majority of patients, and 20% of patients had undergone an AF ablation after 2 years. And the patients in usual care hardly received any rhythm control therapy at the start. And as is now practice, about 15% received rhythm control after 2 years. All patients were followed up for 5 years on average to see whether there was a difference in outcomes. The primary outcome was a composite of cardiovascular death, stroke, acute coronary syndrome, and worsening of heart failure. We stopped the trial at the third interim analysis due to efficacy. So after we had observed 3/4 of the events that we thought we would need to get our answer, we already had an answer. And that happened earlier this year at the end of February, and we ended the trial on the 6th of March, 2020. 249 of the patients randomized to early rhythm control experienced the first primary outcome event, 3.9% per year. And that was 21% lower than the 316 patients who experienced the first primary outcome event in patients randomized to usual care of 5% per year. That was a clearly significant difference. Moreover, every component of the first primary outcome was numerically lower in patients randomized to early therapy. So cardiovascular death, stroke, but also hospitalization with heart failure and acute coronary syndrome. A clear overall benefit in terms of the primary outcome. We did an extensive subgroup analysis. I'm not going to go into the detail, but we did not find a subgroup of patients that benefited more than others. The effect of rhythm control, of early rhythm control, was obvious across all patients that were included in the study. One important aspect of care is, of course, cost. And one of the simplest estimates of cost of healthcare is nights spent in hospital, because hospitalizations are the main driver of cost in healthcare systems. And we therefore quantified nights spent in hospital as the second primary outcome of the trial. And this was not different between random groups, as you can see in this table. Furthermore, early rhythm control therapy was very effective. Over 80% of patients were in sinus rhythm 2 years after randomization. We did not see marked differences in quality of life, mental health, or physical health when we applied normal scores. The other important aspect of such an intervention is safety. And the good news is that early rhythm control therapy was safe. This was a concern before this study, because there were older studies that showed that rhythm control can lead to complications. And indeed, we found complications of early rhythm control therapy, but they occurred in very few patients at a rate of about 0.4% per year. And they were balanced out by the fewer deaths and fewer strokes that we found in patients randomized to early rhythm control. So that in summary, early initiation of rhythm control therapy reduced cardiovascular outcomes in patients with early atrial fibrillation and cardiovascular conditions without affecting nights spent in hospital. As expected, the early rhythm control strategy was associated with more adverse events related to rhythm control therapy, but the overall safety of both treatment strategies was comparable. And these results clearly have the potential to further inform the future use of rhythm control therapy, thereby further improving the care of patients with atrial fibrillation. I'd like to thank everyone who helped us run the trial. This map shows you the areas of Europe where the trial was done. You can see that it covers most of Central, Eastern, Western, and Southern Europe. And we believe that early rhythm control therapy should be offered to all patients with recently diagnosed atrial fibrillation and concomitant cardiovascular diseases, in addition to oral anticoagulation, rate control, and therapy of concomitant cardiovascular conditions. Or to modify the current guideline picture, we may now have to change the name of the B column in ABC from better symptom control to better outcomes. But of course, this is just my idea, and it has to go through the correct process of adjustment and updating of guidelines. So now I've told you what we can do when we diagnose atrial fibrillation with anticoagulation and rhythm control and treatment of concomitant cardiovascular conditions to prevent strokes and improve lives, actually save lives. Now, why is screening for atrial fibrillation so important? And I'll start with this patient whom I saw now over almost 15 years ago. It was a 75-year-old patient, a man, who presented with the signs of an acute stroke to the stroke unit at the Hospital of Münster, where I worked at the time. And the imaging signs, you can see the CT here, the perfusion CT, and the MRI clearly show the signs of an early ischemic stroke. Now, the ECG clearly shows atrial fibrillation. Sorry, I was too quick. And fortunately, because this patient received successful thrombolysis, he recovered well, so I could speak with him a few days later. And he told me that he actually felt breathless for 7 days before the stroke. And this is a very typical symptom of atrial fibrillation, so that I am convinced that this patient developed atrial fibrillation 7 days before this stroke happened. And it seems obvious that if one had only diagnosed atrial fibrillation then and started anticoagulation, this stroke could have been prevented. Now, this is only a case report, but when you do this, when you look systematically, and we did this a few years ago in Germany, where ECG screening is actually quite advanced, as you'll hear also in the next talk, we found that every 5th patient who is admitted to a stroke unit in Germany has atrial fibrillation just by doing the ECG on admission. That was not known before. And if you then do a little bit of hold-up monitoring for 3 days, you add another 4% of patients, so that one could claim that almost every 10th stroke that occurs in Germany or occurred in Germany a few years ago was due to undiagnosed atrial fibrillation. So there are many strokes that we can prevent with screening. Now, depending on how you screen and how long you monitor, you find even more. I'm not going to go into the details of these pie charts, but they basically should show you the number of stroke patients studied in green or blue, and the proportion of patients with previously unknown atrial fibrillation who were detected by ECG screening. And you can see that it goes from 5% to up to 25%, depending on how long you monitor the heart rhythm. We actually know this even more robustly from patients with implanted devices. You probably know that many patients have either a heart rhythm that is too slow and they need a pacemaker, or they are at risk of sudden death and they need a defibrillator. And these devices are implanted under the skin. They monitor the heart rhythm throughout life. And when we look what proportion of patients with these implanted devices, where we have continuous ECG monitoring over years, have atrial arrhythmias, you find that almost half of them have atrial arrhythmias. And when you exclude those with known atrial fibrillation, you come to very similar numbers. So 1 in 10 up to 1 in 4 patients with implanted devices has undetected atrial fibrillation or atrial high rate episodes. Now, what can we learn from this group of patients that has been characterized so well? The first thing, and this is a paper that was published by my colleague Jeff Healy 8 years ago, he looked at over 2,500 patients with implanted pacemaker and found that those who actually have these atrial high rate episodes, so these atrial arrhythmias that occur very rarely, they also have a higher stroke risk, suggesting that one could maybe help them with anticoagulation. But we know that if you just give anticoagulants to stroke survivors, we do not help the patients. They do not help to prevent strokes, and they just cause bleedings. And unfortunately, there was one study that tested whether intermittent blood thinners, intermittent anticoagulation could prevent strokes. They didn't show a benefit, so that we are not really sure what the best treatment is of patients with rare device-detected atrial arrhythmias, whether they should be anticoagulated to prevent strokes or whether they should be kept as they are because the bleeding risk of the blood thinners is too high. And this medical problem, which is unresolved, is actually addressed by 2 controlled clinical trials. And one of my main messages in this talk is really that I want to convince you that we need to generate evidence that these screening-based, technologically enhanced monitoring strategies lead to better outcomes before we implement them population-wide. So let me tell you this, the design of this study. So it's called the non-vitamin K antagonist oral anticoagulants in patients with atrial high rate episodes trial, or NOAA AFNet6. It will randomize approximately 2,500 patients with implanted devices and with rare atrial arrhythmias detected on the device, but without ECG diagnosed atrial fibrillation. And patients will be randomized to either oral anticoagulation using one of the newer anticoagulants, edoxaban, or to no anticoagulation. And they will then be followed for a primary outcome that is a combination of stroke or cardiovascular death. And there is a sister trial, if you wish, it's called Artesia, and it's run by the same group that published the first pacemaker study 8 years ago. And when we've seen the results of those trials, we will know whether we should prescribe anticoagulants to patients with rare atrial arrhythmias. Now, why are these atrial high rate episodes or rare atrial arrhythmias different from atrial fibrillation? On the ECG, they look the same. And a wise colleague of mine, Jim Reifel, said that this can be summarized as magnitude synergism. It's a complicated word and a complicated concept, but I think it's important in the context of this talk. So we know on one hand that atrial fibrillation patients, when they are young and without any other heart damage, they are not at risk of stroke. So atrial fibrillation alone does not cause strokes, even though atrial fibrillation in most patients is associated with stroke risk. Many of the frequently coexisting associated disorders, such as hypertension, heart failure, or atherosclerosis, have a stroke risk that is independent of atrial fibrillation. So they lead to stroke and to atrial fibrillation. So strokes in these patients can be due to atrial fibrillation, but can also be due to these conditions. These comorbidities also cause damage of the atria. Remember the wonderful picture of the beautiful atrium that I showed you at the start, and the damaged atria that we find in patients with atrial fibrillation. So atria can be damaged, and that can lead to clot formation in the atria and to a stroke. And thus, the stroke rate should probably increase when we have more atrial arrhythmias, so longer and more episodes, and when there are more comorbidities. And the findings of the EAST trial that I've just shown you beautifully underpin this concept, whereby a stroke reduction is found in patients who are treated so that they have less atrial fibrillation. So in summary, we know that we can detect atrial arrhythmias in device patients, but also with other ECG screening methods. But we are not really sure, particularly when we monitor for very long, what treatment to offer these patients. So how does this transfer to this amazing emerging area of consumer electronics? Now, the ESC guidelines say that one should use opportunistic ECG screening at the doctor's office or when a patient sees a nurse to check for irregular pulse and then record an ECG. And they also say it is recommended to interrogate pacemakers, but they fall short of saying you need to anticoagulate those patients, as I've just explained to you. And indeed, for example, the UK National Screening Committee does not recommend population screening for atrial fibrillation because there is no clear evidence that patients who are detected through the screening will benefit from the diagnosis. And I believe that the studies that I've just explained to you, NOAA and Artesia, will give some answers. And there are other studies such as Stroke Stop, which is run in Sweden, that will provide answers to that question. Now, obviously, we have now a wealth of technologies that we can use to detect atrial fibrillation. And they run from blood pressure measuring devices through to your smartphones, smartwatches, and of course the Holter ECG recorders that have been in use for many years. One can split them into medical devices, and you can include the healthcare professionals taking the pulse in that. So automated blood monitors, single lead ECG devices, ECG patches, implanted devices, and consumer electronics. And those are the ones that provide most of the data now because they are available to everyone. And we all, or almost all of us now have smartphones, and the majority of us are thinking about smart watches, so that detection of heart rate through physiological sensors, often using the photoplethysmography sensors on the devices, enable detection of arrhythmias at a very broad scale with little cost. Now, one of the studies that has been published is the Apple Heart study. You've probably heard about it. And Apple basically used the data of 420,000 of its Apple Watch consumers who bought an Apple Watch and analyzed their personal data and checked whether they had an irregular pulse. First thing to observe is that very few of these people had an irregular pulse, only 0.5%. That is less than what we expect in the population. And the reason for that is probably that the average smartwatch user is much younger than the average atrial fibrillation patients. The average year in the Apple Heart age in the Apple Heart study was 41 years. Whereas the average age of patients with atrial fibrillation is 70 years. And the prevalence of atrial fibrillation is much higher when you go further into old age. Now, almost all of the patients with detected arrhythmias were excluded because they didn't interact with the Apple Heart survey. And some of them also had other reasons. For example, they had already known atrial fibrillation. And they were then offered an ECG patch to check whether they had atrial fibrillation. And of the 450 probants out of the 419,297 who returned the patch, indeed a third, 153, were diagnosed with atrial fibrillation. So it's a big effort, but it makes use of available technology. But I think one of the two key findings for me are the age of these people was young. Almost all of them, 4/5, were lost because of difficulty in communicating. And yet they found quite a bit of atrial fibrillation. And it's worth to see that, of course, there was more atrial fibrillation detected in the patients who were older, but they were also those who interacted less frequently with the technology offered service. And I think that is one of the key things that we need to work on as a community to enable that these consumer electronic-based simple ECG screening tools are used by the population who needs screening the most. We have in the past developed a pair of apps that helps patients with established atrial fibrillation to manage their disease better. And we've had some experiences of how dialogue and interaction between a technological tool and the patient is important. Like we have learned in the last 7 months how to interact through screens, we have to develop ways to interact with participants and patients through digital technology. And these apps may be one of the ways to do that, but I'm pretty sure we have to develop better ways to communicate with participants to ensure that we don't lose the 80% who don't reply to the initial survey. We are actually, through the European Society of Cardiology, currently conducting a controlled clinical trial that tests whether a technologically enhanced educational intervention, primarily geared at healthcare professionals, can improve outcomes in terms of guideline adherent management for atrial fibrillation. This is an ongoing study, and I hope we'll report it in 2 years. There is a lot that's going on in terms of research, and I think it's much required. I want to point out Renate Schnabel, one of my colleagues in Hamburg, who is coordinating a worldwide research project that tries to determine the best ways to screen for atrial fibrillation. It's funded by the European Union, called Affect EU. And I want to spend a few minutes now explaining a little pilot study that we are starting. It's called SMART in OAC, and it tries to address some of the remaining challenges in using consumer electronics, in this case, a wrist band, to screen for atrial fibrillation in at-risk populations. This is the outline of the study. It's led by a colleague of mine from Birmingham, and it's done in 4 countries: Germany, Poland, Spain, and the UK. We plan to screen 2,000 participants. All of them have to be above 65 years of age. And we want to do this in 8 months. And we want to demonstrate that the screening, a technology-based, ideally completely digital screening tool can actually reach these populations at a high percentage. How is the study designed? We'll initially invite people to participate, and that will be done through letters written to them, but also through electronic means. Patients can then register and agree and consent to participate in a fully digital process. This process can be supported by living people in person as needed, but we hope that it works fully digitally. And the people will then agree to be screened, and you'll hear details of the technology in the next talk. And those in whom atrial arrhythmias are detected are then offered further ECG screening, for example, with an ECG patch. So we have to await these results, but let me summarize what I wanted to talk to you. What do we know about technologically advanced screening for atrial fibrillation? First, is obvious, early detection of atrial fibrillation has huge potential to improve health for affected patients, but actually even on a population level, by enabling early anticoagulation, also enabling early rhythm control, and early detection and treatment of concomitant cardiovascular conditions in patients with atrial fibrillation. Screening using current methods, and as doctors, we are used to Holter ECGs or ECG monitors or ECG patches or implanted devices, is resource intensive, is not very sensitive, it misses many people, and it requires expert analysis. So it does not only cost money, it also takes a lot of time. Technologically enhanced screening using consumer electronic platforms can detect frequent and infrequent atrial arrhythmias. And that has been shown for several devices and several approved algorithms. So what do we not know? What do we need to find out now? We don't really know whom to screen or how to identify at-risk populations. Is it just elderly? Should we just screen everyone above a certain age? Or should we focus on people who've already had an event, stroke survivors, where the risk of recurrent stroke is the highest, but on the other hand, where something bad has already happened, which we want to prevent? Should we maybe consider to use biomarkers to enrich elderly populations or other populations for those with a high risk of atrial fibrillation? Or should we focus on those who come to our healthcare system in the first place, or a combination of these? We also do not know, as I've shown you, how to react to rare and short atrial arrhythmias detected by screening. Should we only start anticoagulation after ECG documentation? What is the limit of normal? How much of a very short and rare atrial arrhythmia episodes can we accept as within the norm? And equally important, where is the threshold where we would have to initiate therapy? And I do think that the ongoing studies, for example, NOAA and Artesia, will give us answers to some of these questions based on patients with implanted devices. And my final point is that now in my community, there has been a bit of talk about how technology will replace healthcare professionals. I think that we will actually need more health professionals to process the data and to implement treatment strategies once we start screening at the population levels. It's clear that the long-term monitoring of biosignals, I've talked to you about rhythm and atrial fibrillation, can potentially help to detect chronic cardiovascular diseases. But it also creates new disease entities. I've already talked to you about atrial high rate episodes, and we need to generate evidence for that management. But most importantly, in my view, from a perspective of training and development of health systems and health professionals need to revive and retrain old skills, including the art of integration information into good decisions and to navigate the opportunities and challenges provided by technologically enhanced screening. We as doctors, as nurses, as pharmacists have to relearn some of these old skills to cope and to integrate information from these amazing new data sources into care. Thank you for your attention. I look forward to comments or questions.
Professor Kirchhoff, thank you very much. My team prepared some questions. I would like to give you the first question. What is your opinion about the impact of COVID-19 to additional risk of thromboembolic complication of AF due to the fact of changed coagulation status in COVID-19 patients?
So let me first start with two general statements. One, COVID-19 was not entirely unexpected, but hit us really hard. And two, I'm truly impressed at the speed by which the global medical and scientific community has adapted to this new challenge. We now know that COVID-19 creates a prothrombotic state and that thrombotic complications during the acute illness are a major driver of morbidity and mortality in COVID-19 patients. And we have therefore learned how to treat them with anticoagulants during the acute phase. I think there is actually another aspect. And when you look at countries, and I know most about Europe because that's where I live, that were hardest hit by the COVID pandemic in the first wave, you find that the excess mortality, for example, in northern Italy or in parts of Spain, is only in 50% occurring in patients who had COVID-19. And 50% of the excess deaths are due to patients who've never had COVID. And many of them die because of untreated heart attacks, undetected strokes, undetected atrial fibrillation, but also of untreated cancer. So I think that the wider impact of COVID-19 on thromboembolic complications has been that we have, by necessity, withheld care from patients in whom these events could have been prevented. And I do think that we have learned how to use digital means to offer care during a pandemic, and that hopefully during the second wave that's now starting, we are potentially in a better place to prevent these additional thromboembolic complications.
Thank you. There's another question. Are there large-scale AF screening programs on population level already in place or at least planned in Europe? Mm-hmm. If not, what are the reasons?
So the Europe-wide, there is a recommendation to do pulse palpation and opportunistic ECG screening. And I think that this is actually implemented in quite a few countries in Europe, and, for example, combined with routine health checks or with flu vaccinations and other healthcare contacts. Several countries with established public health systems have judged that ECG screening on a population level is not yet ready for implementation. And I know that there are ongoing studies in Sweden that test a screening-based, an ECG-based screening for atrial fibrillation and compare that with usual care. So that I do think we will have more information on the societal impact and the benefits of systematic ECG screening in a few years. And I would hope, if these studies show the expected benefit, that we will have a population-based screening programs in a few years. At that time, we may end up doing them using consumer electronics, which of course was not possible or not even imagined 10 years ago.
So there's one more question. We know so much about the relation between AF and stroke. We have technologies to control heart rhythm like wearables and apps. So what is needed to translate theory of prevention into practice?
This is a brilliant question, and it's a big question. I think the short answer is, one, we have now data that early rhythm control therapy helps to prevent strokes in addition to anticoagulation in patients with recently diagnosed atrial fibrillation. And that is a new but important aspect of treatment that we have to implement now. Two, not everything that is detected by a continuously monitoring device has the same stroke risk as ECG-detected atrial fibrillation. And it comes back to this concept of magnitude synergism that I've tried to explain to you. So in short, we don't know yet whether we should anticoagulate patients in whom we detect 1 or 2 short episodes of atrial high-rate arrhythmias per year. And ongoing studies such as NOAA and Artesia, and probably future studies implementing consumer electronics, are needed to establish whether anticoagulation is beneficial for those patients. Those are, in my view, the 2 main reasons why we are not yet acting on everything that is detected by a smartwatch, and also not giving smartwatches for free to everyone above a certain age.
Professor Kirchhoff, Paulus, so you generated a bunch new questions.
Okay.
How we can overcome the challenge of e-health/digital health literacy among population to facilitate implementation of consumer health informatics?
Now, changing complex system is difficult, and changing behaviors of people is even more difficult, but it can be done. There are different barriers between consumer electronics and the data that are generated and the healthcare systems that are digital. My daily work is happening completely digital. And when I use a piece of paper, it is for my research, not to treat patients or to capture their data. But the requirements for data protection and data safety and data ownership for medical data are much higher than the requirements that are that we currently impose on manufacturers of consumer electronics. And therefore, it is difficult to integrate them from a data handling perspective. It has also been very difficult for the medical community to cope with the sheer amount of data that we can access. And this is something where I would say we as a medical profession and as academically active physicians have a role to enable and enhance that. Both of these things have actually been sped up a little bit through the pandemic because of the need of remote care, but there is still a lot to do. And thirdly, I think we need to accept that the vast promise of big data, including artificial intelligence in all its ramifications, will generate interaction, will generate associations. And one thing that we have learned in medicine over the last 50 or 70 years, and I would say that cardiovascular medicine is one of the drivers of that, is that evidence-based treatment, one, requires randomized trials, and two, treatments work best when we understand why they work and which disease process they tackle. So that a lot of the big data science that is very exciting and currently going on is, in my view, hypothesis generating and will need testing in controlled clinical trials.
Professor Kirchhoff, I'm very happy about this. It's really enthusiastic how I feel the enthusiasm you're working on it, but also the structure and also the critical questions behind that. But I'm also happy. So thank you very much. Stay with us for the discussion. And now I would like to come to some good news. So it's another presentation from Germany. So it's my home country. And I think we are sitting not far from each other, Paulus. So I'm in this hotel here in the Fontenay. And you, I think, 1-2 kilometers away in the UK University Hospital. So the good news is that we have really a very concrete case study in Germany. So now we will hear the Germany's first smart managed care program for population-based AF detection and stroke prevention. So Thomas Hübner, who will present, is a serial entrepreneur with an 18 years background as CEO in life science companies. Preventicus is his latest digital health venture, providing game-changing solution for cardiac rhythm monitoring and stroke prevention. So Thomas is co-author of 20 peer-reviewed scientific publications and has filed 30 patents. So innovation in healthcare will not be possible without these strong entrepreneurs and investors like Thomas Hübner from Preventicus, who are transforming scientific findings and policies into reality. So make this work, sorry. So he made this world a better place in the healthcare context. So Thomas, let us come to Germany's first smart managed care program for population-based AF detection and stroke prevention. The stage is yours.
Lupo, thank you so much for your warm introduction. And following the talk we already heard from Paulus, I would like to introduce you a little bit what we can do, making use of new technologies and how to bridge the gap between the new digital technologies we have in place and bridging the gap to the standard of care and to the treatment strategies with safe evidence. So just to give you or just to repeat a little bit about the relevance of stroke, we have here in Europe every year to face 1.1 million of strokes every year, causing 16 billions of treatment costs every year. This is only or the treatment costs may rise if you also consider additional healthcare costs, social costs, productivity losses, etc. Unfortunately, and mainly due to the aging of population, we have to face the situation that the stroke rate will still increase in the upcoming 15 years. It's expected that we have to face an increase of stroke by approximately 34%. Fortunately, the survival rate increases year by year, but on the other hand, due to the situation of more strokes and due to the situation of more survivors in strokes, the treatment costs are going to explode. And that's why ongoing European strategies focus on detecting as early as possible the major risk factors why it may come to a stroke, such as early detection of hypertension and atrial fibrillation. This is one of the key challenges we have to face nowadays. We have heard that approximately a third of all strokes is somehow related to detected but mainly undetected atrial fibrillation. If someone has atrial fibrillation which is not under treatment, it increases the stroke risk at least 5 times. Atrial fibrillation is one of the major risk factors for a stroke. We have to face in Europe more than 5 million people, not with AF, but with undetected atrial fibrillation. AF has a situation that comes and it goes in the early years sporadically and often without any symptoms, which makes it very hard to capture. The standard of care, usually the Holter ECG, and we have good evidence and good publications that in early years of atrial fibrillation, when AF episodes occur sporadically, it fails in 75% of AF cases, which means only 1 out of 4 patients with sporadic AF are really confirmed by the standard of care, the Holter ECG. We have guidelines from the European Heart Rhythm Association, but also now from the European Society of Cardiology to suggest, and we will go in this direction a little deeper right now, they suggest making use of available technologies to opportunistically or systematically screen for AF. Now we have seen that some devices are suitable, such as blood pressure monitors, such as pulse palpitations, auscultations, but also using, for example, smartphone cameras and wearables to identify rhythm disorders by analyzing the PPG signal. One example is, because it's a case study, one example is preventive heartbeats. It's an application which runs on a smartphone. I hope that's visible via Zoom. If it is slow, please let me know. The application takes the camera signal, which is placed on the fingertip, and films the blood flow. And those PPG data are sent to the cloud service, and the cloud service sends back within less than a second a result, which looks like an ECG rhythm strip. It analyzes the RR intervals, and it suggests if it finds any abnormalities. It can distinguish between a regular heart rhythm, between some ectopic or irregular beats, but especially if it turns to an absolute arrhythmia suspicious to AF. This is doable just with a smartphone camera. And going back to the guidelines a little bit, so far we have a high recommendation class of 1 that suggests opportunistic screening of AF should take place in patients from 65 years or older, and very systematic approach to screen for AF should be applied to people from 75. But on the other hand, or additionally, if we do an opportunistic or a systematic screening, the guidelines suggest that the people who are identified with a positive screening result, they should be referred based on a structured pathway for the subsequent clinical evaluation. That's why the preventive approach, and you will see the numbers later, is not based as in many other attempts with an initial ECG. Now we just use this smartphone camera or even this technology inside wearables to systematically screen patients. Now, the advantage is that this technology is available right now. In case of any positive screen results, the data will always be double-checked and verified by ECG technicians and subsequently by cardiologists. And only if a cardiologist medically confirms absolute arrhythmia, only then those people are led over to the subsequent next step, which is performed by a 14 days ECG patch. The whole procedure can be operated fully telecardiological to make or to face the challenges of not having physical or regional cardiologists in any place for the second step, but also to address ongoing pandemic challenges where we want to minimize the contacts, especially of older patients, because we have to go to cardiologists. Just to give you some ideas and some numbers about this smartphone technology. It's a fully certified medical device. The analysis is done here in Germany on German servers. Compared to many other participants in the market, this PPG analysis, it's a complex mathematics, it's a complex signal processing, is not in our case performed on the smartphone. It's always performed in a cloud service. It needs a high calculation power, and so far we did it more than 10 million times per day, approximately 10,000 times here on the German servers. This application itself, it always ranks among top 3 of the most successful German health applications. The same technology is also available in smartphones, in smartwatches. The preventive heartbeats for smartphone is the first contact to the patient when we do population screening, and the continuous monitoring with PPG is used for monitoring patients at a higher risk, for example, after a cryptogenic stroke. Clinical validation and accuracy, and especially positive predictive value, is of key. Our application has been tested in several international multi-center studies with an accuracy around 60 or 96%, but especially with a very high positive predictive value of 99%. Which means in our case, 99% of the patients who are identified with a positive screening result has been confirmed afterwards with a subsequent Holter ECG. PPV is key. That's my message. If you see studies from other companies, in preventive situations, more than 90% can be confirmed with an ECG. In other studies, we have seen the situation, and that's why this approach is not, or there's no general answer possible. Should we recommend consumer electronics for screening? Because you can never be sure how accurate the algorithms from any other market smartphone makers are. In the Apple study, we have seen, it's just a recent study that showed that 90% of the patients with an irregular finding on the Apple Watch cannot be confirmed with a subsequent ECG. This may have several reasons, and one reason may be if the subsequent step is a standard Holter ECG, and I told you that within 24 hours, it's unlikely to reconfirm sporadic AF episodes. Just to give you an idea of what's going on with other studies in this field, we have financed or co-financed by the European Union. We have a so-called Red Stroke study, which investigates mainly the diagnostic yield of that smartphone screening-based approach in different European countries. We find systematic differences in the diagnostic yield. In some saturated healthcare systems like Switzerland or Germany, we usually identify 3% of so far undetected AF, and in other Eastern European countries, the diagnostic yield, as we already see, is much higher compared to markets like Germany or Switzerland. Paulus already mentioned the ongoing trial, Smart and OEC, the feasibility study, and also ongoing studies and efforts take place, not only to identify atrial fibrillation, but also how to monitor and how to manage those patients better when now, if this disease is already diagnosed, but in order to better manage and to better find treatment decisions. The second step of our approach is always those 14 days Holter ECG, because the confirmation rate in patients with sporadic AF increases the longer the monitor. This is a nice graphic from iRhythm. It shows the longer the monitoring, the higher the probability of capture arrhythmic events, whereas in the first 24 hours, comparable to standard of care, the identification rate is 25 or 30%. The longer the monitor, the higher the probability of capture of confirmed AF episodes. Any period longer than 7 days usually increases the detection or confirmation rate of 90% or higher. The guidelines recommend not only the detection of AF, but especially once AF is detected, it needs further parameters to find or to define the treatment strategy. And one of the key parameters here is burden. It makes, as Paulo said, it makes a big difference if a person only have a couple of episodes in a year, or if the burden rises up to minutes or even hours per day. And that's why we always suggest not just to identify AF with a mobile device. It's from our point of view important, but we have what we identify safely AF, but then also to quantify the relevance of AF by analyzing the burden and other clinical parameters. To give you some practical examples how preventive course managed care programs work. Managed care is doing or is managing here in Germany the whole process of identification of atrial fibrillation. We are contracting with a health insurance. We have a situation here in Germany what we have more than 120 different health insurances. Is in this regard at least a very fragmented market, and that's why we found solutions to let several public and from January on also private health insurance participate under one umbrella contract. This contract is now here in Germany cleared by the Federal Office for Social Security, and this systematic approach to identify patients and to subsequently confirm them is now open to every public and even to any private German health insurance. And currently we have, that's why I said it's the first, and at least by the number of participants, the largest one here in Germany. We have now more than 6 million insured lives who currently start to roll out that systematic AF detection. Just to give you an idea how this managed care works in reality, the insurances we are addressing usually every insured people over 55 by providing them an invitation letter and explain why it is important to look to screen for atrial fibrillation. The people can download the application, and the application also allows the people to enter into the special care contract. Now, the legal base here in Germany for those care contracts is made by the so-called Digitales Versorgungsgesetz in combination with Social Security Code 5, paragraph 140A, special care. So the app, and Paulus said, there's so far no recommendation for systematic population screening unless we consider further risk factors. That's why the application always asks if about what's the age of the patient. The patients are allowed to enter either over 65 or over 55 if at least 2 more risk factors apply, such as diabetes or hypertension. Then the people start to measure regularly. That means in the first 2 weeks, every 2 times a day, and after 2 weeks, twice a week, and always in case they feel palpitations. If it comes to suspicious findings, those measurements will always be double-checked here in Germany, first by ECG technicians to make sure that the data technical quality is there, and subsequently by the cardiologist. And only a cardiologist can return medically confirmed positive screening result to the patient. And the patient's, this is a telecare service, which means the positive data are clearly analyzed. We have the ECG technicians, we have other parameters to justify if a measurement is regular or if we have any artifact. And only if a measurement is technically clean and medically verified, then those people are led over to the closest regional cardiologist, or those people who need the subsequent ECG service can alternatively get the service remotely, which means this ECG patch is sent via mail to them, and those people are supported by ECG technicians via phone to apply the ECG patch. So this patch can take on this, can go on the patient for up to 14 days. It automatically sends the data automatically to the telecare service and to the physician. So always during the investigation, the ECG is visible to the cardiologist. And in between, the telecare service also technically analyzes the data, because always a lot of artifacts are usually inside 14 days of ECG. And if the patient sees his doctor for the second time after 14 days, the telecare service has issued an telecare report 2 hours before, in order to let the doctor, if he sees his patient for the second time, he can make use of a cleared report, which is free of artifacts and only highlights the true AF episodes which occurred over the 14 days. So at this time, the special care ends and the final diagnostics happens here according to guidelines. As we said, it's not just enough to see AF if it is occur or not, but also to quantify AF and to also use further risk factors and to do further investigations such as echo or wet labs. At this moment, from this moment on, those patients go back into their regular care with a treatment suggestion, mainly with NOAC, with anticoagulant, but also with other treatment strategies that may apply. So just to give you an example how this managed care program is technically backed. Now, on one hand, you have seen the applications for the end customers, such as preventive heartbeats, which is to enter into the managed care contract, to digitally sign up, and especially then to screen and to regular measure. When those data or with measurements go automatically to a telecare platform to let medical ECG technicians and cardiologists verify the data. The doctors who do the subsequent next ECG step, they use a CareNet platform. This platform allows to start the ECG service, to see the ECG data, but also the reimbursement is handled via CareNet. And last but not least, the health insurers itself, they use a platform called CareSafe, and in those platforms, all managed care contracts are stored. The specialty here is that all participants of a managed care do not have any personal data. Once the patient enters into a special care contract, he types in his contractual data that go directly out of the application directly to the CareSafe of his health insurance. This health insurance shares a unique identification code per patient into the CareNet. So all participants of a managed care and even Preventicus itself, they don't have any personal data from the patient. Once we collect the reimbursement data every quarter, we're sending back to the health insurance only a pseudonymized data set, and only the health insurance can merge the personal data with the pseudonymized reimbursement data. That's why we can, or the best even if we have a high standards here of data protection and data security, but the best way is to avoid that anybody who does not necessarily need personal data, who should not know personal data. So in terms of cost effectiveness, we got, after the new guidelines came out, we got our cost effectiveness validated, and this was a very a novelty. We have been able to show that a systematic in age independent or in risk factor independent screening in patients over 65 will lead per 100,000 participants to a cost reduction of around 13 million euro, and it will avoid 600 strokes per 100,000 participants. This is always we hear about that in the breakout sessions. For those ones who join the breakout sessions, is always the difference of a systematic screening versus a standard of care. And only in this cost effectiveness, we have only included the direct treatment costs. If also additional costs would be considered, the savings because of reduced strokes may double when we take all those productivity losses and social care costs also into account. That means we have, of course, we have a social and a medical benefit, but also for the health insurances, a health economic benefit in this regard. So just to give you an example of what it would means if we, on an example in Germany, well, we speak about a population here in Germany of approximately 83 million of people, and 31% of the German population has an age between 55 and 80. So those ones would be addressed for this systematic screening. And according to our ongoing projects or completed projects, we can see on the first 100,000 participants that we usually reach a real participation rate of approximately 10%. That means 10% of the people who receive a letter from the health insurance are actually participating and fulfilling the inclusion criteria. Not everybody who is receiving a letter fulfills the criteria. If someone is 57 without additional risk factors, he will not be allowed to enter, and only the ones who, or 10% out of them who getting a letter are fulfill the criteria and are willing to participate. And if annually, really in a full rollout, 2.5 million people would be participating, we would be able to, according to our studies at least, we would be able to identify at least 3%, which means 75,000 newly identified AF cases, which would correspond to approximately 15,000 of avoidable strokes, according to the newest health economic evaluation. So coming to my final slides, care coordination, it's a puzzle. You need to consider many pieces which needs to fit to each other. If anyone falls out, the whole process may be endangered. Is not enough to just have a good screening technology unless this technology is not incorporated into a guideline-conform structured pathway. And also we have to, and this is my final slide, we have to face that just for one disease, it's hard and it's complex to define a managed care program, but we also need to look for other diseases, to other areas with managed care programs, and we all need to go under one umbrella. It does, even if stroke belongs to one of the most relevant diseases, but from the perspective of a health insurance or even of a governmental health provider, it needs all to fit under one strategy. And this is the ongoing challenges now, how to create the interoperability, how to make use of a very special care concept which focus on one dedicated area, but it has to be in line with other concepts like skin cancer screening or whatever. This is an ongoing challenge to make them compatible with the overall strategy and the overall IT structure. So thank you so much for this presentation, and I would I'm happy to discuss further with you, either now with some questions or maybe subsequently by email or other chats. Thank you so much.
Thomas, thank you. Thank you very much. I got my voice back. So we have here from the audience 3 questions. The first one, can you please point the importance and benefits of smartphone screening of AF, especially during this pandemic?
Yeah, we have seen during pandemic situation that it affects people being at the people with already existing cardiovascular risk are especially or have to face especially increasing risk if they got an infection, and we can see it very clearly in the last months. The percentage of users quite doubled. So the awareness is very, and especially in those times, if we have on one hand increased risk situations especially for older people, and on the other hand we need to avoid too many personal contacts, such an approach which is instantly available in everybody's pocket, which systematically leads those ones who really have an issue to the next cardiologist or telecardiologist. I think that fits ideal in such a pandemic situation with reduced resources, but on one hand, but on increased need on the other hand.
The next question, how long did you take? No, how long did you take, Dr. Hübner, so Thomas, you, from developing the idea for Preventicus heartbeats to the managed care program? What were the greatest barriers, and where do you still see room for improvement regarding the implementation of digital innovation into healthcare systems? So what are the greatest barriers? So how long you take, and what was the greatest barrier?
Yeah. How long does it take? It's a very, very good question. So I started Preventicus 6 years ago now. We have been one of the first companies in Germany in this area of digital health who did it seriously, which means it was not clear 6 years ago if those measurements with a smartphone with wearables, if it is already a medical device or if it is somehow lifestyle. In the genome of Preventicus, right from the beginning, I printed that we do it like a medical device company. I have a medical device background, and I applied all the norms which apply for real medical devices. From the beginning, we fulfilled as a medical device manufacturer. So it took us approximately 3 to 4 years to be technology mature, which means that we created an accurate technology, that we got all those certifications, ISO, CE mark, etc., that we got the clinical validation. And when we thought having that technology ready, we did 80% of a job, but I failed. It was a major shift from having a technology ready to nowadays being able to complete the care continuum. That means to provide the technology, but in combination with a managed care program. I did not expect that it takes so long to make use of the technology and to formulate a managed care pathway with integrating the physicians, having reimbursement for them available. We had to set up the corresponding IT structures beside the measurement with a smartphone app. Now we had to create telecare platform, the CareSafe platform for health insurances, the CareNet for doctors. It take us another 2 years, but in Germany, at least, to formulate the legal base for managed care, it took us 1.5 years. We have a lot of ongoing, fortunately in Germany, a lot of ongoing changes. due to the new Digitales Versorgungsgesetz, due to the novelties in the Social Security Code 5/140A, which regulates the standards of managed care. But still, it took 1.5 years to get everything approved by the upper federal office to get the approval for managed care. So fortunately, when I founded Preventicus, fortunately at this time, I only have foreseen the technical issues, but I have not foreseen the barriers in getting such a managed care program in the market. Fortunately, it came step by step. Now we are through in any regard, but if I would have seen those hurdles before, maybe I'm not sure if I would be in the position to speak to you today.
The greatest barrier is the regulation, right?
Absolutely, yes. To have so many new aspects, if an application comes out with a positive screening result, this is usually something a physician is issuing to the patient. So we had to deal. How can we combine the algorithms coming out from an applications with a doctor's decision? So many new aspects. In constantly changing legal situation here. Fortunately, legal situation, because 2 years ago, the legal base in Germany would make it impossible to define such a fully digital managed care program. This essential paragraph, as Social Security Code 5, has undergone 3 major changes in the recent 18 months, and only with the latest change and enhancement, it now complies totally to this managed care program.
So the last part of this question, so it's a tricky question, one with 3 questions. So where do you still see the room for improvement regarding the implementation of digital innovation into healthcare systems?
Interoperability, as I have shown you, it's on one hand it's vital to combine this new technology aspects we can make use of, but we have to find a way to integrate them with a regular care. And it also took us long to find the proper stepwise approach of the whole patient journey. But secondly, we have to see the upper norms. We have the patient records, for example, and we have to make them compatible. So even if we now have a good managed care program for a certain disease, but we have to see the whole story. We have to make fit our managed care program in the overall strategies, in the overall IT infrastructures. And this is indeed, this is a major issue to really define a smoothness or a smooth interoperability with all those overall standards.
So the next question, can a medical center or a public health authority in other countries implement the managed care program by Preventicus? Is it dedicated to health systems with private or public reimbursement models?
In Germany, we have a clear legal base now for public health insurances, and from January on, also, that's a new thing, and you may also understand more about this in the breakout session. Even private health insurances can enter into a managed care program, which is originally defined based on the SGB5, so made for public health insurances. Any adaptation to other health schemes need the same legal clearance. Every country has its own legislative how to deal with special care or managed care programs, and every country or for every country we needs to fit into the existing legislative.
Thomas, thank you very much. Ladies and gentlemen, so we will have a break till 1:30 p.m. sharp. So please be back on 1:30 sharp. Then we will hear the thrilling presentation from Professor Dr. Nick Goldemont, Professor of Integrated Care and Technology of the Sechenov First Moscow State Medical University. He will speak about the lesson learned from an European Innovation Partnership on active and healthy aging to implement better health and care in regions. But parallel to that, and Thomas mentioned it, we will have a German language breakout session from 1:30 sharp until 3:00 p.m. in the afternoon on digital managed care programs in Germany. This breakout session is in German language and by personal invitation only. So it is with Dr. Constanze Püschel, Christian Mevers, and Dr. Stefan Wahler, and will be moderated by Thomas Hübner. So for all participants of the main GCCCF CARE 2025 conference, please be back at 1:30 p.m. sharp. So see you in 1 hour.
morning. Oh, he's so suntanned. I go away now.
So great. So you are then the next.
Mm-hmm. Very good.
Yeah. Did you monitor us so far, or?
Well, because it was quite early, and I had also a meeting just before this one.
Okay.
So I didn't catch much yet of the conference.
Well, Chai Chua were from his 10 hours in the front. So
yeah.
He was with us, and I was very happy that she is. And you are, it's early in the morning, yeah?
It is, yeah.
So we have 4 minutes. So how is the status? Biden won?
No, I don't think so yet. It's yet unclear.
that has to be unclear.
Yeah, I didn't saw any. Well, he's won another, or he's ahead in one state, Arizona, I think. Well, anyway, well,
okay.
We will see.
Don't speak politics. So I'm really happy that when you thrill now the people, we have on parallel, some people are on the German-speaking breakout session, but I think the majority is with us. So.
Oh, nice.
Well,
very good.
Nick has half an hour.
Yeah, that's okay.
Yeah?
Yeah.
Good. Don't bring me in trouble with the time. Okay. So it's very different for me.
Yeah, it's...
So we have 1 minute. Okay.
Genau, okay.
Left, okay. Thank you, Nick. Ladies and gentlemen, so let us proceed with a very haptic presentation and inspiring lesson learned from the European Innovation Partnership on Active Healthy Aging, EIP, and on AHA to implement better health and care in regions. Dr. Goldemont, Nick Goldemont, is professor of integrated care and technology at Sechonov First Moscow State Medical University and senior researcher at the National eHealth Living Lab of Leiden University Medical Center, Department of Public Health and Primary Care. He holds a degree in medicine and electric engineering. So during his career, he worked as a clinical researcher on numerous health innovation, pharma, medtech, health IT, AI projects. He is key expert on eHealth and integrated care for various governments in different continents, NGOs, multinationals, and startups. And I know, Nick, you are now in Curacao, and I'm happy for you. Now, Hamburg is calling Curacao. It's your stage.
Wonderful. Thank you very much, Lupo, for this invitation for this conference. So I'm going to talk about the EIP, European Innovation Partnership on Active and Healthy Aging, and lessons learned. And it's the idea it's an example of an attempt of the European Commission to build a community across Europe to tackling the challenges with an aging society. So I will give you some insight on how the program was developed and was performed over the last 10 years. And I think it's a very interesting case on how you can mobilize actors across different countries on important topics for health, for growth and prosperity of a continent. So let me give you some insights and also some implication in the context of the situation where we're currently in with COVID. So let me share my slides. All right. Yes, so I'm affiliated to different organizations. Basically, my daily work is transformation of healthcare systems on a policy level, strategies, but also more concretely in local settings, etc. So a bit commuting between the policy side and the operational work, and also in different settings like developed countries, but also favelas in Brazil, for example, or here in Curacao on an island with certain characteristics. So if we look back already, more than 10 years, this topic of aging societies was on the agenda, because already at that time we know that that the aging societies will have a huge impact on economies, on healthcare systems. And just to give you an indication, the age dependency index is one of the economic indicators which show the dependency on the working people and the older people, the dependency of the older people on younger people in the economy. And in 2007, this was 1 to 4, one elder person and 4 working people. Well, in 2050, this will be used on average in Europe to 2 working people to 1. And here you can see really the challenge. These 2 people are responsible to keep economy going, running healthcare systems, administration, educating children, etc., etc. And also paying back the debts we made due to economic crisis. So you can see really the challenges already were known at that time, and that we had to do something about the effects of aging on society. And besides that, this is almost true, this is true for almost any part of the world, any continent. So Brazil, Russia, China, obviously, Asia has similar challenges, if not worse, compared to Europe. And we know that over time, while people are getting older, it goes together with problems in health. So on the right-hand side, you see a picture, a diagram, which show the diseases, the comorbidities of people over time in the Scottish population. And you can see the tremendous impact. At the age of 65, that almost 80% of the population, this population has, one or more chronic conditions. So, and this poses obviously more dependency on health and social care and an impact on economic growth. So the challenges are huge and comparable with the impact of the COVID crisis, only it takes a slower effect. So it creates instability of healthcare systems, and it creates accordingly also an impact on economies and growth for the whole society. So it's not only an aging issue, it's a societal issue, the same as climate and energy. And therefore, the European Commission took responsibility about 12 years ago. We have to do something to anticipate that. And now we have also the reality of pandemics and their impact on society. And it's interesting to learn that although this knowledge was all available, reports were written, and politicians and leaders in countries were informed about all these risks. And what we basically see is the inertia had to change systems accordingly to anticipate. So it's an important lesson. This is not something which is come from clear sky. This was already predicted and forewarned, and you can see this inability of countries and governments in making this systems more sustainable. So just to give you one example from the UK, these are pictures from flu outbreaks in the last couple of years. You saw ambulances waiting outside the hospital, couldn't deliver patient because the EMR emergency units were overflowing. The beds were occupied. The patients couldn't be discharged because social care was not well arranged. Healthcare workers were overpaid. And each year this comes back again. And the same is in the Netherlands. Maybe not for all the country, but in some areas, ICU beds were fully occupied by patients with flu. And yet, also our government didn't take appropriate measures. So it shows the importance of these type of programs or for the longer term to anticipate these threats for economies. So accordingly, the European Commission started a program on active and healthy aging as an important measure to prevent vulnerability in elderly and also to increase productivity. So it was at that time, I'm talking about 2011, it was a new EU initiative. It was also accompanied by new instruments. It should be led by stakeholders, not by governments or the European Commission. And it was also, it had a sort of multidisciplinary approach to engagement. Industry, public, private, research, healthcare organizations. And the objectives were basically in line with the challenges, was had to extend the healthy life years of people aging, and thereby improving sustainability and efficiency of social and healthcare systems. And also try to, in parallel, work on innovative solutions, because the rest of the world also needs solutions and approaches in this respect, and competitiveness. So there was different rounds of consultations were organized, roundtables, online consultations, and accordingly through a process, priorities were determined, defined, and there was sort of the idea, okay, we should establish sort of framework. I won't go into detail, but so there were different pillars in which several sub-themes were grouped. There were horizontal themes like IT and etc., rules, regulation. So it was quite comprehensive. And based on such a framework, an implementation plan was formulated. So how does this sort of strategy framework translate into actions and engagement with stakeholders at the regional level? And this was in September or November 2011. It was formalized and agreed by the stakeholders. So the movement, the operational sort of model was that it consisted of action groups which were related to themes mentioned in the framework, and the sort of locations for actions to implement were called so-called reference sites. So there were regions across Europe enlisted to say, okay, I want to help with this program. I want to implement these sort of strategies and solutions, including technology, in order to tackle the challenges related to an aging society. And these were called reference sites. And there was also a mechanism built in, an instrument to collaborate between the regions so that they could learn from each other and exchange ideas. So here you see a description of the 6 action groups, the thematic, adherence to prescription, which is a huge challenge, falls prevention, a very practical theme, and which is also a huge problem in most countries with aging societies, with a huge burden on the healthcare system, with the consequences, functional decline and frailty, a more fundamental oriented action group, integrated care system and organization oriented, independent living solutions, basically an IT oriented action group, and a more, let's say, broader sort of environment oriented action group, not only the physical infrastructure, but also more policies and regulations oriented for age-friendly environments. And on the right-hand side, you see the first depiction of regions involved in this, and you see clearly that Italy, Spain, the Netherlands, the UK were quite prominent in enlisting with stakeholders in action group as well as with regions. I think at the beginning there were a lot of research, academia type of organization were involved because, yeah, obviously they are interested from a thematic point of view, but also the hope of they getting budgets for further research projects. So there were quite a considerable number of public administrations and NGO type of organization, healthcare providers as well. The industry and SMEs were a bit reluctant in the first stage. So after a couple of years, there was a new sort of reform on policies, and also the Commission attempt to align other related policies into a more unified strategy on the stability, sustainability for economy, working on social cohesion and employment, and also tackling these challenges with aging. So it became more harmonized over the years with the lessons learned. And in 2006, at the beginning, the participation interest was really high, and also the intensity of collaboration was also quite considerable. Considering also the extent of these networks, European-wide, different stakeholders working on relatively abstract topics, but making it also more concrete when they work together or worked within the regions on implementation. So already then, it was against all odds, it was quite a success that at the European level, a program was able to mobilize so many people on one topic with a shared vision, and often without support of member states. So the regions were specifically addressed from the European Commission, and some of the countries, the national governments, they supported, or maybe not with so much energy, but so there were all kind of factors which didn't work really for the benefit, but to the contrary, it became quite successful. You see here the sort of topics mentioned in alignment and etc. With investments, try to raise investments for the initiative, to reach out to people, etc. Extend the number of regions. And also there were some documents formulated which referred to the aging topic and how we can make a benefit of it, how digitalization and the single digital market fits in this approach, and also the economic sustainability. And again, I think this was quite an achievement if you look to the very limited sources where the different countries or organizations, as well as the European Commission, had to work with in this program. So in 2016 or 17, it was there was a new call for commitments, a no reach out to organizations to participate in the initiative. So at that time, we had about 850 new commitments from small and larger organizations. The diversity of stakeholders further increased, and we ended up with almost 80 reference sites, so regions in Europe from 22 member states interested in working together on making their region more sustainable in an aging context. So here you see an overview, and also from other countries, including China, Japan, Canada. There was a huge interest on how did this approach work with the regional approach, also from Russia. So this was also a sort of indication that what the European Commission and the stakeholders were doing was quite interesting in getting people mobilized on topics. Also, in the second time frame of the program, there were also more instruments aligned with funding, with collaboration. So another indication for alignments. And if you look back, there are some results produced. And if you look at the regional level, if you're looking at collaboration, so there were many things, spin-offs from what this program achieved. It didn't receive too much attention also at the national level with the national governments. But definitely this is a a good example of how a pan-European or European work program could work to mobilize people on such a topic. I think if you look to the lessons learned and also considering the sort of challenge these countries or regions are in, you can see here a sort of summary from a healthcare perspective and healthcare system perspective, where everybody is convinced we have to move from an institutionalized type of care, which is very reactive, is very monodisciplinary oriented, to a more integrated system where we have a stronger role of primary care, offering a broad range of services, not only medical, but also social and other things people need, and also a stronger involvement of people in this attempt. So the program definitely had actions to work towards this. And collaborations were established, but still this is quite a challenge to achieve. And not only at the regional level, but also on a nationwide level and a European level. And still you could say, also now with COVID, that we were not prepared, and still we are not prepared. We have to do things extra. We're only at the beginning of achieving a sort of model, as you see here on the right-hand side. So meanwhile, if you look globally, all these plans about more personalized care, digitalization, over the last years, it has been populated. And obviously, a lot of consulting firms had their nice presentations with PowerPoints and did work on these plans. Yeah. So if you look to these plans, a lot of commonalities and obvious topics are presented. If you look to the implementation, however, there are not so many countries who are really successful in implement these type of approaches. There are some regions, there are some good practices, but still we have wonderful plans, but not so much a very effective implementation strategy for change. If you look and do a sort of mapping on, okay, how good is a country able, does a country have the ingredients to make this change towards more personalized, integrated care successful? You can look at all kinds of indicators from policy, technology, infrastructure, organizational sort of power. And you can make a list and ranking, and you see here the Netherlands quite well ranked. And it does give you an indication on how much is a country prepared to make this change happen. However, I told you about the Netherlands, my country. Although we have so much ingredients to make the change successful in integration and personalization, we are also considering the huge IT, wonderful IT systems we have. So in terms of infrastructure, population who is digital literate, we here at the lowest level of information sharing. So because of the wonderful IT systems we have, from Cerner, from Epic, from whatever type of wonderful IT system, we are still faxing the data to primary care, or the primary care to social care. So the sort of ranking you can do on countries on readiness, often, if you look more closely, they're totally not ready to work fully integrated. There are huge challenges in technology, in interoperability, in exchange of data, in alignment of finances, in how organizations work together from a social perspective, a cultural perspective. That you see within a sort of vertical pillar if you're talking about the diabetes management. But also if you look across sectors, which is needed if you want to anticipate this typical older people with comorbidities, a lot of combination of challenges, physical, mental, social. You need this integration, also collaboration with other sectors on the horizontal line. And this is often not achieved, despite all the marketing and communication on how organizations or countries are doing. So also, due to COVID, you saw the uptake of digital tools for collaboration and application in health. You saw an uptake, especially in terms of communication tools. There are some solutions which focusing on disease areas and are useful for managing diseases, but they are often standalone. So it's not the same as an integrated way of working, that it really facilitates collaboration among the different stakeholders, including the patient and the informal care, the family and friends of patients. So despite all the sort of enthusiasm for this uptake, the real challenge is a better collaboration and information sharing, coordination across different actors. And we're really, really far away from that. So I'm an enthusiastic, positive person, but I think enthusiasm and positivism shouldn't make it impossible to discuss the issues we have. And as I showed, we have really issues as COVID learns us. Another lesson is also from these attempts with working on topics such as aging and chronic conditions and IT solutions, is that all these IT solutions, it does not mean that it's more efficient. So increasingly, as globally, we see that healthcare professionals, social care professionals are overburdened by administration. Also due to IT systems, putting data in systems which are often not aligned and interoperable, and this creating also really a threat. So despite all the consultancy firms and all the IT industry being so enthusiastic and that life is really wonderful with their solutions, the reality is something different. So to also a lesson about implementation upscaling. So we are dealing with different healthcare systems. More market models or private models, such as in Germany or the Netherlands, or some are more like one-payer system type of model, as you see in the UK. So you have all kinds of forms of healthcare systems. And it's not per se that one system is better than the other. So you have to look closely towards the local context in what is needed to make change happen and what could work. So that's a good lesson to learn. And also that this attempt to make the change happen, it's a complex problem, as you probably be aware of. That it's not a single thing. You change a system, and if you only try to tweak the technology part, it won't solve other elements in the system. Or in order to make it work, you need other parts of the system, like financing or the culture, as well. So, and that points also to the complexity many of the regions were facing in this program, that in order to make a specific thing successful, you need almost a complete system change. And this is really complex. and difficult. But we can learn a little bit on what are ingredients for success. And ingredients for success is the regional level, is the engagement with multiple stakeholders who are relevant in the setting, and focusing on the people's needs, and with a sort of basic requirements on the technology infrastructure. You have a sort of context of a healthcare system, which might in which it might be feasible to make the change happen. So we know that this type of setting approach with a sort of co-creation involvement of different stakeholders in looking at the challenges, the problems, use this for discussion on what could work as a solution, and accordingly try to implement with these same stakeholders. And again, collaboration is part of getting the support for implementation later on. Is what now is be seen as the most successful way for implementation of solutions and think about improvement and change. So this process orientation, okay, where are the problems? And accordingly, what are the root causes? How can we think about solutions and how to implement them? And so this year you see a sort of graph on the process elements and the different aspects related to the care process over time, the needs of patients, the collaboration of professional, the technology, the setting involved, the data used. We use this in various studies, and how can you can use this approach, and also how can you capture the success factors from it. And I'm quite enthusiastic about this sort of approach. Co-creation and process redesign of healthcare systems. But this is the way to go, with sort of sufficient scope on the healthcare challenges to include the things which are essential for making the change happen. So accordingly, you also see that this discussion on value-based healthcare or patient outcome financing models, they can only work if you are fully integrated. So it doesn't make sense to talk about value-based healthcare if you don't align all stakeholders across the care process and do this performance-based financing. It doesn't work in a fragmented system. So the step to integration, if you really want to create value and focus more on outcomes, the solution for that is integration. Is the thing you see here on this slide. You have to align all these different elements together into a sort of integrated process. And we don't see so much the evidence yet about this value-based healthcare. Also because the sort of integration aspect and the implementation of the integrated services is still lagging behind. So, one thing maybe also to mention, so governments or payers are really focusing on the patient outcome and use this as a sort of measure for financing, or they try to focus on the outcome for their approach. But the change or the improvement is in the process. So we see quite a sort of reluctance or a sort of irresponsibility from these authorities to look at what is needed at a process level in order to make the change happen. And that often single organizations are not able to make this successful. So again, in the consultancy world, value-based healthcare, outcome-based healthcare is very popular, but it's far more complex than that. And usually they're not bothered about implementation. But if you go into implementation, we need definitely more have a subtle discussion about how it could work. That things can work with a country, a large country, on different levels with a unified approach with different stakeholders. We showed in Brazil. Unfortunately, COVID was a bit, creating barriers for further implementation. But so in different countries, different regions, we work on this more sort of integrated approach for making change happen, also in Curaçao. And what I said already, so you need both the policy level, the top level, and more the operational level, the bottom-up level. So all the people who are claiming, you have to just start from bottom up, and creativity and startups and etc., it doesn't work. We see that in the startup world, more than 95% of the startup in health, especially with technology, are failures, because there's huge creativity there, which we can use, but there's no system for adaptation. So if we don't think about the system aspects and the change needed, and only focusing on all pilots and good practices, it will never work and scale up at a level which we need for a real change for the future, which we need for future generation. So I hope to provide you some insights on the challenges with transformation of healthcare, and that what you see often on the media about successes and all this innovation talk and innovation hype things, that usually the reality is very different. And we have to pay more attention to the reality of things and be more realistic about what we can do. And that the solution is in working together, making Europe or the world stronger by collaboration, not by claiming healthcare is a national priority, because the countries can't. Even the Netherlands, where we have everything in place, they are not able to make this change happen alone. You can see it from the COVID crisis. So hopefully also in this forum we can extend the collaboration and work on a better healthcare for people together. Thank you very much.
Nick, thank you very much. You, let me say, also answered the why Global Clinical and Care Coordination Forum, because I think through this cooperation we can solve this thing. And some countries did it less, some more. And I think you opened with your presentation so much areas that we will really come over time. But I think that the people know you, and we will provide the questions after that. I would like to emphasize, and that's why Victor is with us. Please stay, because I think we also can be reflected in the discussion with Victor later. Victor Renovicki is with us, and the country with really tremendous transformational power in the last years is Poland, and they touched a lot of things. Also, the Polish people are going very pragmatic, very clear. They don't bet on illusions. They really bring things forward. And Victor Renovicki is the Director of Architecture and eHealth Services and eHealth Center in Poland. So Victor supervises the development and rollout and maintenance of the P1 platform, which is services on e-prescription, e-referrals, EHR exchange, and internet patient account are deployed. Additionally, he's responsible for digitalization of public blood services. I think he has a broad range of what he's responsible for, but very important is, and this is interesting, he has a very short, one second I have, he has a very short title. His title is Data and Health Technologies, and behind this short title is a lot more. So Victor, tell us how Poland went through this process and what is behind this short title, Data and Health Technologies. The stage is yours.
Thank you very much. I hope you can hear me well.
Very well.
My name is Victor Nowiecki, and first of all, I will try to share the presentation and see if that works fine. If you could please confirm that you can see what I'm presenting. Although, yeah, can you confirm this? Yeah, it's working okay. Thank you. So thank you very much for the introduction. I am very happy to be. Come again? Could you repeat, please?
So please put Nick on mute.
Could you confirm that you can see my presentation? Just 1 second. Seem to be.
So we are again on Nick Goldemont.
I'm trying to share screen with you, and just hold on a second. Maybe I know what the problem is. Second. Let's see if it works this time.
So the tone is still on Nick Goldemont. Can you change it, please?
Or not? I'm trying to do the share screen, and I'm sharing my presentation. Can you see the PowerPoint?
Now go on the slideshow. It's the bottom right.
Right. Is it okay? Okay, thank you very much. Okay, thank you very much. Welcome again. My name is Wiktor Nowiecki. I'm speaking to you from the eHealth Center in Poland. Thank you very much for the invitation. To be honest with you, I was very much looking forward to be there in person in Hamburg. When I was joining the roundtable in September, I was very much looking forward to this event in Hamburg, but apparently circumstances changed. So I kind of miss being there with you, and yeah, I will try to give you a presentation about what we've been doing here in Poland in terms of eHealth, and probably, as you can imagine, most of it in the last weeks has been determined by COVID-19. So I will put a stress on these activities because yeah, we've been working and we're still going to be working very hard to try to, well, do our share in the fight of COVID, and our share in this is just to optimize what can be optimized on the technological level and make the work of medical professionals well as easy as possible with the technology because they are on the front line of this battle. So I will just go through the well architecture and landscape of our eHealth ecosystem right now. We have been working on this for the last several years, and we are, well, finally can see some positive results of it. We have already e-prescription fully rolled out in Poland. We have e-referral. We have a large-scale internet patients account running in millions right now. We are in the middle of rolling out electronic health records exchange, and we will be very much stressing e-services like central e-registration and e-consultations, remote visits in the next month and next year. So quickly brief through the e-prescription a solution that we are, well, very proud of, and we are already seeing what e-prescription brings in terms of not only the e-service, but in terms of the possibilities that we can build upon e-prescription. It has shown to be very effective in the COVID times because it is a very natural way for all sorts of teleconsultations where doctor doesn't necessarily need to see the patient in order to set the prescription for him or to, well, make a continuation of a treatment. It has been really effective in the COVID times. We have a very large number of e-prescriptions right now, although we have still some leftover of paper prescription I will mention in a second. Some of the statistics of e-prescription in Poland, we have already 400 million e-prescriptions issued. That is a large set of data that is in the system, and well, that is a good basis for very advanced analysis. I will talk about it in a minute. We have already almost 28 million patients that received at least one prescription, and we have 3.5 million citizens that join the internet patient account when you can see the history of your prescriptions and so on. When I showed this slide on the roundtable in September, the number here, instead of 3.5 million, was 2.7, I believe. You can see that, well, in the period of two months, we have increased from 2.7 million to 3.5 million. Well, partly because there is some good support for COVID-19 services there. This is how the graph of e-prescription versus paper prescriptions. I always emphasize that we will not rule out paper prescriptions from the system completely for a long time. Well, I personally know doctors who don't work on any computers, who work on paper prescriptions, and will probably remain to do so for the next month or years. And this is still in place in the system. We know about paper prescription because because when the paper prescription is realized in the pharmacy has to report it to the system. That's why we know how many paper prescriptions there are. And well, the attitude of of Ministry of Health here and ours is that this is something that is acceptable, and we're not trying, at least in the nearest future, to force very much or to penalize the use of paper prescription. This is still in place, although this is less than 10%, and it will probably remain so. This is the graph of the last 30 days. You can see that e-prescription is the blue graph is has some waves and ups and downs. The paper prescription, the yellow one, is on the stable level. It will probably remain so for the next months and years. This is our survey done in April 2020 about the e-prescription, what people think about it. So especially COVID times, no need to see the doctor to get a prescription, and this is very valuable, of course, in terms of continuity of treatment and I would say not very complex issues, because of course some advanced cases need to be handled physically, but in COVID times, general practitioners in Poland do I don't want to be imprecise, but something like 80 or 90% of their visits are teleconsultations. So this is the main channel for general practitioners right now, and this e-prescription is just right in time for this. So patients also emphasize that they don't need to carry a paper version of the prescription, which may be vulnerable to be lost or destroyed. They value convenience and comfort and simplicity of the solution. I don't want to say no mistakes, but it's better protected than simple mistakes when you write on the paper. So this is the perception of e-prescription in Poland. Of course, we're in the middle of electronic referral in Poland, which should be rolled out as a mandatory next year in January. I'm not sure if the COVID situation will postpone it somehow, but e-referral is rolling out in Poland quite rapidly, and solution delivered in the way very similar to the e-prescription, based on the SMS codes for the patients, or if they prefer a printout version, all that can be seen on the internet patient account. Quite a simple and intuitive solution. And some statistics about electronic referral in Poland. I think in September, when I was in the roundtable, I was showing this graph up until August 2020, when we had 625,000 e-referrals. Then we jumped to close to 1 million in September, and then we dropped a little bit in October, and most probably this is because of the COVID wave 2, where fewer number of medical procedures are performed. Probably some of them are pushed back to later further times, and COVID is in the front line. So probably that's the cause of this decline from September to October. We are developing our internet patients account. It is becoming both a portal for the patient, like information service for the patient, and the application where patients find information about their personal data. So we're trying to, in the portal section, we try to write all about healthy lifestyle, all about the COVID situation, all about what people should do in terms of well handling the COVID situation, and the service is developing quite fast. Just a brief go through well the pros, why we try to encourage people to use the internet patients account, because they can manage their data. They can grant access to their data to their relatives or their general practitioner, to the doctor, or to another institution. They can set up accounts so that they can realize electronic prescription for somebody in the family, for example, for a parent or grandparents. So you can configure your patient your account in that way, and you can very easily grant access to your history when you're, for example, at the GP's office. What's been very important in COVID times, that I will mention it a little bit later, but we have added a very useful feature where you can check your COVID-19 test on your internet patient's account. So once the result is there, you don't need to try to call. Well, you probably know the test from the laboratory if this is a commercial one, but that's not always the case. And once the laboratory reports the result of your COVID-19 test, you can see it on the internet patient account. This has been very popular, especially that it has a legal value. It's not just the information. I will mention it a little later. So I was talking to you about that right now general practitioners they do mostly teleconsultations. We also have launched, and it was in April 2020. We also have launched medical consultations, remote medical consultations on our internet, on our patients portal. So you can subscribe, you can fill a form that you need a consultation, and you can wait for it for the medical professional to contact you. We will notify you when your date comes for teleconsultation, and you can join by simply clicking the link that we sent via email. It's quite a convenient solution, and yeah, unfortunately, again, in the COVID-19 second wave, we have this service has become very popular, and we have already 24,000 online medical consultations done via this service. Of course, in the market, there are many other services like this, and very often general practitioners have their own medical consultations tools, and they use it as well. But we as a e-health center provide the tool for those who don't have their own software for that. So I will come back to COVID in a second. I will just mention that we are in the middle of rolling out probably the most complex thing in the P1 project, which is medical events and exchange of electronic health records. This, I think, many doctors wait for this functionality to be rolled out fully, because this is not only, I would say, it does only improve the flow of data, but this functionality will remove a huge portion of reporting that is put on medical professionals right now. So this is in the pilot phase right now. Just a quick go through how this functionality works. We will not be storing centrally as a government all the medical documents, but we will be trying to index all the documents that hospitals and healthcare service provider keep in their data centers, and we're trying to connect these healthcare service provider together so that if they are authorized to request for the electronic health records stored in another provider's data center, we will be well matching these two together. And if all the security and exchange scheme is fulfilled, then we will allow the exchange of electronic health records. I believe that this might be a good step for patients who will no longer need to carry the medical history, will have easy way to move it from one place to another, from one service provider to another healthcare service provider, and hopefully this will improve in the times where people are migrating. Probably now the migrations are maybe lower, but in terms of migrating cross country or internationally in the future, this exchange will play significant role. I mentioned before that e-service, electronic prescription is showing its real face right now, because it's not just a service; it's a huge number of data. And just similar information I was giving to you in September, we are performing huge number of data analysis based on the e-prescription. So, well, for example, continuity of pharmacotherapy. It shows that, well, it's not very obvious topic, and we have quite a large number of data to analyze it. And I was using one example of specific osteoporosis medicine. Two of them. One was denosumab, which is a injection, and another one is alendronate. What we find out analyzing e-prescriptions is that the continuity of therapy is significantly different. So we have some indexes like MPR here, which is a medication possession ratio, number of days where patient had access to the medicine by number of observation days. When it comes to injection, this number is significantly higher. When it comes to pills, the number is significantly lower. So this one example shows that, well, some patients have problems with the continuity of therapy, and it's not only the case of the access to the medicine, but it's a case of, well, their will to be focused on this and they continue the therapy. Quite a good information, and general practitioners, they want to have this information because they want to treat their patients. They want to know the history. They want to know not only if the patient had an electronic prescription, but if they actually realized it, if they continue the therapy that's been given. Just one good statistic about prescriptions across last year and this year. March, when COVID struck, huge increase and then decline in next month. I have not refreshed this slide, but on the next event I will show you the refreshed information about this. I wanted to close with some information about COVID-19 data flows, because this has been our main point of interest for the last weeks, and actually we've been doing all this. We have been prepared in the spring for some COVID data flows, tests and the results and all this flow that goes around. But it turns out that in the autumn wave, where the scale is significantly bigger, our system is completely ineffective when it comes to handling these number of things. I will just show you briefly what is the structure of our systems and stakeholders in the system and the connections between them. I will not go through this in detail, but this only shows that we have developed so many solutions. Different institutions have their own system, and now in the second wave of COVID, we have been forced to connect these together and to actually start to look at what is the flow of patients' data in the system, because the old ways stopped working. For example, the way where patients have to wait for the call from the sanitary inspection to be informed that they have quarantine, for example, this solution doesn't work anymore because we have not enough employees. It's not possible to do it this way. So we're trying to do some improvements in the way. For example, we reduced for the COVID, we reduced administrative decision. We replaced it with the information displayed in the system. The information displayed in the system is enough for the patient. It has a legal value. Information displayed in the system of the national insurer has a value for the employer and employee. And you don't no longer require sick leave, for example. So quite a good automation and reduction of the paperwork, which is always late in this kind of situation. Paper-based confirmation of quarantine no longer exists. We automatically generate a document for the patient on their internet patient account, and this document is digitally signed by us. And you can take this document and send it to your employer, to whoever is interested in it, and this is a legal value. We no longer have we have a sick leave, right? But for example, when you're in quarantine and you need to be paid, you have a right to be paid some money from the National Insurance Fund, then you don't need a sick leave for that. You will be displayed this information on the portal, and the National Insurance Fund will pay you the money based on this. We don't do quarantine anymore as a result of administrative decision. We do automated quarantine right now because we have a severe situation here. So, for example, and this is also a matter of regulation happening in Poland, we put quarantine on people who have test order for COVID-19. One interesting fact about tests for COVID-19, it turns out that not everybody who had the test order went to do their tests. The government decided that we need to put quarantine on somebody who has a test order or test referral, and once the result is negative, the quarantine is released. We have a huge problem with telephone contact with sanitary stations here in Poland, who are in the front line of this COVID flow. We have built with the support of many government institutions and external partners. We have built a huge call center which handles all those things. And actually, it's now that call center will inform patients about their situation, and this will be enough for the COVID times. We have simplified the epidemiological interview, which typically was done in the way that somebody called the patient and asked, okay, who did you have contact with? We are encouraging patients to give this information to us based on a self-service automated online forms. We hope that people will be responsible enough to give us this information, and this will automate the process. We try to distribute the information in the modern way. For example, chatbots. Although I am not that much convinced that chatbots are, well, about the effectiveness of chatbots, but they developed quite quickly. I know that many vendors work on their chatbots in the COVID time. I know that there is an artificial intelligence algorithms beneath that, and we also use chatbots to try to inform the patient about the situation, because regulations in terms of COVID change very often. Once a week there is some change in regulations, so it's very hard to follow all these changes. We try to handle finally the waiting lines in the well, samples or swab collection points. We try to automate this by sending people SMSs and putting them in queues. One of the problems we had with COVID, with these collection points, that people gathered there waiting to be served, and this solution was completely ineffective, and it was a risk of infection in these waiting lines. So I'm sorry if I'm a little bit out of my time frame. Thank you very much for your attention, and yeah, I will be glad to share well, your experiences in terms of this COVID-19 solutions. We try to support medical professionals as much as we can with the technology. Thank you very much for your attention.
Victor, dziękuję bardzo. Thank you very much. There are some questions here. One question I would like to ask is, what other services are planned on the internet patient account in the future?
Yeah, so I think it comes with no surprise that when people are well asked what they are looking for mainly, I think they're looking for the easy access to the information of where they can find a doctor they need to see, what is the date, and they can, well, online registration, they can perform online registration. The situation here in Poland is that, well, many private healthcare provider has an online registration, and many public services have online registration, but we have an ambition, and this will be done gradually, not all at once. We have an ambition to try to synchronize it in the internet patient account centrally. So yeah, I think this is the service that people are waiting for, and this is one that we will be launching next year. Not for all the services, but I don't think it's possible to launch it all at once. But for the selected professional, selected procedures, you will be able to register online. I think that's one thing that people are very much waiting for.
Victor, I like this approach, so the service design approach from Poland, because they started very clever with something which would be accepted very soon and immediate from a big range of people. This is the e-prescription, and from there you went to other services. Very clever, and thank you for your insight to that. There's a lot of other questions, but due to the time, I will ask one more. So. Can you confirm that there's an increase in acceptance of digital healthcare services as a result of the pandemic? So this was one of the questions.
Yeah, I think definitely is, but I think that's not a very obvious thing. I mentioned, for example, that majority of general practitioners consultations are done online. And I hear voices that say, yeah, this is the good solution. And I hear voices very often that say, no, this is not enough. You cannot close access to the typical consultation physical. And this is very mixed. So I think people accept this solution, and I think people see the good side of it. But I think that well, there's need to be a balance, and I think some people right now can maybe consider that it's it's too much towards teleconsultations. I'm not sure about this, if it's too much, because we're fighting with COVID now. But yeah, I think the adoption of these solutions is on a good level, and I think we are not trying to, except for COVID, because COVID is a different situation. We're not trying to force these solutions, and we're not trying to rebuild everything. We're trying to focus on the patient's perspective and what's their comfort using these solutions. I would say that I'm not sure what will be the landscape of these solutions if not COVID, because COVID forced some solutions. But maybe the adoption would be on a lower level. I think everybody accepted that this is this way is necessary, because otherwise the system might not work properly.
Victor, again, dziękuję bardzo. Thank you very much.
Thank you very much. It was a pleasure. And once again, I regret I couldn't visit you in person in Hamburg. I hope, and there's a next event we can meet there or somewhere else.
Thank you very much. Thank you, Victor.
Thank you.
So, coming now to the most developed country in the healthcare context, and this is Denmark. Hans-Erik Henriksen accompanied me for more than half of my career time. So Hans-Erik, thank you for your friendship all this time. We worked together in IBM in context of healthcare transformation. He's now the CEO of Healthcare Denmark under the patronage of Her Royal Highness, the Crown Princess of Denmark. I asked Hans-Erik if he can show us his view / Denmark's view on digital health 2018 till 2022, and how COVID-19 is helping progress already planned initiatives. So, Hans-Erik, it's your stage.
Thank you very much, Lubishau, and thank you very much for inviting me to talk a little bit about digital health in Denmark, and also some of the, after all, positive things which come out of this terrible crisis we are in with COVID-19 at the moment. Just a little introduction to my organization. Healthcare Denmark is a public-private partnership. We are owned by the state of Denmark, our Ministry of Health, our Foreign Ministry of Denmark, our Ministry of Business. We are owned by the industry associations and confederations in Denmark, which have healthcare industry as their members. And as you can see, we are also owned by a number of private companies as part of the private side of the public-private partnership, but also by universities and teaching institutions who see an interest in using our network. And it's our mission to have the dialogue with other countries about how we can inspire each other, how we can learn from each other, and how we can strengthen the dialogue on addressing some of the serious issues countries are having with healthcare. So we try to have that dialogue, and of course the underlying assumption is to strengthen the interest for Danish solutions and Danish innovation, and that way grow our healthcare industry. How we carry out this mission is actually quite simple in a way. We have a program where we receive international delegation visits to Denmark. Not so much this year. Most of it is, of course, virtual visits, but usually we have 70 to 80 international delegations, ministers of health, top decision makers, making use of our visitor program to see for themselves some of the ideas we have in Denmark on how to improve healthcare. We participate in conferences. Again, this year it's virtual conferences as this conference. We join our ministers and royal family when we have delegation visits to other countries, and we use the press and communication to also spread the messages about where we think we can inspire other countries from the Danish side. If you go to our homepage, you can find small videos and white papers talking a little bit about the areas where we think we have something unique to offer. As Lubishav mentioned, we are proud to have Her Royal Highness, the Crown Princess of Denmark, as the patron of healthcare Denmark. Of course, she's happy to lend her name to an agenda of growth and more export, but she's also very happy and see us in a role, as I mentioned before, as an organization who foster more dialogue and hopefully create inspiration about countries and new ideas, not only from product or solution standpoint, but also ideas on how we can inspire each other to handle the challenges we all have across the world. So I promised to talk a little bit about digital health and the COVID-19 impact. I'll start by setting the scene and giving you a little bit of background information. Talk about the Danish healthcare system so you understand the setting and type of system we have, but also talk about the challenges we have in the Danish healthcare system and how we try to address them with new ideas and new initiatives. So the Danish healthcare system is universal coverage, single-payer healthcare system with a focus on providing free and equal access to healthcare for all our citizens. That means that our healthcare system is financed by our taxes and that we have a focus on a high degree of decentralization and a high level of providing the healthcare that is needed with equal access and opportunities across the country, independent of where you live or how you live in Denmark. This kind of healthcare system is in a way very simple compared to some countries at least, and especially to Germany. We have 3 levels in the healthcare system. We have the Ministry of Health with our board and directorates. We have the regional level where we have 5 healthcare regions. The healthcare regions, they own and they operate our hospitals. So 99% of all hospitals in Denmark, they are owned by the public healthcare system and operated by the public healthcare system. And we have our municipalities. We have 98 municipalities. With the reform in 2007, the municipalities got a bigger role in healthcare, apart from elderly care and home care, which they have been providing for years. We also gave them the responsibility to provide rehabilitation in a local setting outside the hospital, and a role to help strengthen our primary care system with healthcare clinics, and finally a responsibility to increase the health level status of their municipality and their citizen, trying to work with prevention and population health to increase and reduce demand from future diseases due to unhealthy living by our citizens. We are also in a good position that we have our general practitioner as the gatekeeper of the healthcare system. That helps us both keep a good contact to our citizens and patients, but at the same time contribute to making our healthcare system more efficient. So as a Dane, you always start with a contact to a general practitioner. And if the general practitioner say, okay, yes, this may be something that is quite serious, then you move on in the healthcare system. You get a referral to a hospital or a private clinic specialist. Even if you need to go to the emergency room, you need to contact the general practitioner. Of course, if it's a severe case and you dial 911 for an ambulance, then the ambulance will come and pick you up. But in all other cases, the general practitioner will need to be contacted. And that's a way to keeping our healthcare system quite efficient. So that was the introduction to the background and setting, the healthcare system we have, and the background for the initiatives we're taking. Single payer, universal coverage, financed by our taxes, and in a way, quite a simple healthcare system compared to many countries. And like many other countries, we have a burning platform, and that was the background for the healthcare reform I mentioned before in 2007. And of course, you know it. It's about changing demographics, the fact that we have a population that is growing older. That means that they also live longer, they get more serious diseases like cancer and chronic diseases. At the same time, we have a fast food generation, issues with obesity among our young citizens, leading to more chronic diseases and a rise in the number of people with chronic diseases, diabetes, heart disease, and so forth. But we also have more knowledgeable citizens and patients who use Dr. Google, who have more insight into healthcare and have more knowledge about what the healthcare system can do for them and higher expectations. So those forces together with a push for new innovation, new technology, more expensive medicine, it puts our healthcare systems under a budget pressure and a demand pressure at the same time. And as mentioned, we saw that popping up already in the beginning of the zeros. We had our reform of the healthcare system in 2007 to try to address this. And that means that today, some of the political initiatives are the 8 initiatives you're seeing on this slide. I'm not going to go into details with those, but as you can see, it is about higher quality in healthcare. It's about more productivity, efficiency, driving more healthcare services out of the system we already have. It's about pushing healthcare closer to the citizens. It's about early detection and diagnostics and early treatment. The earlier we can detect and diagnose a potential cancer or chronic disease, the better chance to address it with early initiatives and treatment, so we avoided moving into something that requires expensive chemotherapy or surgery. So that is the master plan of Denmark, and I think the overall way to describe it is that what we want to do is to deliver healthcare in new ways, new ways which are closer to the citizens, where we use the resource of the patient, but where we also have a focus on delivering healthcare where we have the lowest efficient cost in the healthcare system. And because this came around with the reform 13 years ago, we have already made some progress because of the change of our hospital structure. Our productivity in the healthcare system has increased by 30% over the last 10 years between 2008 and 2017, meaning in essence that we're treating 30% more patients with the same budget and the same staff. And that's definitely also necessary because we've seen demand for healthcare services going up during that period in Denmark. So as mentioned, it's about an organizational transformation. It's about changing how we deliver healthcare, focusing more on treatment with outpatient clinic and non-invasive surgery as one way to shift the delivery of healthcare from staying 4 days in a hospital for a surgery to going to an outpatient clinic and then relying on rehabilitation services by the municipality. And it's about using our primary sector and the resources of the patient in new way. And as you can imagine, that means that we need to glue together the whole healthcare system. And that's where e-health and digital health and telehealth comes in. As some of you may know, we are quite advanced in the way we use digital health and e-health. Today, all Danish citizens, they have access to a secure e-health portal where they can look up all the healthcare information. They have access, in essence, to the full electronic health record. All clinical notes from hospitals, general practitioners, all lab results, all medicine information. So an hour after visiting your general practitioner, you can look up in your own electronic health record and see what was the registration by the GP, what was the referral, what was the result of that dialogue. And that is, of course, powerful because at the same time, all healthcare professionals had the same access. And that means that when you move around in the healthcare system, they all have access to your healthcare information in an electronic way. As I mentioned, we have worked with our hospital structure. We go back to the year 2000, we had 98 hospitals in Denmark. Today we have 32 hospitals. It doesn't mean that we closed down 63 hospitals or so. We closed 25. But the rest of the hospitals, they were merged into groups of hospitals. So if you were a hospital CEO in a city, maybe you got the message that after the reform, you could run the 4 hospitals of that city as one logical hospital. And that is a big background for the productivity increase, because you could imagine if you were a hospital CEO and you got that opportunity, you'd probably say, okay, then I'm not going to do advanced orthopedic surgery in 4 places, I'm going to consolidate. And that is exactly what we have done. At the same time, all the hospitals changed their role. 15 years ago, you could go to any hospital, knock on the door, and they would say, "Come in, let's see what we can do for you." Today, they are specialized some way or another. Our acute care hospitals have been reduced by 40, from 40 in the country of Denmark to 21, and all hospitals are specialized in one way or another. So when an ambulance arrives at the scene, they don't go to the nearest hospital anymore. They go to the hospital which have the right specialty to receive that patient and give top-notch treatment. As part of that reform, we are constructing 16 new hospitals, and they will be the backbone of the future hospital system. Those are the hospitals where we have all the specialties and where specialists are ready to work together in new ways. Because in the future, when we move healthcare closer to the citizens, when they finally go to a hospital, they are in more need of not only specialized healthcare and treatment, but also new ways of working together. They may have comorbidity and so forth. The red dots are greenfield hospitals constructed close to highways and where it's easy to go for staff, patients, and ambulances. The blue ones are refurbishing existing hospitals. It's an investment of $7.5 billion for the Danish healthcare system. And friends in Germany tell me that if Germany were to make the same investment, it would be $320 billion. So you can imagine it's a huge investment for our healthcare system in our future transformed healthcare system where we can deliver healthcare in new ways. So it's actually all about, as I said, moving healthcare closer to the citizens, delivering healthcare in new ways, reducing our reliance on the hospital. So you only need to go to a hospital when you really need the highly specialized care and treatment they offer at the hospital. This is actually a slide from our Ministry of Finance. So it's a bold statement, but I think you got the message. We want to deliver healthcare in new ways, focus on early detection, treatment, and using the primary healthcare system in new ways, and also the resources of the patients themselves. So where do we go from here, you might wonder? If you're in a situation where everybody have access to their electronic health record, what's next? And that is described in our Digital Health Strategy 2018 to 2022. 5 main initiatives. We want to focus on quality in healthcare, not based on the quality of treatment in the hospital, but quality of treatment across a continuum of care, measured on whether that patient who started with the DP went through diagnostics and treatment actually got cure, and in the patient perspective, received high quality of care. That is about patient-reported outcomes. As I mentioned before, digitalization integrate and connect our healthcare system. So it's about integrated care and actually moving towards a situation where we have real-time exchange of data. You can, in the future, probably go to a general practitioner. The general practitioner may say, yes, you need to go to an outpatient clinic to get some diagnostics, but we can do it in my office because we just connect to the specialist at the outpatient clinic. Then you save the resource of the patient and the system. It's about also using this digital relation, which we will get to a higher degree in the future, to focus on population health and prevention, motivating our citizens to a healthier life, healthier lifestyle, more exercise, healthier food. And when we start using digital data in a much more extensive way with the new strategy, of course, we need to step up on data security, not only make our vault of electronic data even more bulletproof, but also focus on the confidence and trust which Danish citizens have in sharing data, because that is actually the secret behind what we're able to do when we exchange data in the Danish healthcare system. And then it's about the health IT architecture, which connect the dots behind the scene. It also needs to be improved and extended. So, in another word, the new digital health strategy move digital healthcare from being something you access in your portal to actually being something you access in an ecosystem in your pocket. It started out with the Doctor in My Pocket app, taking you digitally by the hand from the first contact with the healthcare system, then the DP, as I explained, and then literally you get digital support from the healthcare system when you move on in the healthcare system. Maybe next you get information from an outpatient clinic about your next appointment, and then maybe the hospital and so forth. So we shift digital health from being about accessing a portal where you today, if I need to renew my prescription, yes, I can log on to the portal, but it's even easier for me to take the phone, open the app, and then swipe, and I have renewed my prescription. I can go to the nearest pharmacy the next hour. So it's about an ecosystem of apps in the phone, also allowing apps from private companies which can make a difference to enter that ecosystem. That's where we are going to with digital health. And you can see we have a rapid uptake. I believe the shared medication record, which is all our prescription medicine reimbursement, I think we are more than 1.5 million downloads. So data is not even updated here. And of course, we need that kind of digitalization, as I mentioned, because our future hospitals rely on that connection. When we are coping with fewer hospitals, higher specialization in the hospitals, we need this connection across the healthcare system and continuum of care. And then it's about delivering healthcare in new ways, as I explained, that also require a high degree of digitalization. And it's because our patients, they demand it. I see the way that what we're doing in our public healthcare system is kind of offering them an Apple healthcare, but with the big difference that it's an ecosystem of apps where you know as a citizen, as a patient, that if you use that ecosystem of app, then the information, your healthcare information, is actually flowing to the doctors and physicians and healthcare professionals who treat you in the public healthcare system. That way, your electronic healthcare data provide much more value than if you store them in a cloud by some private company. So the digital health strategy has also been specifically designed to support the 8 political initiatives I talked before, to increase coherence and the integrated care, to empower our patients, to support telehealth, to increase productivity, and so forth. And as mentioned, it's about these 3 main objectives, supported by 27 initiatives in the strategy. Summarize the patient as an active partner, building this digital connection with the patient, allowing them to participate in patient-reported outcome programs, where we can also have more dialogue with the patient and rely more on what the patient wants, and measure the quality of treatment and healthcare in new ways based on the perception, the cure of the patient, more than on the focusing just on the hospital. It's about shifting the sharing of data, which we have extensively in Denmark, to be more knowledge on time, to allow a future healthcare system where the moment you want to have a dialogue with a specialist at the hospital, you're able to have it through teleconference, or the moment you move on in the healthcare system, the same instant when you have closed your consultation, they have it in the next step of the healthcare system. So we connect the healthcare system, and we allow ourselves to deliver healthcare where we have the lowest efficient cost across the healthcare system. It's about population health and prevention, as I mentioned. And this is actually how we do it, because this is the description of the IT infrastructure behind the scene. You can see it connects all our 5 healthcare regions, all electronic health records at the healthcare regions, all electronic health records at our municipalities, all 3,600 DP systems. So being able to share data this way, it's not about having one big system for Denmark. It's about having a strong healthcare architecture and infrastructure which connect the systems in the healthcare system. That also means that hospitals, DPs, municipalities, they can purchase whichever system they want, but the systems need to live up to the standards that enable them to replicate their data set to our national service platform master, which is the hub from which we share all the data in the healthcare system. So with this situation and COVID-19 coming around, what happens? Well, as many other countries, we closed down in March. We were able with that relatively early total close down of Denmark to establish a positive situation. But as in many other countries, the curve is kind of going in the other direction at the moment. We have it under control because we can handle it on regional levels, but we're definitely not through this crisis yet, and we're not able to know by the end of the crisis how well Denmark did compared to other countries. As in many countries, we have these white tents at retail centers where you can go and get a test, and one way to control the outbreak was, of course, also stepping up on testing. So what we did in Healthcare Denmark during spring was to issue this brochure on our what we regard as innovative-driven responses to COVID-19, to the COVID-19 crisis. It's not so much about what we did in a systemic sense in the Danish healthcare system, more about how we use innovation to help us handle the crisis. So as you can imagine, it's about stepping up on test capacity and connecting our test centers. So we have a real-time overview of where we are in the outbreak of the crisis, how many were tested positive. Obviously, it's about optimizing hygiene and using technology to do that. It's about the capacity of our hospital and having a real-time overview anytime which hospital can take which patients, and it's about ICU and ventilator capacity. But it also fuels our digital health strategy. One initiative in the digital health strategy I talked about was the ability to have a teleconsultation from your phone. So not only can you book an appointment with your GP or the hospital, you can also ask for the hospital or the GP to deliver that appointment through a teleconsultation. That was accelerated. It was planned 2 years down the line in the strategy. It's in effect now. It's being used by patients now. And it's the same manner with other technology like robots and AI and fast and universal access to testing, and also with the app which give you a tracing and exposure notification, which we know from many countries. So overview of capacity, we connected all our hospitals. They have advanced logistics systems, and that way across the country, we are able to know not only what is the bed capacity, what is the COVID-19 department capacity, but also this COVID-19 department, do they have sufficient beds? Do they have sufficient trained staff? Do they have sufficient equipment? We can see it across the country, and that way we can balance the loads that help us a lot if the COVID-19 crisis gets worse in Denmark. We can also monitor the testing capacity and the load of our hospital. I'm sorry, it's in Danish, but you actually see capital region, Zealand region, South Denmark region, Central region, North Jutland region on one slide. What is the capacity for COVID-19 testing, and what is the exact load? So both in terms of testing capacity, but also capacity of our hospitals, we use the digitalization we have in the healthcare system to connect the dots and give our healthcare authorities these real-time overviews, and that is a big help handling this kind of crisis. One example when we talk about hygiene is these infrared UVD robots, which were brought in use to step up and increase the sequence of cleaning equipment. They use powerful UVD lights to travel around and do cleaning, and that way we can step up the sequence of cleaning, which is a big help in this kind of crisis. And one final example of innovation, but also how we work with public-private partnerships in Denmark, is this swap robot, which was developed between a company and a university in only 8 weeks. It works the way that you put your forehead this area, then you open your mouth and the swab robot will take the test. It will package the test into a canister with a label and a barcode, and then immediately it goes to the testing lab. So it increases our testing capacity, and going forward, that's definitely one of the things we need in this crisis. So finally, our elderly citizens, which you can imagine, they are the citizens who are most at risk with this kind of crisis, and they are so happy about the opportunity to meet with the healthcare system through the app and through the new teleconsultation possibilities which were introduced. So that has been a big success, very rapid uptake among our elderly, obviously, and a push to the digital health strategy for some of the initiatives we planned down the line. They were implemented 1 or 2 years later due to the COVID-19 crisis. So after all, something positive coming out of this terrible situation. So thank you very much for your attention. It was setting the scene with the healthcare system, the initiatives and issues we have in Danish healthcare, the status of digital health in Denmark, and how the COVID-19 crisis helped us a little bit progressing some of our initiatives and innovation. Thank you very much.
Hans Erik, thank you very much. So before start the discussion with the speakers who are in, there's one question here. I think you pointed out, and this is the base of your success, is the confidence of the citizens and trust into the government. I think this is the base why it's working. Here's a question in the internet. Even beside that, what is the level of public acceptance of digital health solutions in Denmark? Let me phrase it a little bit and say how you measure it.
Well, one way we have been measuring it so far is the number of unique encounters and visits to the eHealth portal, where you can look up your own electronic health record. It is close to 22 million unique users every month in a population of 5.7 million. Of course, it's also clinical professional, but based on those numbers, you can see there's really a high acceptance and use of these opportunities to access your own digital health information.
Mm-hmm. So Nick, Victor, do you have questions to Hans Erik? And also Michael, even have done your presentation, you're also invited to ask a question.
Thank you. Can I ask how you've addressed semantic interoperability? You mentioned different systems that anybody can buy in your country. One of the problems I find around the world is that when that happens, the semantic interoperability is a real issue. So how do you ensure that you have a sort of unified content in your bus or whatever you call it?
Yeah, that's a very good question. We have worked with semantics for many years. I think we were one of the first countries at least one of the early countries to shift to ICD-10 and use that classification extensively, not only for diagnostics, but also for operation and treatment. We have worked with HL7 for many years, and you're definitely absolutely right that it's a hard prerequisite for allowing hospitals, GPs, municipalities to buy their own systems, that we have that in place.
If I can I? Sorry, it's just, you can do that, but then it's not just a question of IC10 or whatever, clinical ontology, SNOMED, CT. But it's also the issues of naming conventions for lab tests, units of measure, reference ranges, all those drug and device naming conventions. Otherwise, it becomes an impossible job to do. I've seen in England, for example, we spent billions on it, and we're as far away from it as we ever were 10 years ago. So it's a real challenge, and I just wondered how you'd overcome that.
Yeah, and of course it's still a challenge. One example is the capital region that bought a foreign system and implemented that system for the hospitals. It has been a big challenge to implement that system. So you're right, the challenge is there. Specifically when we talk about lab results. What we do is that the standard we use allow the lab to forward also the reference value, and that help control that problem.
Nick, there was a question from you.
Well, thank you very much, Hans, for your presentation. It was really nice. And I think also it showed really about a well-developed healthcare system. The same as Netherlands, UK, and other well-developed systems. But I wonder, so also my country, how they like to boast about the system, how well they are doing, what nice information system and strategies. But if you look back, how you see we haven't been very successful in making transformations. And honestly, a student of mine have done research in Zealand, one of the Danish region, on integrated care for diabetes, and also showed many barriers in collaboration between family doctors, the hospital, the diabetologist. So a bit reflecting, maybe also Michael can reflect a little bit on this. Are we doing well currently, considering we having this crisis? We are bouncing into next crises. That's quite obvious. We only at the start of some of the healthcare challenges. So are we doing well in collaboration and making things happen?
But you're definitely... Sorry, Michael.
No, please.
You're definitely right that we have a lot of problems. And we are not perfect in Denmark. I think we have some good initiatives, but we are also seeing siloing in Denmark. The issue of getting DPs, which are private enterprises, municipalities, and regions on the same agenda, and that's probably some of the issues you refer to from Zealand. We are seeing issues stepping up and reaching the level we want to in cancer treatment, for instance. In some areas we have done good progress, but we want to do more. So lots of problems and issues to be addressed, certainly, and lots of issues. When you rock the boat and you try to transform healthcare, you get a lot of issues popping up in that process.
But can I just... Don't we need a European, initiative? We're so, I'm not anti-American, but we're so dependent on American software. When one looks at the Commonwealth research, mirror on the wall, comparing 11 leading industrial nations, they come out the worst in terms of clinical outcome, and more than twice as expensive as the white. So why do we use American software? And I'm not anti-American, to improve it. Why isn't there a European initiative, maybe led by our friend here, and the clinical care coordinator? Why don't we have, a development of a European-wide system? I think we're long overdue, and that addresses the semantic interoperability issues right from the beginning. Mm-hmm. I think, we've really missed out on that. Sorry to campaign, but...
I fully agree, and if you look at into some of the European Union programs, you have those elements. It's just too slow in moving to implementable initiatives, in my view. But I think that the thoughts are there, but it's a super tanker we need to turn around here.
Yeah. And maybe so the Commission have made some attempts through standardization and obviously regulation to work on this more open platform approach and improve interoperability. But it's not sufficient. I totally agree, Michael. And maybe it's also had to create the sort of conditions in which the different application and system can better work to each other. And again, you see here also the challenge with the different levels of European sort of markets, European Commission, national, regional. So this again refers to a sort of leveled approach where we probably should do better in aligning stakeholders and have a more common vision.
I'd hoped, I remember in 2007, we had the English Initiative, you know, probably the first major e-health program in the world. I remember trying to get SAP to, you know, join and develop a EHR, electronic patient record system, and unfortunately it never happened. But we really need, I think, a European initiative. And that's not to be anti-American. Please, I'm not trying to be that. But I really think it's essential that we move in that direction. And I hope sometime that, you know, I'm old enough not to worry about my career to actually participate in it.
I fully agree. We really need that.
Victor, do you have some comments, questions? You're still with us from the perspective?
In general, or related to the?
No, Victor is he still with us, Victor? No. Okay. Now I think. Yeah, this is, as you mentioned, Michael, nothing to do with anti-American things, but let me say, we need to develop these initiatives more. And you, Nick, you are most involved in these initiatives. How is there a discussion around this, or is there silence about that, or is it very controversial? What they're doing there? So to ask.
Well, definitely, due to the COVID crisis, you see on a lot of tables had this discussion: how can we make healthcare system more sustainable? Is high on the agenda, but still this sort of united approach, because COVID is a perfect example that, from a medical perspective, technology perspective, policy perspective, things are so intertwined. You can only solve this by a huge movement across countries to make system work better. And so the Commission, WHO, is working on this, but still you see in this pan-European approach that, for example, industry is excluded. And I don't believe the sort of governments and public organizations only can solve this issue. We have to engage with other stakeholders as well. Also, in the industry, there are a lot of creativity and power to make a change. But balancing this sort of interest and the sort of leadership in this type of things is really critical. And that's something also what we see not so much yet in Europe with leaders in this area. And hopefully also, well, I see some positive things happening in industry as well. So companies like Sanofi, Roche, had a big European, they really change business models and approaches. It's also for them not really easy. And hopefully in Europe, we have also a sort of leadership from governments, etc., who say more, not focusing on sort of national interest, but reaching out and say, we have to solve this together. So I think this is what I hope for.
Do you see more demand, because in the Global Clinical Care Coordination Forum, GCCCF, there are a lot of partners, and I think is there a demand to involve more industry partners? So one good thing is the Healthcare Denmark, is there are also a lot of industry partners involved. So Hans-Erik, as I understood, these partners are only Danish, or are they also from other nations?
At the moment, they are only Danish, but you know, we are an export promotion organization, so it depends that they have an affiliate at least in Denmark, but there's no exclusion of international companies as long as they have Danish activities. Just to comment a little bit on what Nick was talking about, I also think that with the COVID-19 crisis, we have a window of opportunity, because at least what we have seen in Denmark, I gave some examples on progressing our digital health and use of technology, but we have also seen things in hospitals and our healthcare system which were possible in very short time, where we broke through the culture because of the crisis and sense of urgency. And hopefully that's something, a momentum we can use also to make some more things happening across Europe, going the same way in the European Union.
I think it's, sorry.
No, please, Michael.
No, I think it's important, for the opportunities for our young, for careers, for our health services, so that we have affordable solutions that meet our requirements. And I took Nick's point about, that some of the software we're using in Europe that comes from overseas, just adds to the administrative burden and isn't actually assisting our clinicians. So, I was invited to China about 18 months ago to go and speak at a healthcare conference, and I was fortunate enough to be taken around China, and I looked at some of the Chinese developments, and I was quite impressed. I didn't expect to see, if I'm really honest, but I actually saw some very good software in the north from a company called Newsoft, and they had reached HIMSS level 7 when there was no HIMSS level 7 in the UK. I think we had the first one 2 weeks ago. And they're working very hard on telemedicine and their solutions, and they're looking for collaboration. So I just cannot help but feel that Europe really, we're not giving the future for our young and playing the role that we should. We can develop, have the most sophisticated particle research facilities like CERN, if we can have big companies like SAP and aerospace. Why haven't we got a software industry in the healthcare domain that's of size, a global player? And I think it's essential.
Michael,
sorry, I'm sorry about that.
Yeah. Let's say on that also in the direction to Denmark. I think everything it's a two-way. I think in two directions. So from one side, except also that other nations are playing a role, for example, in Denmark or in UK or in US and so on. But from the other side, also to open the markets in their countries. I think this is also an important aspect from the GCCCF, because from one side, we cannot only, complain that the US is dominating with the EMR systems here in Europe, but from the other side, we don't develop anything new. From the other side, why to develop renew the wheel again? So I think there's a lot of things what we need to discuss. But we skipped, as you see, the break, and we expecting now also the other persons in our session. So the breakout session will also. I look to my regies. The breakout session also finished. Yeah. Okay, so we need to proceed to stay in time. And I really enjoyed more a discussion than to go into the break. Thank you all. And let's go forward. Nick, please, and Hans-Erik, please stay also with us to proceed the discussion after the speech from Michael. So let me say some words about Michael. Professor Michael Miller is the member of the WHO Digital Health Technology Advisory Group, DHTAG, roster of experts, so of the World Health Organization. So he's the CEO of the Care Innovation Corporation, which is based in UK. So his topic is about tackling burden of chronic disease with digital health. So I think there are a lot of more to tell about Michael. I think it's a lot because his career is longer than mine. So I was always asked, please be short, Lupo, but I would like to tell you a little bit about that. So Michael is also a respected international consultant in health informatics and e-health strategy and system, and has worked on the largest e-health programs around the world, including NHS England, the Supreme Council of Health Qatar, Queensland Health Australia, the Ministry of Health of Kingdom of Saudi Arabia and Singapore, developing an integrated care model and national EMR strategy for Singapore of Ministry of Health, and most recently with the Samoan Ministry of Health on a national e-health program financed by the Asian Development Bank, and subsequently for the Philippines, MOH, and China, you just mentioned it. So, there's a lot of more things. important is that Michael is the member of the WHO Digital Health Technology Advisory Group, this roster of experts, which is important for us, and the assessor of BCS FADIP registration, former associate vice chair of the healthcare executive of the British Computer Society. So I think that was the reason why you asked on this these questions about how this resonates, how the syntax work together. So, Michael, I think the next things you speak or you tell us about you. So I find here also you're former head of program for London and Southern clusters of NHS England. So Connecting for Health Programs, national program from 2004 to 2008, covering some 20 million UK citizens. I think you have a lot what you can tell us. And Michael, the stage is yours. You have half an hour.
Thanks.
So the stage is yours.
Thank you very much indeed. And so I've recorded my presentation, so I hope this technology works. Forgive me if it doesn't. I'll have to go back to manual, so because I tried to keep to the time slot. So thank you for that. I'm going to share my presentation now, and I hope you can see that, and I hope soon that you will hear that.
Yes, so go in presentation mode. So yes. Okay.
Thank you for inviting me to speak at the Global Clinical and Care Coordination Forum. My name is Michael Miller, and my subject for today is tackling the burden of chronic disease with digital health. I show a brief biography of myself for those of you that may wish to reference it. Let's begin by looking at the crisis of fiscal sustainability in healthcare. Healthcare systems around the globe are challenged by increasing demand and demographic changes in population. The fiscal sustainability of healthcare provision is now in question. Let's look at some examples. Australia. In 2009, the federal government stated that there are currently 5 people working for every person over the age of 65. By 2050, that will reduce to 2.7 people working for every person over the age of 65. In August 2016, the Australian Financial Review states, if healthcare costs increase at the present rate, the government will be broke by the end of the century. Singapore. In the Budget 2014 debate roundup speech by the Deputy Prime Minister and Minister of Finance, the following statement was made. Compared to a decade ago, our health spending has increased almost 6-fold. This will rise further. Now, 1 in 8 Singaporeans is age 65 and above. This will rise to 1 in 6 by 2020 and 1 in 4 by 2030. The United States of America. In September 2013, the Kaiser Health News reported, by 2022, health spending will total $5 trillion, which is 19.9% of the gross domestic product. Although perceived as a private healthcare system, some 55% of funding is actual federal funds. Some 40 million citizens are also excluded from the healthcare provision. England. Official figures released by NHS Improvement showed that NHS trusts in England, which predominantly run hospitals, ended the 2015-16 financial year £461 million worse off than the organisation had forecast. The combined deficit is almost 3 times bigger than the overspend incurred by the year before, and more than 20 times the size of the 2013-14 deficit. There is a trend around the world in healthcare to move from the fortress-like structure of primary healthcare, acute care, hospitals, mental and social care facilities, to an integrated care model that is patient-centric. The diagram shown on this slide gives an outline of a patient-centric model of care and includes primary healthcare, community care, diagnostic imaging, ambulance services, maternity, acute healthcare, mental health, laboratory pathology, social care, and polyclinics as examples. Let's now look at the major area of healthcare expenditure worldwide, or as I deem it, the elephant in the room. The World Health Organization predicts the cost of managing chronic diseases will be 80% of the total healthcare expenditure worldwide by 2020. As an example, let's take a look at just one chronic disease condition, diabetes. In 2017, the Harvard Medical School estimated that diabetes cost the world some $1.3 trillion. The International Diabetes Federation suggests that the number of diabetics worldwide is estimated to increase by 51% by 2045. Let's quickly look at the IDF Diabetes Atlas. In Africa, it's predicted by 2045 there will be an increase in diabetics of 143%. In the Middle East and North Africa, 96%. In Southeast Asia, 74%. And in the Western Pacific, 31%. Globally, by 2045, the number of diabetics is estimated to be some 700 million. A global increase from 2019 of 51%. NHS England, in its long-term plan, states, for many years we have known that we should be moving away from a system that prioritises treatment to one that can also predict and prevent poor health. So what can we do to address these challenges? Professor David Cutler, Professor of Applied Economics at Harvard University, suggests perhaps the most underused person in healthcare is the patient. Let's look at some possible enabling technologies. The classic clinician-patient engagement model was based on a method of documentation with the acronym SOAP, subjective, objective, assessment and plan. Limitations of many initial telemedicine systems were that they omitted the objective patient vital signs measurement, for example. This has led to public protest in the UK, an example of which is shown on this slide. Let's now look at how we might address this problem of the remote measurement of patient vital signs by considering the developments of clinical grade wearable devices for measuring those vital signs. The use of telehealth based on the evolution of advanced wearable devices to measure important vital signs include blood glucose, truly non-invasively, continuous glucose monitoring, blood pressure, ECG, oxygenation, heart rate, sleep pattern, activity, and temperature. And latterly, addressing chronic disease patients' mental well-being, assisting with patient chronic disease by measuring patients' mental well-being in a quantitative manner, and perhaps addressing the biggest challenge of changing patients' lifestyle and assisting patients cope with the fatigue caused by managing chronic conditions. Some examples of such devices are shown on this slide. Additionally, recent developments in data science offer significant possibilities in the use of analytics in healthcare to reduce cost and improve patient outcomes. These include accurate, intelligent alert generation, minimizing both false positives and false negatives, and assisting medical professionals care for much larger cohort of patients, moving from a scheduled system to an interrupt-driven system. The patient will see you now. Segmentation of the patient population on the basis of risk, minimizing the likelihood of acute complications such as stroke, myocardial infarction, amputation, etc. Individualized care pathways, and driving patient engagement and ownership. Development of such applications as the patient hub and the doctor portal that work on multiple devices in a secure manner form the basis of an holistic ecosystem for managing chronic disease. There are many initiatives in place worldwide which employ various approaches to the improvement of chronic disease management. They include lifestyle coaching, medications management, clinical best practice, chronic disease patient software, and non-invasive wearable vital signs monitoring devices. However, these approaches are largely disparate and often do not address patients with comorbidity, multiple chronic conditions. What is surely required is an integrated ecosystem solution that brings together the best of each approach and offers patients and providers with a more efficient and effective model of care that reduces cost, improves outcomes and quality of life, minimizing the development of acute complications associated with these conditions. Let's now consider an improved model of care for chronic disease. That is, an end-to-end and homogeneous system, a closed-loop ecosystem for all major chronic diseases that addresses patients with comorbidity, simple for the patient to use while supporting and educating them. Welcome to the Virtual Chronic Care Continuum, or VC3. The Virtual Chronic Care Continuum was first conceived in 2007 as a result of a large telemedicine program in NHS England called the Whole System Demonstrator, which, although it showed many benefits, which we will consider later, it also demonstrated a significant number of limitations. These included a high percentage of false positives in the alert generation mechanism, leading to alert fatigue by clinicians, and a very limited use of such elements as lifestyle coaching, medications management, analytics to set patient goals, and determine patient care pathways. An improved design, VC3, was then defined. Let's look at the diagram before us in more detail. In the center of the diagram shows a patient with chronic disease. The patient is provided with advanced wearables to continually measure the patient's key vital signs, such as blood glucose, blood pressure, ECG, and well-being as examples. The patient data is then sent via the patient hub in a secure transmission to a data center, where algorithms analyze the patient's vital signs over time to determine if an intervention is likely required. If a patient alert is generated, it is sent to a call center of clinicians, either real or virtual. That call center could, of course, be anywhere in the world. The clinician then reviews the alert and patient record via the doctor portal. If the clinician decides that an intervention is required, the clinician contacts the patient via their mobile phone or tablet to consult with the patient. This transforms the classic appointment-based consultation process with an interrupt-driven system based on need. On the left-hand side of the VC3 diagram are shown two important patient support elements. The first is medications management to assist the patient adhere to their prescribed medication.
And the care continuum.
And the second element, and perhaps over time the most important, is the lifestyle coaching, diet, exercise, and well-being to support the patient in making the necessary lifestyle changes, manage their conditions, and improve their outcome, minimizing the likelihood of the development of acute complications. The final element shown in the clinical is the clinical best practice, shown on the left-hand side at the top of the diagram. In 1991, Wyatt estimated that medical knowledge will increase at least fourfold in a clinician's lifetime, and that somewhere in the world, a medical research paper was published every 15 seconds. Therefore, to assist the healthcare system, clinical best practice in an easy assimilated format is supplied to the clinician, lifestyle coaches, and the patient. Analytics within the doctor portal also facilitate the segmentation of the patient population on the basis of risk, enabling them to prioritise those patients most at risk of experiencing life-changing and expensive complications, and the setting out of an observations of individual patient goals. The system has the capability to be interfaced with existing electronic patient records, EPR systems, if required. VC3 offers a complete, homogeneous, easy-to-use environment for patients with chronic disease and comorbidity, assisting them to take ownership of their health and supporting them with the demanding lifestyle changes necessary. Now let's consider the possible outline benefits of a virtual ecosystem for the management of chronic disease. As previously mentioned, in 2007, a large pilot trial of telehealth was undertaken in England, entitled the Whole System Demonstrator. The headline findings were published in 2011 and showed the following: that if used correctly, telehealth can deliver a 15% reduction in accident and emergency emergency department visits, a 20% reduction in emergency admissions, a 14% reduction in elective admissions, a 14% reduction in bed days, and an 8% reduction in tariff costs. More strikingly, they also demonstrate a 45% reduction in mortality rates. However, as previously mentioned, the alert system generated over 90% false positives, causing alert fatigue amongst clinicians. Technology has developed substantially since those pioneering trials. Subsequently, NHS England, with the assistance of the King's Fund, developed a Markov model of the virtual telehealth system VC3 shown. This resulted in a projected cost reduction of some 30%, with a similar reduction in patients developing acute complications such as cardiovascular disease, stroke, and amputations, etc. And further, it assisted the move of the service to a preventative healthcare model, which my experience suggests is the aim of all healthcare systems worldwide. Thank you for the opportunity to present to you today. Perhaps it's now time for any questions you may have and for some discussion. Thank you.
Michael, thank you very much. So there was a nice idea to record this, and so
Yeah.
all the piece to present it. So let me start with one question from the audience, but edit from me with some other things. So the question is, how can WHO contribute to accelerating the digitalization of health systems? And that's my additional thing, how, and that's what we discussed former, is how the industry, or how can the WHO involve more the industry in this game? That's the question.
Yeah, I think the WHO has quite a large section already addressing the questions of telehealth. And if you go onto the websites and you do your searches, you will see that the WHO is active right around the world, assisting nations to develop such e-health strategies. I myself been out in the Pacific Ocean, for example, and seen that firsthand. There's also significant developments in other nations around the world, but unfortunately, the COVID pandemic has tended to sort of delay the introduction. But I think if you look at the figures on the WHO website, it will say that 98% of nations around the world have some kind of mobile health initiative already operating.
But how they do that? So how they really involve the industry? Because in the discussion I had with the industries, the really strong one from US and others from European Union, they do not, let me say, perceive them so much.
Well, my experience has been that it works through contracts that are sort of issued. And so the WHO and other of its agencies advertise contracts every week. And it's up to people then to apply for those contracts. And if they are successful in those, to actually assist.
Mm-hmm.
I mean, also, it doesn't stop nation states from actually taking an active role as well. You know, I've experienced that. And, there are many, many opportunities globally, in my experience. But very often, one of the challenges I had, can I give you a real example?
Yeah, please.
I was out in Samoa and working on their sort of e-health requirements. And we did an RFP on what they actually needed for an e-health system. And I went around to the major providers in the world. I shan't mention their names, and said, look, the Asian Development Bank has sort of has a budget of $20 million to assist Samoa develop that. And the problem was that really I couldn't find any of the major suppliers that were interested in doing that. Unless there was a sort of a significant increase in the budget, it wasn't going to happen. And so I think for many nations that I've experienced recently, Bangladesh, Pakistan, Philippines, one has to be realistic about the sort of budgets that are likely to be available to help those nations to build e-health. And I think somehow we have to find ways that we can implement systems that are not at the American or European budget levels.
So any question from Nick, Hans-Erik, Victor?
Yeah, I have a question. Because Nick, you talked about wearables and the potential of wearables. And in my view, we can move in two directions. We can offer an opportunity for wearables to deliver data to, in our case, the public healthcare system, so it can be used by the physicians. And that way we can get a tremendous benefit from wearables. But the basic scenario is that when you use a wearable, the data end up somewhere in the cloud owned by some company somewhere in the world. How do we, in your perspective, and on a European level and in the countries, grab this opportunity, which I see now, to actually strengthen that digital relation with the citizen also when it comes to wearables?
Yeah, and I think, in some areas, in Germany, I understand, has very strict laws on where data can actually reside, but they are not alone, and in many countries that exists. So when we talk about going to the cloud, I think, we have to understand that it needs to meet those countries or those nations' legislation on data security. Although, off the record, I might question some of the data security that actually and truly exists. I won't go into that now, but with the development of quantum computing, most of the encryption techniques we currently use are hackable because we can solve the traveling salesman's problem using quantum computers that has not been before us before, which means we can basically break the encryption on nearly every encoding system that currently exists in the world. So, that's a bit of a concern. But in England, for example, we had very strict rules. We couldn't even send data to Scotland. That's changed now, and we've started to use the cloud. And perhaps nations start to have to look at how they address that issue. I've been working with a number of the providers like AWS and Azure, for example, Microsoft. They are looking at local, as it were, clouds, so they can be national clouds. And therefore, hopefully meet those national requirements, whatever the legislation may be or whatever the European-wide legislation may be. So I think that's one of the steps forward. The other problem with wearables is I've experienced some issues with Bluetooth consistency, and that often if you've got a large population, you'll find you'll get Bluetooth dropout. And I think the advent of 5G offers us a way perhaps of getting around that. And there are companies that look to put SIMs in those devices so that they do not use the Bluetooth mechanism, but use 4G, 5G, whatever it may be. I don't know if that answers your question. Please feel free to come back.
Yeah, but it definitely answered a big part of the question, but I'm also thinking about the vision we have in Denmark is a future where at a hospital you can actually say, okay, I have this patient as a healthcare professional. I want to follow these trends in the home of the patient and further treatment or diagnostics. I want to use the wearable, and for that I need the wearable to be plugged into our electronic health record in the hospital. That's what we try to achieve with the digital health strategy in Denmark and the ecosystem of apps I mentioned. But how do we develop the same kind of solutions in other countries? And how do we make that possible?
Yeah, maybe a little bit. No, sorry.
Yeah. My experience has been that, many countries are interested in having those exact systems. The question that often comes is that what you don't want to have is multiple systems for multiple conditions. So let's take an issue where a patient has comorbidity. One of the things we did in England, for example, NHS England, that we now boast that we have 1,000 apps for patients to use, but they've all got different look and feels. And let's take a sort of a senior patient who's, senior in years and they've got comorbidity. Are they really going to use 4 different applications that have different look and feels? That we need to make it as simple for the patient to use as possible, it seems to me, so that the collecting of that information is pretty simple from their point of view. So we don't put too much fatigue on the patient. We don't encourage them to become fatigued. And the integration with EPR systems or EHR systems doesn't seem to be a great challenge to me. I mean, I'm seeing requests for this right across the world, literally right across the world. And in some countries where they're sort of jumping the legacy of the West that we have in Europe, for example, in the United States, for example, countries like Philippines, where they're having a 5G network put in right across their nation, delivering, the potential for healthcare for 130 million people, 60 million of which have never had healthcare before. They will plug straight into sort of wearable technologies and the use of mobile phones, because even in relatively low-income economies, mobile phones penetrate at least 80% of the population. We can see that healthcare can be delivered to those people, relatively low cost. and of a much higher standard than ever before. Does that answer your question?
Yeah, definitely. Thank you.
What sort of particular problems are you worrying about integrating with the EHR?
Well, I'm more talking about, as I said in Italy, we can go two ways. The one way, which is if we do nothing, would kind of lead to anarchy, because suddenly we will have citizens and patients using wearables and apps who have a fragmented electronic health record in a lot of different clouds around. Or we can think about having kind of a maybe even European Apple Health Kit, so to say, where the countries can offer them to connect apps and wearables. And when they do that, we can, in a secure and safe way, deliver data into our electronic health record, into our infrastructure shared in electronic health record. That's kind of what the vision we're trying to make reality over the years in Denmark.
I totally agree with you. I mean, that surely goes back to the point I made earlier in the last sort of discussion, was that we really need a European initiative. I appreciate that Britain's leaving the EU, but if Biden makes it, it may only be a short period of exit. Europe needs to have those kind of systems and policies that protect patient data and allow for those integrations, so that we don't finish up with islands of automation where parts of a patient record exist in one system, other parts exist in another system. I mean, this is what we have in England at the moment. I talked about the problems of semantic interoperability. What we have is, myself, I probably have 50 different records in parts. Although we've been at it we spent 30 billion and 20 years trying to integrate disparate systems. And to be honest, I think my personal view is that we're as far away from it as we were 10 years ago. As a former president of the British Computer Society said to me recently, it's the biggest scandal in our industry. The fact that, we've spent so much money and so long and we cannot integrate patient records.
Michael,
sorry.
Let's touch one thing which also we speak about EHR system and so on. But there also a clear tendency, for example, in US, now also in Saudi Arabia, that they're going in the direction of to build some command and control centers, so big areas. So let me say a hospital with no patients, but let me say like Houston ground control, it's looking like that a little bit. Not only for monitoring stuff in the hospital, also monitoring elderly people also outside or in the rural regions or somewhere. So I think this is something. Is it going in this direction? Is it useful that it's going in this direction? So US and Saudi also are looking a lot in this direction. So what is your view? All the questions to you all. What is the view on that?
Well, I think Saudi's seeking to address the problem. I'm familiar. I've had some contact with Saudi recently on the whole question of this. I've also recently been asked to become an advisor to the Australian government on their telehealth standards. So it's happening right around the world as far as I can see. But, as this is sort of largely European, I think Europe...
Yeah, not in Europe. So I don't see it so much in Europe. Command and control center approaches are not in Europe. So US...
One of the reasons I wanted to come along today is, I don't know how we do it, but I really think Europe needs to get itself together on this, for the interests of our citizens, for our health services. I think it's really, really important. And I don't know how we do it, but I think we need to really move in that direction. So that we've got integrated systems that, when I start in a new country, I say two things. Before you even consider the technology, first of all, we need a unique patient identifier nationally. And secondly, we need an agreed clinical vocabulary. That's not just whether it's ICD-10 or SNOMED CT or whatever it might be, but right across the spectrum in terms of drug lists, in terms of naming conventions for tests, reference ranges, units of measure. It's time, and I suggest to them that they put that into legislation or regulation of some form, so that every provider in the country has to abide by that. And I suggest perhaps in Europe we need to do that.
Nick, what is your view on that?
Sorry.
Well, I think in general, so the idea to centralize some of these services and coordination operations digitally in centers could work and does make sense. A recent study we done in China with one of the largest digital health platform in the world, with more than 300 million subscribers, also showed that this handover from the digital world to the physical world, with had the real doctor in place locally, hospital, etc., has to be taken care of. It has to be real well connected. The sort of idea, especially with more complex issues, that you can solve everything online, is I think is not very realistic, and is also it refers to this: you need to have a total system approach in order to make it work. And that's complex. But yeah, that's the reality. So also in other sectors, I think that we see experience. So if you have this combination of digital and the physical world, and it's so much depending on each other for the eventual outcome or result, you have to really take care of how it's connected and that everybody is engaged, and that the physical processes are well aligned with the digital processes. And we still, the discussions are very much on the level of EHRs and information. Well, information is not going to solve the thing. It's about the planning, the actions, and the coordination. That's the thing. What solves healthcare systems and lives of people.
Hans-Erik, I think, is Denmark in such a, do they have also such an approach, or still not yet? Or is it in the future something? Because as Nick said, and this is also, I also agree with that, is information is nice, knowledge is also very nice, but if it's converted in intelligent actions, in the right thing at the right time, then I think a command center or care coordination center can solve that. Is this something in Denmark also?
Yeah, we definitely. Also, we have two needs, and I fully agree with Michael. Some of the issues we are struggling with in Denmark is that when you exchange a lot of data across the healthcare system, of course, we need to have a clear classification terminology of what the information means. And as I mentioned, at the moment, in lack of having even more powerful classifications terminology than we can create with Snomi CT and similar initiatives, we need to send the reference value with a lab result, because that's the way we can make the exchange of data clear. So I agree, we need that. Coming back to the need for command centers, we're seeing command centers and the importance of logistics, hospital logistics, clinical logistics emerging in hospitals. And I think we will see the same need when we talk about coherent healthcare and integrating the healthcare system, because in the future, it will not be about having optimized logistics overview command center in the hospital. It will be about having an optimized command center and logistics across the continuum of care. So I think you should see what you're observing, Lubisau, as something we will see more of in the future, as we see more coherent and integrated care healthcare systems.
Thank you very much. Thank you, colleagues. So I just heard that Patricia is at the start. So Patricia, Dr. Patricia X, is the managing director of the German Managed Care Association. So she started her career as a research associate in the former German Federal Ministry of Health and vice president of the Parliament of Ulla Schmidt. She advised diverse stakeholders as senior consultant of an agency for health and care politics and led the Berlin office of the Specialist Physician Group. So Patricia received her doctorate in public health for studies of the reimbursement and diffusion of healthcare innovation at the Technical University of Berlin with a research visit of UC Berkeley. So Patricia, Berlin was also my hometown. I lived there more than 10 years. So I'm back now in Hamburg, but it's nearby. I don't see your picture, so I think you're on start. The stage is yours. We are listening very carefully about your presentation.
Yes, thank you so much, Lupo, for the invitation, and thank you so much out there for sticking through all these presentations today. I listened to various of them, and I think it was so much input. And even before, I thought, so what could be a good sum up, kind of knowing that I'm kind of in between all these thoughts and just before your weekend. So I thought maybe it makes sense to take all these that we've heard and kind of give it to a bit bigger picture. And maybe how it came up, this idea also is that myself and the chair of the board, we spoke this year because suddenly there were lots of things we couldn't do anymore. And we started looking at the old books, for example, on managed care and coordination of care from like 20 years ago. And looking at what we said back then and what has changed since then, and what will therefore come for the future. And I thought maybe there are some thoughts that actually will be interesting also for you, kind of maybe at some parts also as a sum up for what we heard today from these various really interesting speakers. Yeah, so you had my introduction. Thank you so much. So I guess I don't have to say much more about myself. And regards here from Berlin. So my questions for today is first to actually look back on how we spoke about, in our case, managed care or on the coordination of care 20 years ago, and what actually has changed in the meantime, where we can say we are a step ahead. And then also deriving from that to say what are actually the implications also that we can see from COVID-19 this year, but also generally where we think that, or where I think that could be some outlook into the future. So this is actually the table of contents of this book. Our chair of the board published in 1999. And it's the German version. Then it wasn't translated in English, but it is, we will go through it in a second. It is basically all the principles of coordination of care. So what happens, what kind of managed care organizations are there? What kind of institutions in this context? What are the products they offer? What are the contracts? How do you get these contracts and to execute the projects to life? What are the financing instruments? And it's actually interesting when you go through it to say, so for example, the HMOs we have today and we have had are continuously on an extremely high level. And the ones I displayed here on the map are only, of course, some of them. It's not that it would have become the norm and they had spread all around the world and we would just as generally have closed healthcare systems that can focus on coordination, that, for example, this dashboard you just described in the discussion, that can have such a dashboard because they are a closed system where patients belong to. And I would say, as you can see on the map, that not only in the United States, but there have definitely been more there than in the European countries, where you have certain principles of it, or certain ideas, but not as many. So two examples I would name is, for example, the hospitals in Denmark, which I think don't tell, or they are not sold as an HMO, obviously, but they definitely have this very close patient needs and patient perspective included in the process. So I think you can definitely name them in this context. And another example is the German version. It's from Rhön. in the south of Germany that built a campus around a healthcare or a hospital campus around the needs of patients. So starting the main part is actually the ambulatory care, but also connecting it to all the other outpatient providers. And basically the architecture of the building is the further you go into it, the more inpatient it becomes, the more, so you have the ambulatory in the core, and then comes the day care, and then becomes the patients who have to stay several days, and then the intense units. So it's actually quite interesting how you can definitely have examples with patients in the core of it from organizations, but still I would not argue, at least from the German perspective, that they would have become the norm in these 20 years. What's also quite interesting is this is now the screenshot of a big, it's called Teleclinic. It's one of the big providers for telemedicine. And it's, on the one hand, of course, I think in most countries this year especially, we observe to say, does it get more normal to use telemedicine in care, just because you know that sitting in a clinic, sitting with a physician's office can actually be also dangerous. But then, and this is one of the examples, there are obviously others that got sold this year now. And it's quite interesting that they are actually not a company of physicians, but they are an IT company, a software company. So, which by itself is fine. But when we started 20 years ago, I think, or at least from the German perspective, it was usually physician networks that started serving in this field of who offers the services, that they developed the new ideas, which may be a consequence of digitalization, to say, well, actually there are so many more other needs of infrastructure, of knowledge, of contracts, so that it just went beyond the actual healthcare services. And yeah, now the products are offered by IT companies. This is an example. It's when it comes to contracting. Also there, I would say that all these contracts we are speaking about today are actually the same that we have had. So what's not so interesting is to establish the idea, but to execute it. So here is an example of Switzerland, how it's a CSS, it's a health insurance, how they have contracts for digital insurance tools, so that patients actually pay significantly less, around 12% less of their premium, if they in the first place take physicians through a digital tool or to a telephone. So it's one of these very typical contracts that where you say it has a benefit, you integrate the patient into the process, and actually it would be obvious that it's cheaper for the health insurance, so they would want to have it. It's more convenient for the patients, and they pay less. There is a contracting with physicians, but it's not as easy what actually we thought about at first. So also the contracting doesn't change that much. Yeah, so here you see again how they drop by 12% when patients, or in this case, insured people, select the telemed tariff. We have 3 more fields. This one, and I'm still going through the table of contents of this book. This is one on the reimbursement, on the financing mechanisms, where I think is one of the very interesting fields. So I would argue that in the last 20 years, that definitely has changed as we got easier ways how to bundle payments. Of course, there are still many advanced systems which, at least in Germany, have not been executed so much. I know that, for example, from the Netherlands, I know various examples where bundled payments are used, for example, for chronic patients. In Germany, it's not that much, but even this diffusion of DRGs has led to a certain bundling of saying, okay, we we pay for a certain group of services or group of services, and therefore what exactly you do is part of the group or part of the individual provider. It definitely becomes more interesting, I would say, from a care perspective, as soon as various provider groups, provider individuals are linked within this one payment. But obviously this has in the past been quite difficult. And there I definitely see a great advantage through digitalization, because as soon as you have the services that you offer in a digital way, it is also possible to just, and the whole payment process is taking place digitally, to actually have much more clever reimbursement systems than just saying, okay, you have one provider and you pay that one their share, but to, for example, say who did what in the process, which just after you agreed on such instruments, on such financing instruments, actually were pretty difficult until now. So this is kind of the right-hand side with the green boxes, where you say additional payments for high cost outliers. In the idea, they've been known for a long time, but actually they could now just be executed more easily and more conveniently. The same thing for pay for performance, for a fixed salary for a certain coordination, which in the German system definitely has still not really been in place, that you say coordination has a value in itself, and therefore you pay for it, and therefore you can just offer it as well as any other medical service that belongs to a coordination process or a health process. And as well on shared risk contracts for new models of care. We see that, for example, I don't know who participated in this breakout session today on digital health tools, the mobile apps especially, that we have a process now to reimburse. And it's quite interesting because especially such an application, it would actually make a lot of sense to have intelligent reimbursement systems, just because you don't have many you don't have a difference in costs depending on whether you have a very small or large number of patients. But actually at the moment, in our case, at least German case, they have the very traditional, you pay per case and per patient, and then the provider gets, and the producer gets this money. So I do see that with reimbursement schemes, they can definitely become easier to manage through digitalization and compared to 20 years ago. And then one thing I also don't want to underestimate is when you speak of managing quality and costs, I would argue that there definitely have been certain developments which were just very small steps. So here I just, with some pictures, which are obviously a bit also to be understood with a smile, but you have the proper innovations, the disruptive innovations, where you would say this was a big jump, where everyone would accept maybe that this was an innovation. You have the ones where you would say it's actually no innovation at all, it just looks different. And then you have these incremental steps, which by itself can actually be as important as the disruptive ones, because sometimes it's needed to have an incremental learning and just continue changing. And I would argue that, for example, the disease management programs that we've had also for 18 years now this year, with at the moment 6 diagnoses that we have, but around less than 9,000 approved programs in Germany overall that are taking part in these disease management programs. No one ever speaks of them as the big jump, the big, innovation. But actually, they did definitely participate, or they did contribute to managing quality and costs better than we had originally, or than we would have without them. Another example would be the SIRS programs to actually integrate a culture of mistake management in among institutions of health provision. And also these, one speaks about them, everyone knows them, but actually being aware to say, well, actually this did improve the quality and the costs as very small incremental steps, and which obviously still have many options how to improve them. In this context, I would also definitely mention the case management, just because, again, case management, old, we know that. But for example, now these years in Germany, it actually is gaining momentum. The whole idea that you need a person who is coordinating or who is taking care of the coordination for certain specific patient groups. Excuse me. So we've had this innovation fund. I'm sure many of you have heard or have read about this, which has been running since 2016. And it's actually interesting how various indications are in there that are executing case management projects. And because the one important thing of this innovation fund was that a requirement to be funded through it was the ability to be scaled up afterwards. So actually at the moment we have around 31 projects included. We as a BMC also did a small overview of these, because we said actually no one knows which projects these are, and because there are more than 200 projects overall in this innovation fund. And so we did this survey of running projects, and we were actually quite surprised to see that there are more than 50,000 people in these, only in the intervention groups of these different projects that all get evaluated from neutral, independent sources. So actually I was surprised to say, well, this definitely has a momentum that we haven't had or didn't have 5 years ago or 8 years ago, even though, again, case management was as known then as it is today. And in the end, the principles didn't change at all. So what we do at the moment is also to give them a voice and bring them together, because as usually the individual projects don't really align with each other, to actually say which are the consequences and the knowledge that we can have across the projects, across the indications. What are the principles, kind of where you can say this is together also a right to have access to coordination through a case management. And lastly, and then I'm done with this first big part, the question of evaluations. I definitely think, and this is this mix of putting the phases of actually clinical studies, usually or mainly executed with pharmaceuticals, also adopting these two complex interventions, which actually have been the case much more than originally used to be. So I think, or at least from the German perspective, I can say that in the last years, it got so much more normal, and it was just one integral part of executing projects was to have a professional evaluation with it. One can say that sometimes some projects you also just have to know, or you just know while you're doing it without the evaluation where the strong and the weak points are of it. So obviously you can always evaluate something which doesn't hit the point actually. For example, if usually these are mixed models where you would study, of course, certain numbers and doing quantitative modeling, but also mainly qualitative studies to actually find out not so much is it right or wrong, but what were the individual, the small indicators that led to make it successful or not. So not so much a yes/no response, but more an evaluation which actually helps to learn from it, because you see that you just know to say, well, in this case we decided to whatever, you know, when you have case management, where it's located, or how you fund them, or how you integrate them into the process. There are so many questions which are between this yes or no. So I definitely think that evaluation has become much more professional in the German healthcare context regarding the coordination of care. But also what was the idea 20 years ago, I think, was much more that this libertarian and market-focused context is necessary and advantageous for coordination, for projects, for innovations in healthcare. And at the moment, we definitely see that this, if it's a panel, is just going much more to this state-focused perspective, to say we don't want too much freedom, we don't want too much liberty, let's go for certain rules. So that's, I would say that the belief in the market hasn't become very popular in the last 10, 15 years. So what about the future? I have a few more minutes to say, so this was now all, why does she always speak about the, you know, past 20 years? But I do believe that, of course, this year will certainly change through Corona, through the experiences, through sometimes just needing to be fast and yeah, having some more courage to try different things. But I think mainly there are three tendencies, I would say, or three arguments why it will go on. The one is that we, especially currently, see that we don't run so much short of money, especially in Germany. There are different countries, of course, but we don't primarily at the moment have a financing problem, but even more a staff problem. So just two numbers, for example, the average time that nurses for the sick and elderly stay in their jobs is 8 years. So we school all these nurses, and at some point they realize that the job is actually really not what they expected. So that's also what they say, that 50%, so half of the nurses state in studies that they would not choose the job again with the knowledge they have now compared to what they knew before. So this is a map, for example, where you see how the German number of nurses as well as physicians. So you have the physicians on the x-axis and the nurses on the y-axis. And you see that Germany is doing great, but this is per capita. So per capita, we actually have lots of staff, and it also increased in the last years. And this chart looks very different when you actually do it per patient case. So it was a learning for many of the German healthcare people, I would say, just because there were some big studies from Professor Busse, who I wrote my PhD with in the last years, just showing with Bertelsmann Stiftung that actually maybe it's also a problem of how many cases that we have and in what way our incentives of financing and so on put an incentive to actually have many cases, and that even though we have so much staff, it's actually very little per patient case. And also, I want to just show this very short difference, because obviously everyone has these baby boomers. And until now in German healthcare, we speak about these baby boomers very much as we will need more staff, which is definitely true, but I think it's only the first part. We will need more staff, and then suddenly we will have all the baby boomer generation also will be gone. So what actually it means is that we also have to become more flexible. I mean, I'm sure when once that we have more staff, we will also know how to use it. But it's not only to say we need more, but we also have to be faster in making it flexible and maybe having a wider understanding of how to actually tackle such an issue. And therefore, for example, last year we had Cities Changing Diabetes as a guest to one of our conferences, because we said it actually changing and flexible structures are much more than just saying we need more staff, but also looking at the challenge as a whole. So that was the first reason why I think things will change, just because they will have to change. And this is also quite connected to another topic which belongs to this overall question of staff and personnel, which is this different interests and different perspective of healthcare staff today in the majority compared to earlier. You realize how careful I am, because you see that I'm below 50, as you may guess, and that's the very young ones in the German healthcare system. Everything above 50 is normal and below 50 is young. So, and I didn't like this whole idea of saying, well, the generations and they have different expectations. And you do see that the way we think and we offer services just doesn't really align with the reality of many people anymore. So this, for example, is a survey among, in this case, it was physicians, and it was men, women, it's everyone, on what are the largest criterions to command a job as a physician. And I was actually surprised to see that 91% say a good compatibility of job and family. And that doesn't mean, and that's very important to me, that they are lazy or only go on holidays the whole time. But for example, it means that many of them together, that many couples and many more than 10, 15, 20 years ago, that the couples together have responsibilities for the family and therefore are not as free to say one is 100% free in taking over hours every day he or she wants to, while the other one is really taking care of everything else. And then professional success is the second one. But it was definitely, 20% different on percentage points, different compatibility, and professional success is definitely not what you would see in our structures with how you can actually get a physician job. So here you see that from which jobs are actually compatible or family friendly, that it's mostly to be employed in a network or in an outpatient center, also to be owner of a network or outpatient center, a little bit less to be employed in a private practice. And on the right, you see that overall, the numbers are a bit old. I couldn't get new ones now quickly, that the number of physicians employed in outpatient care are roughly 30,000, which is basically nothing. It's increasing. That's the positive part, but it's still very small. So maybe it just doesn't fit to the expectation of our educated people. And then, as I said, there may also just be some other principles that are important for certain generations. For example, the company identity, the flexible working forms, compatibility, as I mentioned, but also to the personal opportunities. Because what I definitely believe is that we used to have a time where one could just have the structures you had, and you always had enough applicants. And that definitely changes. And I think it's interesting how long it takes for us to really digest it. And without saying that we have to follow any wish of the applicants, I'm far away from that, but to just see where structures can actually be also beneficial for the staff, but as well for the patients. And so I think as a third part, and then I'm coming to the end, is this whole issue of digital health, which, as you just spoke all the day about that, I thought I will put it as the last aspect, because obviously it will change and influence the way we can and will coordinate processes, and just also the focus of the topic, I think, has increased a lot. This is, maybe you all know, our great position on the Digital Health Index that Bertelsmann Foundation did last year. So you see that both regarding policy activity, but also digital health readiness, and also the actual use of data are all, one can exploit it further, one would say positively. But one has to say that especially the current Federal Ministry of Health that has been in power for 3 years really focused on the topic and did a lot to at least ease the way into the right direction. And it's so, for example, with the electronic health record, with the reimbursement of medical apps, with the telematic infrastructure. And we just currently asked, sorry, I forgot to translate this part. We asked all our members, it was overall 711, I think, participants in the study, in what way digital, the current health policy increases or fastens digital health, or whether it slows down digital health. And I was actually quite surprised, because usually we have a very critical mass of people, obviously, but I was surprised that this going forward, 61% of the interviewed said that the current health policy is either fastening or fastening digital health very strongly or strongly, which I think has really quite an impact to say maybe it is getting better, at least from the regulation and the requirements. This doesn't mean yet that it's executed, but at least from what you can do. But also what these red dots are is the acceptance of physicians, which from, again, the study, it was the most named challenge that we currently have with digital health, which I find quite interesting, just in a way that maybe also we have to focus on other things than only technical issues, but more bringing actually this trust and the belief into the field. Because, funnily enough, patients and physicians are the ones that are supposed to profit most from digital health. So you can actually get user cases out there, because people expect that these are the fields which are with the most profit. So I think we have said again, we shouldn't too much focus on technology or finances, but especially on the attitude, because at least for the German healthcare system, that's where we are currently working on. And that's also, I think, the only position you have to change in order to actually gain momentum there. So this is just the last slide to show our German healthcare, the digitalization in comparison to many other areas like telecommunication, like trade, like finance instruments. And I think it shows very nicely that it's not an overall German thing, for example, not like digitalization or so, to actually just say there have to be user cases and it has to be obvious how to use it, and there have to probably also be market ways of how to market them, and then it will be they will support to the whole coordination. So this is maybe the conclusion, that we will go to that we are going to this more state-focused system, but it will have influences through the staff, through the expectation to work interprofessionally, and through the possibilities, but also the requirements of digital health. Thank you very much. And now I'm looking forward to maybe 1 or 2 questions.
Thank you, Patricia. Before I forget it, so all my greetings to Professor Volker Amelung, the chair of your board of the Bundesverband Managed Care. So we worked a lot together. We had a very good time, and we also worked on the paper which is published, where we put all the different care coordination systems worldwide together. I think it was also nice work together. I'd like, before I go to the questions which I hear from the audience, I perceive, and I will come, I don't know if it's also your same impression, is that in Germany we are a lot stuck in pilot projects. So we are in the pilot hell, how to call it. So let's do a pilot, and then they did a pilot, they burned money, nothing happens. Is it the same impression, or?
Yes, it definitely is my impression that we definitely have many of them. We have even many instruments that always create further pilot projects, even if they have existed before. that's one of the problems, that I think this whole culture of learning from each other, shopping for ideas, just going through and saying, oh, that's interesting, I want to use this. This is good, I need it a bit differently, but I will take this as well. This becomes part of finding new ideas. I think that definitely is too little. But I also sometimes see that I think the focus of how we describe our projects is also maybe sometimes wrong, in a sense that I do see when I listen to presentations from other countries, which often also not yet have the entire country and every patient and every group included, but at least presenting it from the positive side. So I do believe that we are stuck with pilot projects, but sometimes it's also good to be confident of what we achieve there and not so much focus that there are maybe 20% others that we haven't achieved through it. So I think it's maybe both parts of the coin.
You have done a, let me say, retrospective, but very reflective view on that. And I'm happy because I saw on one slide that at the project, and forgive me, I'm much more than 50, so it's not below 50. But also, and I will give also the question to Michael and Nick later, I'm very happy to see that these countries where I was involved in is Canada with Canadian Health Infoway. I don't see where Singapore is, but definitely Denmark, where I worked with Hans Erik. So they are on the top. And as I said, my home country is Germany, and here I really failed because of this pilot hell. And that was only a comment. I see, and this is one of the slides where you said it's about attitude. So I think this is also about attitude, how you formulate a project, how you see a project. If you see it as a pilot, then it will stay a pilot. So yeah. if very declarative aspect is it's a pilot, then it's a pilot. So it will never change. But if you see as a, let me say, if you take a different wording like proof of concept or something like that, and definitely after that, do the next steps, that will be the right things. And this is that how I worked in the other countries, because I'm not a fan of pilots. So, but let me give this my impressions first to Michael and then to Nick about this.
Yeah, I mean, I have a concern. You know, we have in Europe, and again, I'm not trying to be geographical too much, but we have a very well-educated population, very inventive. But what mechanisms do we have in our economy that takes pilots and then converts them into products for the market? And I have a real concern about that. I think we failed to do it. You know, there's been a few notable exceptions, maybe like Airbus as an example. But in Europe, we have no Oracle, no Facebook, no Google, no Microsoft, no mobile phone manufacturer. Doesn't matter what, you know, and yet many of the ideas for these devices come from Europeans, you know, the first digital computer and all the rest of it. We don't seem to have a mechanism to take concepts through to delivering it to the market. And I think we need to analyse that as why we don't. You know, it's politically safe to say for politicians to say we've given X million for research, but then we don't build on that. And I think that, you know, that's not good for our continent. Really, I don't.
Yeah.
Sorry.
Yeah. Nick, what?
Can I mention something?
Yes,
because
please.
I definitely agree, and I think the interesting part is that even regardless of where the ideas are coming from, it sometimes seems to me that in healthcare we don't really think of the business model. So there are these projects, but no one really thinks about whether anyone is interested in executing them or in implementing them. Which means that, for example, let's take telemedicine. Of course, there are these projects where they are, reimbursed, all fine. Then now this year, or more or less, but at least you can do the projects and so on. And then this year, when actually you thought there were all the reimbursements changed so that everyone could use it. And nonetheless, no one does, because why would anyone? Let's take an overcrowded family physician here in the middle of Berlin. They have enough patients. They are just waiting there all day to get the 5-minute slot. So why would they start to offer this? Obviously, it has lots of impact for the patients, but I think this whole, like, who actually needs to either have an advantage through it, or it just has to be mandatory. I think sometimes when it really has to decide that market is great to start things, but then there has to be a business model why people start using it. Otherwise, I don't see how to convince them, or to say you don't have a choice. Please, tomorrow you have to offer this and that. Fine, that's also an option.
Nick.
Thank you very much. I think also in looking at all the presentations that you can see a lot of knowledge is there and experiences across the globe. So we know how to fix things that we already knew a decade ago, and we have these projections on developments, and so I have the impression we slowly getting the stage that the systems are beyond repair, because the opportunity to really anticipate and prevent collapse and really huge problems in managing these issues is over, accelerated by COVID, but also this we forewarned governments. So besides, there are some things, ideas how to fix things. We probably will stay in a sort of crisis mode where we just have to make very strong decisions and actions to make things still running. So despite all this knowledge and reviews and meta-analysis and etc. on what to be done, probably we are at a stage, and also my country is an example where we have so much knowledge and resources available, but not able to really change things. It's that we have to think about the sort of next stage on what do we need actually to make the most basic sort of care processes still running, considering the challenges we have. And this is maybe also something to think of so what can we still save in the current context? And who should be doing this? Who should be engaged? That would be an interesting question.
Yeah, definitely. Especially because that's also what you, Michael, mentioned, this whole idea of how do we actually have to participate together in order to firstly create new issues that are maybe another model than, for example, solutions coming from the States or coming from other countries, but also in many ways how to get the markets together to serve as a platform, as a network. For example, I often see it with digital health solutions. There are so many that make so much more sense when you can use them across the border, or but not only that, there are so many when it comes to genetic testing, where it's only a question of the number of tests you actually have in the database and so on, where I think it's so sad because, when I maybe with a short example, when I became CEO of the BMC, it was half a year before the data protection, what's the English name, came into force. And so in 2017, I arrived, and then I had half a year to prepare.
Yep.
Say again?
The GDPR, do you mean?
GDPR, yes, that's the English acronym. So, and since then, and I'm actually still, I must admit, I'm a fan of it, actually. I'm a fan of it that it's European, and I'm a fan of it that it has strict rules. I just completely disagree with the way it is implemented, because often it is used as this big excuse for everything. I mean, for example, for using Zoom as a tool for a conference, which where I'm really quite interested in the patient specific or person specific data questions you have there. And I think at the moment, sometimes it seems that this data protection is just a good or a bad argument, but an argument against anything. And I think that's really a sad thing, that we don't use it as a source of ideas to say, well, patients have certain rights, the social health systems have certain rights, and we need to have an innovation that works on top of that. But to just say, therefore, nothing is possible. And
like an excuse, yeah. Like they always say, like an excuse, and I also perceive COVID always as an excuse for everything. We need
sorry, no, that's okay.
To go. Let me say, but I have one question which is really thrilling here, and I'd like also to see your view on that. Is, do you think that healthcare has to fear, let me say, healthcare in Europe or generally, has to fear a disruptor from outside? So such big tech companies like Amazon, Apple, IBM, or others.
I think this could be an option, yes. I think that probably not healthcare, but I could imagine that they go into one part of it, or, you know, like start with one field of it. Or offer either offer a health insurance or offer a group of service providers, or do whatever. I do believe that we have our regulations. German healthcare is especially very regulated, but they could disrupt the whole system, definitely. And depending on, at the moment, I must say it's getting a bit better. Some years ago, when, for example, regarding digital health, nothing happened except for debates. Sometimes I thought maybe, you know, sometimes there can also be positive impulses through such a disruption. So I'm sometimes not even sure whether, like, sometimes when I see what we are doing to some of our patients, I just hope that it's better than what disruptors would do.
Yeah.
No, I don't think so. It's mostly wishful thinking, and I fear more that it will be used as an excuse by leaders to solve their problems. And we know that it's maybe a part of the problem, but it's not the problem for all the other aspects which are needed to save healthcare and societies. And we saw also many negative effects of these platforms in other sectors, and our recent studies also show the potential exploitation societies on the expense of health of people and costs. And I think we shouldn't be too naive on the sort of good-willing intents of businesses, and we need them obviously, but we have to balance this well. And looking back to the other sectors, all the examples we saw, investor-driven, profit-driven companies is not a solution in this way.
Michael?
I think, yeah, what do I think? Good question. I think we're in the political territory here, to be perfectly honest with you. I think there's always that potential for an external disruptor, although if one looks at the American corporates like Google and Microsoft, who, you know, some years ago got into electronic patient records for the individual. I don't know if you remember those initiatives. And I remember, you know, Microsoft buying a system from Thailand that
failed, yeah.
Yeah, they didn't succeed. They could have done. The Amalga product was very good. It was developed by Ross Perot and his team, although it came from Thailand. Excellent product, but no longer effectively exists. So they don't have a history, I think, largely because of the complexity of healthcare. I think my own personal view, I'm speaking of myself, is that they address it like they were addressing some other industry, and that healthcare is infinitely more complex. And so I see the potential coming from China, potentially, much more likely in healthcare than perhaps from the United States of America. And let me give you some reason for my thoughts. Firstly, when one looks at how COVID has been dealt with, when one looks at Taiwan, China, and those areas, South Korea, for example, we see they've been relatively successful in doing so, where perhaps Europe and America have not, the United States have not been that successful in spite of all their tech companies. So again, but politics plays an important role, and the United States is very dominant. I just come back to the issue. I'm old enough to remember President Mitterrand of France when we first had Europe, and we were greatly hopeful that the Project Eureka, where we would have such industries as healthcare across Europe, car production, so that we could compete globally, European companies, machine tools, all those areas, computing, for example. Unfortunately, it never happened. And I really think that, and I want to keep on, but I really think Europe needs to come together to actually have leadership that actually ensures that we develop these technologies so that we can sit down with these other nations at the table and share our knowledge and experience and markets. But at the moment, the opportunities for our young, the opportunities for our economy are not good in Europe, and we have the potential to be much better, I think. And so that's my honest view. I think, one of the things that I've found, sorry, just to finish off, but whenever I've gone around the world, the number of countries that look at the NHS England and what we publish every year, it amazes me. And yet, we don't seem to sort of build on that. And I would like to see that as a pan-European initiative, personally.
Thank you, Michael.
Thank you.
Yes, but important is, and I think the complete work, even also the GCCCF, also for the Bundesverband Managed Care, is not to exclude the politics. So we need to work with them. We need to include the ministers, the regulation bodies, the governmental bodies, and we do so. I think even then, it's let me say, it's a challenge. Let me say this. And if I wrap up, and that was also, if I go through that, what we through our day today. So when I started with Chai Chua, so I had a lot of discussion. Also, the transformation of New Zealand was very, very much deep discussion with Chai, and also as he also a little bit spoke about that, it's important that you be, especially in a country like New Zealand, to be accepted, to be seen as a friend, to don't. And I think Chai was exactly these leadership principles, what he brought on, he really lived that. And I think this is why we were so successful in New Zealand. So then we, our next speaker was Amin, His Excellency Dr. Amin Alamiri. I think he has also the different challenges, and he also, let me say, highlighted that it's a different political system, but they have a ruler, and I think, and they have to manage a lot of let me say, different nationalities in these countries. And they do it also very successful. And I think they're also working on the transformation on the healthcare systems. And the next was, and then we went directly to Professor Paulus Kirchhoff, and we took one of the biggest burdens and then the cost driver, it's stroke. So, and combined with Thomas Hübner, who is really very brave with his company, the CEO of the company, to go through this regulatory health of Germany, to fight and to also engage on also the investors around him, to fight and to be successful. And I think this resilience or this persistence is very, very important. And sometimes I miss it in Germany. So if you start something, so I learned it as a child, then finish it. So I think in Germany, sometimes we start something and then, okay, I do not want to comment it, we discuss it, we somewhere nowhere. But even more, such institutions like the Bundesverband Managed Care or the GCCCF and also the community, I think that's what we are here, is important to not only to discuss it, also, and Patricia said that we find the people who are really delivering, who are really take it as their project and finish it and drive it forward. And as I said, these countries where I work of, it's a part of attitudes. It's a little bit different attitude. But one thing, and on the attitude of the Germans, is they are very, very accurate. It's very, so from the other side, the Germans are the blueprint, for example, also for Saudi, for UAE, for a Russian Federation, for all over the world, because they are so accurate. Okay, they need longer to decide something, but then it's 100%. And when I see that companies like Preventicus did this 100%, and then they get the seal that they really can go forward, I think this is, let me say something, what needs to be also highlighted. So, and Nick, no, first it was, yes. Then Nick, I think I also monitored this active healthy agents project for long years, and you summarize it in really thrilling area. And let me say, do not said that everything is nice, because it's not, and also make a very good reflection on that. So I will hear also about the German breakout session, how it went. And I think I heard there was around 35 people participated, so it's all Germans. And we intentionally have done that to be a German-speaking session. And then it was Victor, and Victor showed, and also in a, let me say, very clear manner, how the attitude of the country of Poland, of the Republic of Poland, is that they also start something, look at the right thing. And as I said, e-prescription is very, very good to start with, because nobody wants to go to the doctor to get a piece of paper only to get a medication. I think in these times it's a good start. And then all the other things like e-referrals and so on, and they will develop a lot of other things. And I think the structure in Poland is also more simple than ours. They have the National Health Fund, they have the e-health services, the e-health center, and I think it's, let me say, more governmental structured and sometimes easier to go through it. So, and Hans-Erik, so he wrote me that he needed to leave. Hans-Erik, yeah, as I said, we know us for a long, long time, more than 20 years. I think what we have done, and also the Danish people with their pragmatism and with a clear definition of a project, and they never said about something about pilots, as I remember. So very clear definition and way forward. And it was not easy. It's not like, it's not that there was no discussion, there was no resistance, but they worked on one important aspect, and this is acceptance. So acceptance of a healthcare system, of modern healthcare system, acceptance of these technical aspects, and also acceptance that they really, and what they have done, they crashed down hospitals, built new one in their aspect. So they had a master plan, they had a plan. So that's very important thing. And then Michael, so I like your approach that you, first of all, recorded this, because yeah, it makes you now in the discussion more relaxed, and it's very good. And I think, and that I would like to stay more and also with the other people more and more in the discussion, because the question, and this is that what still is not answered so sufficient as I like, oh, look at the website and there's a lot of initiatives what the WHO have done. So I think even the WHO needs to start with something also to fulfill it. And I think this is, you can rise a lot of things. It's easy. But to deliver something and really to make something happen, this is another thing. And let's have a continuous cooperation, how really the WHO can play a role, which is, I always say, make this planet a better place. Yeah.
Could I just ask that after this meeting, I'd really like to stay in contact with with the different people, Nick and so forth. And the guy from Denmark and Patricia and yourself.
This is the aim of the GCCCF. You are one of us. You are connected with us. You will receive all the contact points. And I would wish that we can discuss the next 20 or 30 hours more. But I think we can do. But let's do it bilateral, trilateral, or also in a roundtable, and we will proceed with roundtables. And important is that we bring something and we have a plan, and let's work on such a plan. And
yes, right.
Yeah.
I just wanted to thank you and your team for organising this and for inviting me. It's been really, really interesting for me, and to meet new people in Europe facing the same problems and challenges. So I'd like to thank you and your team very, very much for all your efforts on this. And I'd like to also thank the little team at NC3 who've made this thing actually work and look after us and keep it all going. So thank you very much indeed. God bless you.
And Patricia, you was not between the weekend, and I'm between the weekend and all then, and all the people are now waiting. Lupo, please come to the end. I will, but let me say that also the Bundesverband Managed Care with you, Professor Amelung, and all the teams really did a tremendous work to highlight where the pain point. But now let's be, let me say, more in the area of finalizing things, and also get the people and do it with them. And fortunately, we have now in Germany for the federal ministry someone who is really driving things forward, and not only discussing. And I know it's not an easy task. I think to be a minister of health is, I think, the biggest challenge of everything. And so important is really to say, and that's we need to work together, and also to support each other. We need to support also the investors who are believing in this healthcare aspect, because what we never, and Patricia, as you said that, if there is not a business plan, nothing will happen. Because everything is depending on the business plan. That means not only from the commercial perspective, it means also from the, let me say, from the ethical perspective. Because ethical would not happen anything when the people who are working hard on something don't get a reimbursement for that. And I think this is also what in a lot of countries I miss a lot. Because also these brave investors, these brave CEOs and founders of these innovative companies are living because it works. And that means regulations are important. They have to support. They have also to protect also any intrusion from other side, but it has to work. And I think, yeah, these are my let's call it a day. Thank you very much. And normally I ask everybody how he feel after such a day. So I would like to ask you, Michael, so you wanted to say some more words. And
I'm kind of excited, and it's a pleasure for me to meet people across Europe. I know that we're outside Europe at the moment, but I don't see that as forever. And I just really would like to see a European initiative.
Yes, but don't forget, as I said, don't forget, I see it worldwide. That's why it's a global forum. And I would not exclude China, Australia, New Zealand.
Oh, I'm not. I mean, please don't misunderstand me. I'm very pleased. New Zealand's done some great work, Canterbury, New Zealand, with, integrated care and the pioneering work in China. I'm not excluding them. I just think we can help the world. You say make it a better world. We can help the world with our abilities to develop those technologies. I mean, I'm working with China already. So
I will work with Nick more on the European initiatives, and also the Bundesverband Managed Care is very involved in that. So saying this, everybody, friends, GCCCF communities, if there are still some excellencies online, thank you very much and see you soon.
Thank you very much. Thank you all. God bless.
Have a nice evening. Bye.
Bye. Bye.